live.
You give a countdown, huh?
So start your live. Start.
Can we?
Yeah, Mr. Burman.
Yeah. Good evening, everyone. Good evening, everyone, and a warm welcome again, once again, for this webinar. This is of seventh of its series,
मेरे
and
साइड क्यों
again
आ रही
we
है
have
फोटो?
galaxy of speakers today.
अब सामने आ रही है?
We have our main
हाँ
surgeon, Dr.
हाँ.
Satish Jain. We, am I audible?
Yeah, you are audible. Very clear.
Yeah, yeah. We have Dr. Satish Jain, and we have our guest speakers today from Australia, Professor Richard Harvey and Dr. Professor Sethi from Singapore. Along with that, we have Dr. Rajiv Pachori, who has made this webinar series possible. And today we have one more special guest, Dr. Rajan Bhargav. And we have a very dynamic young Dr. Parmita from Mumbai, who will be as be a moderator today. Again, I wish to assure you on behalf of Sun Pharma, then you will have a very good webinar today, and there will be a lot of take-home messages.
इधर ही लाओ जो मैं
And
इधर देखता भी रहूंगा और इधर ये भी हो जाए.
Sun Pharma is committed to this academic orientation programs always, for all the, especially for the ENT specialty. So with this, let me hand over this session to Dr. Rajiv Pachori. And before that, this is once again Mahendra Varman from Pharma Marketing, Division of Sun Pharma, which is handling with the products like Cipodem, Receiper, and our
क्या नाम है?
Montec
पेशेंट का
Express.
नाम क्या है?
Thank you very much. Thank you, sir. Over to Dr. Pachori.
Good evening, all my friends from India, from abroad. And this is our sixth meeting for Explore Legends. And we are explored so many legends till now. And our master is Dr.
Seventh,
Satish Jain. Welcome, Dr. Sethi sir. Welcome, Professor Richard Harvey. All my team members. Thank you, Sun Pharma, for this wonderful platform for this academic feast. And today it's a surgical, live surgical evening we have. In fact, we can say for 5 or 6 hours. And I think we have three, four cases. Angiofibroma is there, carotid body tumor is there, osseous fibroma is there, and revision pass is there. Regarding the angiofibroma, we all know that it is the surgery. I think I am in practice since last 18, 19 years, and I have seen all the phases. And I think most of us would be in the same phase. I have seen the transnasal surgery, transpalatal surgery, little rhinotomy incision, and you can say finger dissection of the tumor, including the Dr. Sardana's technique. Now, slowly, in last 6, 7 years, we have come up to this stage that we can take out angiofibroma of any stage purely with the endoscope. And that is just because of the legend sitting in front of us, Dr. Professor Sethi, Dr. Satish Jain, Dr. Harvey, and so many other seniors. They have taught us regarding this surgery. And now we proudly can say that we can take out any angiofibroma, any osseous fibroma, any lesion of the head and neck, or means you say sinus or perennial sinus with the endoscope. And today is the one more demonstration of by Dr. Satish Jain regarding the endoscopic removal of angiofibroma. This is very extensive tumor today, and that's why I requested everyone to will start as a first case. And I think starting we have logged in more than 3,000, 4,000 people are there. So I will not more time, and I think we should switch on to Dr. Satish. Anything from Paramita from your side? So next 5, 6 hours.
Yes, so welcome everyone. We have quite difficult cases today, but our master will make it easier for us step-by-step discussion, and you all are free to ask any questions, whether that be silly, difficult, any question. We'll try to utilize this time as much as we can with discussing these topics. So I think we'll move on to Sir Satish sir. Good evening,
Thank you, Paramita. Thank. Am I audible?
Yeah, very much.
So good afternoon, everyone, and it's a pleasure. It's a big day for us to have some masters today with us. You all know Professor Sethi. He's our own. He doesn't need any introduction anymore. He is the one who propagated all these endoscopic concepts in our country way back for last more than 20 years. And he has been a part of our webinar, and he is like father figure for us. Thank you, sir, for being with us. And I'm fortunate always to have a teacher like him who has been guiding all the time. And a big day for us to have another genius, very favorite, my favorite, Professor Richard Harvey. And this man, as I mentioned in last cadaveric dissection, what he has given to this world, to the endoscopic surgeons across the world, is something beyond imagination. This man, for a brief introduction, it's a pleasure for me to introduce him. I cannot, if I speak about what he has done in his life, our whole day will go on speaking about him. But in brief, he is presently associated with the University of New South Wales and Macquarie University in Sydney and his St. Vincent Hospital there in Sydney. He is a prominent endoscopic sinus and skull base surgeon over there. And you know how academically oriented he is. He has more than 250 publications, and one of my most favorite book he has published for everyone, and I must always recommend everyone to go through that on the concept of endoscopic sinus surgery right from the molecular level. We have been so fortunate to have him in Jaipur for a skull base workshop. In India, when Gaurav organized in Bangalore, he was there to demonstrate some amazing cases. And he has been organizing so many courses across the world. And another thing which is we should know, I want to tell everyone, he has been the editor-in-chief of one of the most, I would say, remarkable journal. I love that journal, the International Forum of Allergy and Rhinology. That's the American Rhinology Society journal, which I consider to be the best in the world. So thank you, Professor Harvey, for being with us. And I request audience to, I believe me, will be benefited by his presence, his comments, his suggestion, and I request everyone to make most of his presence. Thank you once again for being with us. So this event, Professor Harvey, this event we have been going on, this is the 7th edition of this webinar. Some of were the lectures on the concepts, some were cadaveric dissection, and some were live surgery. This is the 3rd live surgical session. And I am indebted to Sun Pharma for their wholehearted support in organizing this event. And the mastermind behind this event is Dr. Rajiv Pachori, who has put in everything to organize this event. And you know the pillar behind this, Dr. Paramita, who have been working so hard day and night to make this event successful. So thank you once again all. And before we start, let me introduce our own Dr. Rajan Bhargav from Kanpur. Dr. Bhargav is an All India Institute Fellow, the prestigious center of our country. He did his MBBS, MS, post-graduation, then senior residency, everything from AIMS, and highly academically oriented. Has lots of publication, has a special interest in endonasal surgery, and he goes beyond to the sinuses and does everything. Thank you, boss, for being with us, and I'm sure we'll have a good time with all these legendaries today. So
Satish, can I just say something?
Yes, please. Always, boss. You don't need to ask. You don't need to ask.
Thank Richard for joining us, and it's a pleasure to see you, Richard. Looking forward to your interaction and your comments on the surgery and learning from you. Thank you very much for joining us.
Professor Harvey, you don't need to ask.
Satish and Darren Beer, thank you very much. It's very kind of you to join me, to invite me along. You know I'm always happy to give you my thoughts, whether they're right or wrong, and it's a very kind introduction, especially
That's
coming
what
from
we
you.
want. We want a lot of criticism if necessary.
Never criticism.
And
Please reply to your WhatsApp messages next time.
No, I was going to say everyone has an opinion, and if we have 7 opinions that are all the same here, then we're in trouble. So important.
Absolutely, absolutely.
Thank you, and please feel free to interrupt anytime us and make your comments, your suggestion. Those are most welcome. So, coming to the subject today, the first case of the day we are going to start with is an 11-year-old child who presented with a history of nasal blockage and some intermittent bleeding. He went to some doctor who got a plain paranasal sinus CT scan done. We got the CT scan done. Can you connect the laptop, please? Are you getting my scan on the board? Are you getting the
Yes,
scan?
Yes, sir.
Yes,
So
Yes, sir.
this
Yes.
was the plain CT scan done for that child, looking at the child with a nasal obstruction and some polypoidal thing in the nose. He was posted for sinus surgery, assuming it as enterocoinal polyp. And this is on the another thing is only the coronal section was done, and it looks like something coming from the maxillary sinus going behind, assuming an enterocoinal polyp. Of course, patient came to us, and when we put the endoscope, the mass was quite in the posterior part of the nose, looking reddish, and with a history of bleeding in a young adolescent male, it gives you suspicion of none other than juvenile nasopharyngeal angiofibroma. So accordingly, first thing we ordered was a contrast scan with an angiogram. Once it comes to a suspicion of an JNA, the first investigation to be ordered is a contrast and a CT scan, paranasal sinuses, and we always order it with an angiogram as well, CT angiogram. So I will take you through some of the important findings in this patient, and the same thing I would emphasize, like I emphasized in the radiologic webinar, to see the scan on our own rather than relying on the radiologist. They give all good findings, information, but that may not be surgically relevant to us. Like in this patient, I'll tell you what we get additional information when we look at our own, and what is the additional information this angiogram is giving. Because once it comes to angiofibroma, the everything surrounds around the bleeding and bleeding. So we need to know what all are the vessels which are suffering, and how can we control, how can we plan our surgical approach, because once it is angiofibroma, the only answer is surgery. So this was, let me show you first the tumor. Yes. See, this is the actual picture with the mass completely occupying the nasopharynx, the pterygoid region on this side. Look at the pterygoids on this side. That's the pterygopalatine fossa. You can say where the tumor is going. And this is the axial one. And when we reconstruct in all planes, you see this mass. This is something like on a contrast one. This is the mass lesion. If I come from anterior to posterior, the maxillary sinus is by and large okay, with little bit of the mucosal hypertrophy. And as I go behind, see this mass is centered in the region of the pterygopalatine fossa medially, and as I go behind, this is completely invading the pterygoid bone and going up to the roof and the sphenoid sinus, occupying the nasopharynx completely. And as we go behind, see the huge component in the nasopharynx like a cricket ball. You can see in all planes this kind of a lesion. So first of all, on a contrast scan with this much of enhancement and this much of radiological pattern is classical of a JNA. We all know JNA being a vascular tumor, we never advocate biopsy. Although histology is a very important part of management, and nowadays more and more focus is on histology driven management in the paranasal sinus tumors. But looking at the bleeding aspect, we never advocate histology or the biopsy in a JNA. JNA.
Satish,
Yes.
can I ask you a quick question here?
Yes, please.
Until what age, because I'm with you, I don't do a biopsy for a classic JNA. When it looks like a JNA in a young boy,
Yes.
no problems. I just go straight for treatment. But at what age do you start to say where something grows as a vascular mass in this area in a male, would you start to think that you need a biopsy that, even if it looks a little bit like a JNA? At the age of 20, at the age of 30, at the age of 40, at the age of 50? When would you say that
Yes.
JNA is very unlikely to be the
Yes,
diagnosis?
that's a very important issue. To me, age is not an issue. If it doesn't look like JNA, I'll tell you the reason. I will take biopsy even in a child as well. Because
Yeah,
there are
but at what when it does look like it's possibly a JNA, when would you actually choose to biopsy it? What age?
any age. If I have a doubt about JNA, I'll take a biopsy.
Yeah.
Okay. Now, why I'm
But
saying
what
so?
age, what you're not answering my question. What age do you become suspicious that it's not JNA? What age? It looks like JNA. But how old does a patient have to be before you start to say, maybe I need a biopsy first? Maybe this is not a JNA, even though it looks it endoscopically.
Yes.
Looks it on CT scan.
Yes.
What age do you start to be suspicious? And I tell you why I asked this, because we just had a case.
In very, very young, obviously in a very young, below 10 years, and I mean the adults, you can say about 20, 25, when you don't expect JNA to be the first diagnosis. Obviously, you can think of taking biopsy, by and large. But
like a 45-year-old man, you would
obviously I'll take biopsy. Obviously.
Yeah.
Obviously, there's no doubt about it. Why I'm saying so in the JNA? The diagnosis of JNA is almost always confirmed by certain characteristic radiological signs. What are those? Since, look at this axial, let me tell you, this JNA typically starts in the region of the pterygoid wedge, typically. In the region, in the anterior aspect of this pterygoid process. And from here, it spreads circumferentially with some predilection to certain areas. That is how it is diagnosed. So it has a preference to go laterally to involve the pterygopalatine fossa, and through that further through the pterygomaxillary fissure into the infratemporal fossa. It is a preferential extension. Preferentially it goes behind to the posterior part of the nasal cavity and nasopharynx. Preferentially from here it goes behind to involve the pterygoid process. See how this is patient has a complete involvement of the pterygoid bone, completely destroyed by the tumor. Though it is benign, but it has a tendency to erode locally. It behaves aggressively locally, in spite of being behind. So it has a typical pathway of extension to the pterygoid process and destroy it. And from here, it goes to the sphenoid sinus. From the nasopharynx also, it ascends to the sphenoid by means of eroding the roof. It never enters the sphenoid through the natural ostium. And from there on, it goes up to the middle cranial fossa, to the orbital fissures, to the cavernous sinus. So it has a predictable pathway of spread most of the time. That's how it is diagnosed. So to me, the clinical history, a young male with a history of nasal obstruction with a mass behind and history of intermittent bleeding with these characteristic sign is almost always a JNA. That is how you can diagnose. In any case, you have a doubt. Looking at all these parameters into consideration, in spite of that, if you have any slightest doubt, then you can think of biopsy. Age obviously, like you said, is important, but to me it is secondary. All these features which are classically pertaining to the JNA, if they are missing, obviously you don't have to think twice and take a biopsy. So that's a very important point raised by Professor Harvey, when to take a biopsy when you are suspecting something not to be a JNA. So, having done this CT angiogram, as I told you, along with the contrast CT scan, we always get an angiogram done. We'll come to the concept of embolization, where we are getting done or not, that is different. But why angiogram? See, it is a vascular tumor, and now, like Dr. Pachori said in the beginning, as now with the advancement in the surgical technology, better understanding of the spread of the disease because of the radiology, better understanding and support from the neuroradiologist and the intervention radiologist, majority of the tumors are being taken endoscopically, however big they are, particularly primary tumors. So understanding the vascularity is very important, and for that the CT angiogram is most important. So I will take you through. It is my personal request. I mentioned, emphasize it, reiterate it again and again in my radiology talk, to go through the CT angiogram yourself. Every surgeon who is dealing with a JNA has to go through the CT angiogram himself rather than relying on the report of the radiologist, because it is not the information like radiology says it is supplied by the internal maxillary artery. Important, that is important. What I want more important is how the internal maxillary is entering into the tumor. How the other vessels are entering into the tumor. Would I be able to tackle them before I deliver the tumor? The reason is, in endoscopic, when you take up the JNA for endoscopic, by an endoscopic approach, the concept is, the principle is, you should be able to tackle the vessels first and then go to the tumor to deliver it. Otherwise it will not allow, the bleeding will not allow. So my point is, through the angiogram, when you look at the angiogram yourself, that I'm going to show you in this patient as well. I will see what are the feeders going to the tumor and how they are entering into the tumor. That is most important. The reason is, if some vessel is coming from behind the tumor, I may not be able to control that vessel first before delivering the tumor. That is something to me a contraindication to the endoscopic approach, because how will I control the bleeding before I deliver the tumor? So let me take you through the angiogram of this particular patient. Yeah, I'll start from below. Yeah. Can you see the common carotid artery on both sides? Hello?
Yeah, we can see.
Can you see? This is the airway and this is the thyroid cartilage.
Yeah, we can see.
Why I am showing this? Now see, the common carotid is being divided into two vessels. Can you see?
Yeah.
Again,
Excellent.
let me go back. See, this is common carotid.
Yeah.
I hope it is clear.
Yeah, very clear.
Now it is being divided into two vessels, the external and internal carotid. Now let me go up. We all know the internal carotid doesn't give any branch in the neck. So I'll take 5 minutes before we start the case. Now as I go up, can you see this vessel coming out of the external carotid?
Yeah, very clear.
Let me follow the vessel. Look at my cursor. Forget the internal and external carotid. Follow this vessel where it is going to. See this vessel? See this? Just look at the cursor where it is going to.
Yeah. Going.
This is going in the tongue. Can you see this?
Yeah, lingual.
This is lingual artery. So simple. Now, following this external carotid again, that we have seen, this is the, see another vessel emerging from here. On this side, I am following that vessel.
Yeah.
See this, following this vessel, where it is going to, where it is going to, where it is going to. This is ascending pharyngeal. Can you see this?
Yeah.
Can you see this is going to the tumor from behind? Can you see very clear?
Yes.
Everyone? This
Yeah,
is
very clear.
ascending. I told you this is one of the difficult thing now we have to tackle. Now, another thing. Look at the common carotid again, the external carotid again. As I go up, it is going behind. Behind, this is mandible. And see, this is the branches it is given, the occipital and the posterior auricular behind. And now this external carotid is going to divide into two vessels behind the mandible. See, this is mandible.
Yeah.
Here it is dividing into this superficial temporal,
Central artery.
and this is maxillary. Can you see this maxillary?
Yeah, very thick.
So big, so big.
So big, very big.
See this maxillary artery? Let me follow this maxillary now. See this, where it is going to? See, huge. See,
Yeah.
huge. Keep an eye on my cursor, where this vessel is going to, and this vessel is entering from here into the pterygopalatine fossa. Can you see this?
Yeah.
How this huge vessel is entering. Many a times I can give you so many examples. This vessel was entering from behind, and if you try to look into the pterygopalatine fossa, pushed by the huge mass so inferiormedially, laterally, that it is so difficult to catch. Because this will be the principal part of our surgery. We'll go and catch the vessel first and then go into the tumor. We'll devascularize the tumor first and then go into the tumor. This is one of the principal part of our surgery when we do JNA without embolization. Now there are many.
There is a small question that has come to me.
Yes.
And don't you do a classical sort of a DSA?
Yes, that's an important thing. That's a very important question, and we do DSA once the tumor invades the skull base and tumor involves the critical areas of the skull base. When with this angiogram, if we find there are a lot of vessels coming from the internal carotid system, and when we have a carotid involvement which may require some sort of management. For that, DSA is very important, because once you deal with the carotid, you need to have a full information about the cross flow at the level of the circle of Willis, and you should have a full information about the involvement of the wall of the carotid, and that is given best. The gold standard is DSA. In these tumors which are not invading deeply into the skull base, there is no point in getting DSA done, because that is an invasive procedure. That is an invasive procedure, useful, but that is not required at this point of time in such tumors. Now this was internal maxillary. Now this, as this internal maxillary ascends, here it gives a branch. See this branch, I will show you here. This branch, this branch, this branch going up, and this is the foramen spinosum, where into this branch is going. That is the middle meningeal artery. So once you do DSA, my point is, proposition is for the surgeons to look at the angiogram yourself. You will have a full idea what vessels are entering from here. And not only this, you can have a three-dimensional idea. See this, for example, that is amazing. See this, if I am looking at the axial here and catch my vessel, I will pick my vessel in all three planes. See, this was the maxillary I was showing.
Yeah.
See, this was the maxillary. Now let me pick the maxillary here and come to the coronal. Now in the coronal plane, see, this was my maxillary I caught here.
Yeah.
And now I will get to know how this vessel is. See this maxillary artery, this is arising from the external carotid. Now this, follow this maxillary, follow this. It is giving this branch above. Can you see this middle meningeal?
Yeah,
Going up in the foramen spinosum. See here. And this is the main trunk. This is the main trunk. If you follow this, this will enter. See this? How, at what level? This is when we do dankers, I will show you at what level I will catch this vessel. Now look at the level of the vessel, how it enters the tumor, at what level. See this vessel. See this loop of the vessel. This is the maxillary sinus wall, and see how this vessel is entering at this level. This is the level of the floor of the nose, the level of the floor of the sinus, and at this level of the pterygopalatine fossa, this vessel is running. This is the orbital apex. That's the orbital apex. That's the middle fossa. This is the pterygopalatine fossa. This is the pterygomaxillary fissure, and see how the vessel is entering into the tumor. At this point of time, I will catch this vessel. The same thing I will corroborate during live surgery. My first goal is going to expose this vessel and catch this. I will clip this vessel first and devascularize the tumor. That is going to be my first goal. So what I mean to say, by means of angiogram, we should have a complete information which vessels are going, how the vessels are entering, and the third information, same thing you can see in the sagittal plane also. And the third information what I want, how is the level of the cross flow at the level of circle of Willis. We saw in the dissection on Sunday how the carotid has various parts up to the intracranial space. See, this is internal carotid.
Yeah.
This is internal carotid. This is going in the petrous bone here. You can see. See this carotid?
Yeah.
Can you see here?
Yeah, very clear.
This is the petrous. This is horizontal petrous.
Yes. Yeah.
This is the foramen lacerum level. See this foramen lacerum level? And this is the tumor in the sphenoid. See, very clear. And this bone is quite intact anterior to this tumor. Can you see this?
Very clear.
This is the foramen lacerum carotid, and as I go up, see this? This is the cavernous carotid. We saw in the dissection.
Yeah.
This is the supraclinoid carotid, and as I go up now, this is going to divide into two vessels. This is middle cerebral. Can you see?
Yeah.
And this is middle cerebral, this is anterior cerebral. And see, this is forming the anterior communicating, which we saw in the dissection that day. How the both sides anterior cerebral, see this side anterior cerebral, this side anterior cerebral. How both sides anterior cerebral are coming and forming the anterior communicating. That's a very important part of circle of Willis. And similarly, as we go behind this middle cerebral, see this carotid, as I go behind, I will check you. See, this is the basilar artery.
Yeah.
As I come up, this finally divides into two posterior cerebral. Can you see?
Yeah.
And see how this posterior cerebral is giving this posterior communicating. Prominent posterior communicating on both sides, you see. Posterior communicating, prominent on this side only. See this. This side posterior communicating looks hypoplastic, but this side it is prominent, but still it is a good circle of Willis with good, you can have a reasonably good information. The gold standard is DSA, as was told, Rajan was told, the gold standard is DSA, but in tumors which are not invading deeply into the skull base, when there is no blood supply coming or very little from the internal carotid system, you don't need actually DSA for every case, and this CT angiogram done very well can serve your purpose for all means. Now,
Satish, sorry, there's another one which has come from a friend. He says that if there is a vascular supply from the ascending pharyngeal and IMAX,
yes.
why don't you loop the external carotid prior to surgery?
Yes, that's an important thing. See, any vessel if I loop distally is not going to make any difference for that matter. This is not an end artery. If I clip the external carotid, it is not an end artery and going to give any significant help to me in this controlling or minimizing the bleeding. So there is no point in doing that. Only thing I know, the branch of ascending pharyngeal is coming from behind. That is not as big as internal maxillary. Once I take the internal maxillary in control, I'll be able to tackle that vessel, that much of bleeding from behind, and we'll have a cob later. I'll tell you how we can handle that. So this is about CT scan and the CT angiogram. Before moving further to the surgical part, here I would emphasize on one more investigation which has its own role. That gives a different information which we don't get with CT scan, and that is an MRI. Again, MRI is not required in all cases unless it deeply invades the skull base. But yes, MRI gives you certain information. Number one, it substantiates your diagnosis as you get classical flow voids on T2 weighted and contrast images. That is classical of a JNA, a vascular lesion. See the flow voids. Number two, the most important thing what you get from MRI. I tell you why I am saying so. If you go to so many studies done so far, and we always see the JNA as a tendency to recur. Believe me, this is a benign tumor, if removed completely, cannot recur. Simply cannot recur. If the tumor is left behind, it is going to regrow, and then we call it as a so-called recurrence. It cannot recur, and the maximum 99.9% of the time, the recurrence is solely because of one region. The tumor left in the vicinity of the pterygoid bone or the sphenoid bone, because it has a tendency to invade the Haversian system of this cancellous bone, which is overlooked. Even on endoscopy, sometimes you don't see a tumor and come out. That microscopic tumor residue can be good enough to make a big tumor again. So in order to see whether the tumor is invading this cancellous bone and to what extent, no other investigation can tell you than MRI. And there is a particular sequence of MRI for that. So in sometimes, in this case, it is obviously invading. Many a times you remove the tumor and you don't see any tumor going in the pterygoid bone. Even intraoperatively, it looks like you are cleared. But you don't know microscopically how it has gone inside, and what sequence of MRI can tell you. This is the fat suppressed MRI. A stir image, the fat suppressed image. The reason is, I tell you certain area, you see yourself. Yes. See the region of the pterygoid in this side. This is fat suppressed. It is not contrast enhanced MRI. It is fat suppressed T2 weighted image. See on this side, the entire pterygoid region is enhancing because of the tumor. What normally remains in the pterygoid? What normally remains? Bone marrow containing fat. And on a fat suppressed image, you don't see anything enhancing in the region of the pterygoid. Like you see on the opposite side. See, the opposite pterygoid is dark.
Yes.
Yeah.
The entire fat is suppressed. Suppose had there been tumor, it would enhance. So if it is enhancing on the fat suppressed image, even if there is no obvious tumor on endoscopy, imagine that there is infiltration and you need to drill out the pterygoid, otherwise it is bound to come back. and then we term it as a recurrence. It is never a recurrence. It is always a residual tumor left behind which regrows. Simple, this MRI sequence can save you from a disaster, because a recurrent tumor coming, invading the pterygoid and then going to the skull base becomes more invasive. Now the traditional blood supply to the internal maxillary is gone, and the blood supply is haywire. It can acquire blood supply from any vessel, particularly from the internal system, and it becomes more invasive. All recurrent tumors, so-called recurrences, are more invasive, more difficult to deal than primary tumors, and simply this fat suppress MRI. If you go through quickly, you can get to know your pterygoid is invaded by the tumor or not. It may not be obviously visible on endoscopy or by other means, but this is the only sequence which can tell you. So that's the value of MRI. Besides, it can give you an MR angiogram. Besides, it gives you a contrast picture. Besides, it gives you an additional information on the vessel. So many things. But this MRI is very, very important. I tell you another example when it comes to MRI before we go to discussion. 3 months before, we were referred a case, a child, 13-year-old, complete nasal obstruction, history of bleeding, had a contrast CT scan with an enhancing tumor, and it was all looked like JNN referred for surgery. I have a tendency, once there is a huge tumor, I get MRI done. And in MRI, when I found in a particular sequence, that is diffusion weighted MRI, it changed the entire game. See, this is diffusion weighted MRI. Let me take along with the other contrast picture. Sometime it can change the game. See this. This is the tumor which is enhancing on the axial contrast. This is axial contrast. What is diffusion MRI? Diffusion MRI is a molecular imaging. It truly depicts the nature of the tissue. How come? Because it detects the diffusion of water molecule in the tissue. If it is malignancy, means number of cells are more, there is more nuclear cytoplasmic ratio, there is less water, will be less diffusion. And in a tumor like angiofibroma, which is containing blood, fluid, only water, it will be highly diffusion. And when I got the diffusion weighted imaging, it was diffusion restriction. And that changed my mind to take a biopsy, like Professor Harvey said, when you take. And it turned out to be an nasopharyngeal malignancy. See, sometimes if you take the advantage of the radiology, it can definitely help you improve your diagnosis as well as overall outcome. I tell you again and again, the advancement in the radiology, because it is technology, it is growing so fast, 100 times faster than the surgical technology, and what all we need is to take the advantage of that. The radiologists, the problem with the radiologists and the surgeons is they have no communication, hardly any communication. The radiologists are most of the time blindfolded and they report whatever they see mechanically on the board. And the surgeons, they follow the radiology because they don't know how to read the CT scan. This, believe me, if you start reading scan on their own, make the team with the radiologist to discuss every case. There are so many things by means of which we can optimize our diagnosis as well as result. So before moving into the surgical part, this was something about the radiology which is, I always find which is very, very important in JNA. And reaching to a correct diagnosis, planning your surgical approach. Why I am saying so again? Had I been having multiple vessels supplying to the tumor from behind, I would never take this case by endoscopic approach, because the principle for endoscopic is to go to the tumor in the end. First is to go around, devascularize the tumor, take the vessel in control, and then go to the tumor. If the vessels are coming from behind, how can I go behind the tumor and control them? So that is against the principle. So moving further further, we'll take any question and suggestion. Professor Harvey, what is your protocol? You have been doing so much of JNA. I remember last time he was in Bangalore and he demonstrated a JNA. So what is your protocol in, anything different you do in workup?
Yeah, except the JNA you gave me, Satish, was 4 times this size in a child half the weight.
Yes.
You know, that's what I remember.
I remember.
And with a common carotid post-embolization shoot that showed that there was still great blood supply through the whole thing. That's what I remember from it. Now the only thing is that if you want to go back to your CT scan, I'll show you there's one thing that I think's important.
Yes, 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 please.
Go to your CT.
Yes,
go
yes,
to your,
I am coming.
Go to your multiplanar view post-contrast.
Yes, yes.
You touched on all the things that I would have talked about.
Yes, I will take to multiplanar. Yes.
And actually, let's have a look at that coronal. So scroll through on the coronal.
Coronal.
Forward for me.
Okay.
So maybe enlarge it for me, brother.
Yes.
And enlarge it for me. Make it a little bit bigger.
Okay.
Good. Okay, that's better. Okay, scroll forward now. A little bit more forward. You said all the right things that you know, JNA is a tumor made for, and mate, stop there, come back. Stop there. So JNA is a tumor made for endoscopic excision. You know, it starts in the nose, it's got a thick capsule, it pushes everything apart. And as you said you should get the whole thing out endoscopically. It comes from the nose. It creates the corridor in which you can do the dissection. But it is nice to see how it gets up into the cavernous sinus and the cranial space. I've never seen an intradural JNA.
Yes.
In my opinion, I don't know if you can say that. I've had cases called intradural on radiology, but that was.
We have seen couple of cases, but not primary. All revisions.
Yeah. So I think in primary case, I think they're mainly
extradural. Almost always extradural.
So just one nice thing to see here that what's worth looking at, I'm really aggressive around the JNA, around the cavernous carotid and things, but when it comes up the infraorbital fissure, and you can see on this scan, on the ipsilateral side, there's a little fat plane between the orbital apex and the tumor. Just there. See the dark fat plane?
Yes.
Yes.
Yeah, that's it. You got it. Yeah, just seeing that is very reassuring, because you know then that's going to be really easy to slip into. You're going to see that free fat. You're not going to have a whole lot of muscles and things exposed, you know. And I think that's just a really nice thing to see. I mean, you know that you should find a little ball of fat when you do your operation here, and you'll know that then that you're coming up towards the inferior part of the orbital apex, because you've got that fat that's from the infraorbital fissure that's been compressed there.
Yeah.
That's my main one. And then just on the axial, just go back to the axial.
Yes.
Enlarge that for me.
Yes.
You pointed out all the classic features.
Yeah. It is not going far laterally.
Yeah, that's okay. Just scroll up for me a little bit, or scroll down, I should say. There you go. I think just up there. So just people who aren't that familiar with JNAs, you know, the widening of the pterygomaxillary fissure here is a giveaway. Can you show everyone how the pterygomaxillary fissure on the ipsilateral side is twice the width AP than the other side?
Yes, exactly. This is the opposite side, and what he's saying, this side it is widening.
It's really wide. And although you said there's lots of characteristic signs, if you see something like that, there's very few.
So do we also see the internal maxillary artery of the opposite side then?
Yes, I can show you.
Because that is
I can show you for the reference.
And sir, for the juniors, you can also show us the Holman-Miller sign.
Okay, that's what Professor Harvey was pointing out.
Yes.
The widening of the. Let me show you.
Yes, sir.
So first of all,
the Holman-Miller sign's the bowing of the back wall,
Yes,
but
the bowing of
this
the
case
foot.
doesn't really have it though.
see now the opposite side. First of all, see the opposite. See this opposite internal maxillary, the opposite external carotid dividing into two. This is superficial temporal going lateral to the mandible, and this is the internal maxillary going all the way to the pterygopalatine fossa. Can you see this?
Okay. Yes, sir.
Now another thing I can tell you at this point of time, I am interrupting Professor Harvey, that I can change to a very special sequence, that is MIP sequence. MIP means, now if I will see the vessels and vessels only. If you really want to look at the vessels, This sequence is showing only vessels. See, so prominent. So Professor Harvey, continue with what you were pointing out again.
Yeah, no, I think that was my main thing. It doesn't have this young boy doesn't have the classic Holman-Miller sign,
Yeah, it
which is the
doesn't.
bowing of the anterior wall.
Yeah, it's not there.
That's because Satish wisely picked not something too extreme to do on a live case, which is always a wise thing.
I don't mind doing.
Sir, I have a question here.
Boss, next
So
week
I
or
have
probably
a-
next or probably next to next, what I was announcing, we'll do all these cases of all stages. Like next week I'm doing the huge one coming out of the zygoma outside. You know.
You
So
don't have
Yes,
to
sir.
prove your manhood today, Satish. We love it, and we're looking forward to you doing this case.
Richard,
I
how
have
about
I have a question here, sir. When will you go for an open approach?
let me tell you, first of all, to me, like Dr. Pachori mentioned in the beginning, more and more cases are now being taken up with endoscopy according to the expertise of the surgeon, according to the equipments, and this is certainly because of the advancement in the surgical technology, advancement in understanding the anatomy better, the navigation system, the approach to the intervention radiologist. We can approach more and more bigger lesions with better techniques to control the bleeding with embolization and other techniques. So to me, any primary lesion, like Professor Harvey said, it is never intradural. Any primary lesion, however it is big, 99% of the time we go endoscopic. For the lesions which are revisions, which are invasive, deeply invading the skull base around the carotid with unexpected vascularity, with lot of vascularity from the internal carotid system, going intradural, intracerebral, we have seen such cases. All we have to go open for certain regions, I will tell you. But why endoscopic? I am not perturbed, or I am not biased about not giving a scar. That's why I am using endoscopy. It's not like that. If any approach which is good, in spite of giving a scar, if it gives a better result, I'll go for it. As simple as that. So it is not the scar which is making me do endoscopic. It is the brilliant illumination, the close-up picture visualization I get with the endoscope, which makes you clear the disease better from the narrow crevices and canal where this tumor invades. This
Satish, can
yes.
I add to that?
Yes.
That when I choose a surgical approach, I always want to stay on the favorable side of large neural and vascular structures.
Yes.
And JNA, by definition, arises from the medial and inferior aspect around the carotid and the orbital apex. And so it is always a pathology that is medial and inferior at least in its origins around those large neural and vascular axis. And that's sort of one of the tenets of any sort of surgical approach. You don't want to have to work around a structure. So, if you have a structure that arises from the middle cranial fossa floor over the petrous carotid and comes down into the infratemporal fossa, that's never going to be favorable endoscopically. JNA, by definition, being an STA, pterygomaxillary fissure, it is in that medial inferior area to the neurovascular axis. So it's just a great operation for endoscopy. And even if you had a mass coming out in the face, by the time you took out the exophytic component, I bet most of us would then be putting an endoscope in to then do the rest of it, even if we did it partly open. So I think that's why.
Okay. Thank you, sir.
Paramita.
Sir, Dr. Vikram Khanna has a question here. Does every male patient above age of 10 years with epistaxis needs to be subjected to HRCT PNS with contrast if a nasopharyngeal mass is seen on nasal endoscopy?
Yes. If there is a nasopharyngeal mass on endoscopy, young male with the predominant symptom of epistaxis, obviously you have to rule out JNA. There is no doubt about it. Now, coming to the surgical part, I will emphasize on few things. Our goal is to remove this tumor completely. I will tell you the reasons why we don't embolize and what is our principle behind that, a surgery behind non-embolization. So the principle is number one, exposure, and exposure. 90% or more of my time will be spent on exposing the tumor all around 360 degree. So I can control the tumor from all around, number one. Now this tumor is seen in the axial plane, it is going far laterally like this. If I come from the nose, I don't have any control beyond the tumor. So my approach would be, see what I will do from here, see my angle. My angle is this. So what I need to do is, I need to remove this medial wall as well as part of the anterior wall of the maxilla to go straight with a 0 degree to the most lateral aspect of the tumor. Can you see that?
Yeah.
See my axis with a 0 degree telescope will make me see everywhere if I happen to remove this medial wall as well as the part of the anterolateral wall of the tumor, and that is going to be a modified Denker's approach endoscopically. Denker's, who described by the sublabial, was revised by the Sternman and Canfield as a modified Denker's, that is purely endoscopic. So once I remove this, we'll have a full access, paramedian access to any part of the paramedian skull base. And you saw in the cadaver on Sunday, I showed how it opens up the gateway to the paramedian skull base head on with a 0 degree telescope. Number one, so that we can access all around the tumor. That is first principle of our endoscopic approach. Second is to go and catch the vessel first before I do anything or touch even the tumor. The reason is, this tumor is almost always in this stage supplied by the internal maxillary predominantly. Though it has a small supply from the ascending pharyngeal from behind, that I will tell you how to go behind in the nasopharynx and cut it off. I will show you. Rest is mostly internal maxillary. Now what you achieve in embolization? Embolization is a huge subject, I will talk in brief. Embolization, it looks so impressive that you close this vessel supplying the tumor and you remove it bloodless. It's not always like that. It is not so simple that, and it is not so without complications. It has its own complications. The intervention radiologist has to be very good. The cost involved is secondary, and the kind of tumor you get embolization is different than without embolization, for that matter. I will show you when I go to the particular canals and foramina where this tumor is going, when I go there, number one. Number two, in embolization, what you achieve, ideally the embolization should reach to the microvasculature of the tumor. If you do the particulate embolization, it doesn't reach to the microvasculature of the tumor, number one. If you ask me embolization, we have indication when tumor gets vascularity from behind. We have got certain patients embolized, and if you ask me, the ideal material for embolization is the transtumoral embolization by means of using onyx. Onyx is ethylene vinyl alcohol, is a liquid embolizing agent, and that is ideal. It can literally close the microvasculature of the tumor and being quite safe, but still under fluoroscopic control. In DSA, you have to do a DSA and take the internal carotid and all the dangerous anastomosis in control, and then you use onyx under vision, and it really takes care of microvasculature. And we have done couple of cases. The cost is only limiting factor. In the case, I remember, we had to use 10 vial of onyx. 10 vial means each vial now costs $1,800. $18,000 for the onyx only. And rest is, surgery is different. But it gives definitely a good feel. So, what we have developed in a country like India, without compromising with the bleeding and other aspect, this approach which I am going to demonstrate, and we have done hundreds of cases with this, is to take the vessel in control intraoperatively and stay on the tumor surface all around using cobblator, which is a good surface decongestant, which you can coblate the surface, because histologically it has been studied now. I can give you so many references. If you see the tumor architecture, the majority of the vascularity which is active is on the surface. As the tumor grows, the more and more central part become more and more fibrous, less vascular as on the surface. And as I will show you during surgery, when we use cobblator on the surface, majority of the vascularity is, you can keep under control by means of using cobblator on the surface, and you can literally manipulate the tumor. The reason is, otherwise if you touch the tumor, if it punches the tumor, it bleeds like anything, it will tell you what it is. So the cobbleter, I call it as a man of the match for this surgery. I would never advocate cobbleter inside the tumor. Again, the principle of this endoscopic approach, which I am going to show you, is number one, exposure. Exposure, which is going to be done by the dankers. Number two, taking the vessel in control before going to the tumor. And number three, exposing all around 360 degree with a surface coblation. And then will to remove the tumor like a cakewalk, I tell you. Without embolization and probably without transfusion. That is what I am going to show you. You can embolize if you have a good facility, good intervention radiologist, and have a good tuning with that. With a cost involved, if you can afford, obviously embolization is useful. I don't deny that. But as I said, onyx, if you use, is lovely. Nothing like it. I know worldwide it has been approached to use embolization to reduce the vascularity because it is the fear of the bleeding which makes the surgeon using all this. And that is correct for the benefit of the patient. If you have a good intervention radiologist, go for it. If your patient can afford onyx and all this, anything. Professor Harvey has a huge experience of embolizing such tumors. I would like to know, Dr. Harvey, what embolization you are getting done for your patient and how's your experience?
Okay, can you hear me now?
Yes.
Yeah, we can.
Yeah, so look, just occluding the vessel doesn't do much.
Yes.
You know, when it comes to J&As. Normally, we like to use PVA particles that usually go down to quite a low, to 250 microns.
Yes.
So they literally embed into the tumor. And that's the key for success. You know, just if you have an interventional radiologist whose idea is to occlude the feeding vessels,
yes,
this is not of any use. And just as Satish is going to do today, he can do that during the time of surgery. That's not a huge benefit. It's the actual intra-tumor embedding with particles, which is what's required. Now, you can do that as direct injection. I've seen that as a benefit. There is a small risk of getting a stroke from intracarotid catheterization. So it's not an intervention without any risks. And the one thing is that if you've got an experienced interventionalist, it certainly does make the operation really nice to do, and certainly takes a degree out of complexity. But you have to have confidence in the interventional radiologist. And the only other thing there is that whenever you get an embolization done, there should be a thing called the CCA shoot. It's the common carotid injection of dye after the embolization that should always be done. If the radiologist doesn't give you that view, then something's wrong. It's like they're hiding something, because it's your final view of what the vascularity is left in the tumor after their good efforts. And so a common carotid injection of dye or a CCA shoot is a must after any embolization procedure.
So the bottom line is, your intervention radiologist has to be very good, competent. You need to have a full consent of any complication that may happen with embolization. It is not always risk-free. You have to have a control over the dangerous anastomosis and control over the internal carotid to prevent the embolizing material efflux into the internal carotid system. There are a lot of reports having blindness, cranial palsy, so many things reported with embolization, which are less and less in this era with a better intervention radiology facilities. So it depends upon the facilities, it depends upon the, obviously cost is a big factor. In our country, if we think of getting a good embolization done, at many places the cost of embolization is much more than the cost of the surgery. Believe me.
That is true.
But still it is useful, I don't deny it. And in certain situations, as I mentioned, when we get vascularity from behind, it is certainly very, very useful. So now we come to the surgical aspect.
Sir, there's a question from John Shadow, Australia. He's asking in what situations would you consider taking control of external carotid in the neck?
External carotid, I will show you. Paramita, remind me after
Yes,
this
sir.
surgery, I will show you certain pictures. where we
Okay.
take the control of external carotid. I will show you certain examples. Particularly, as I mentioned, when we
Okay.
get vessels coming from behind, multiple external carotid feeders coming to the tumor, and then it is best to embolize them all around rather than without embolization. Are you getting this endoscopic picture?
Yes, sir.
Yeah, getting.
How is the
Yes,
picture?
yes,
How
very
is the
much.
picture?
Picture is not yet. Just wait. Because
Okay,
not,
let me do white balance. Now,
It's okay. Not very
So you
good, but
can
it's
focus little more.
little fogging is there, I think.
yeah.
Yeah.
Now, best endoscope. How is the picture now?
It's okay, but fogging is there. Fogging is there. Just wait.
Fogging.
Yeah,
Please
something.
clean cut.
Lens is not clean.
Okay, let me clean.
So till then, you can answer few questions. Dr. Prakash Monka is asking for JNA there is no recurrence but mostly a residual.
Yes.
What is your comment on it?
Yeah, that's an important point Prakash Mukha sir has brought. Hey, boss, any improvement in the picture?
Yeah, better now, better.
Better. Okay.
I think.
Pani dal. So this is the left nasal cavity where the tumor is. And this is the primary picture without any decongestion. Okay? So like Prakash
Yes,
Mukha sir has said, it is always a residual tumor which regrows. It is never a true recurrence. So now in the left side, this is without preparation. My preparation starts few days before surgery as we start a course of antibiotic and a steroid. Because of just the aim is to reduce the inflammation around the mucosa, the tumor, everywhere, and these tumors have glucocorticoid receptors and they respond well to steroids. So steroid is always advantageous. Once you post the case for surgery, few days before, it is always better to steroids to improve the surgical condition. That's it. And the second thing what I am doing, as compared to the sinus surgery, I am not using Marocel.
Yeah,
See,
that's it. Just
because there my concern is the mucociliary clearance. That is a sinonasal immune disorder. Where the mucociliary activity is compromised, this has nothing to do with it. And I am using my ribbon gauze soaked in saline and adrenaline. Simple for topical decongestion. We don't use any infiltration, as I said last time, for that matter any nasal or skull base surgery. So this is topical saline adrenaline. Can you see the picture better?
yeah, now we can see better.
Okay, so the landmarks you see at this point of time. Feel free to interrupt me. This is your
How often you get opposite supply blood supply from the opposite carotid artery?
opposite side is not uncommon. I will show you at what points of attachment it can acquire the blood supply from opposite side. It is obviously once tumor has an attachment in the midline, maybe to the septum or particularly the nasopharyngeal posterior wall, the roof of the nasopharynx in the midline, if it is attached to it can acquire the blood supply from opposite side. And as I said you, we have to go around the tumor to devascularize it from all around. And that will take away the opposite blood supply as well. I hope the picture is good now.
Now it's better.
Okay.
Satish, one small question. If the tumor is actually coming out into the anterior part of the nose, then how does your approach change?
In the anterior part of the nose.
Yeah,
The nose is filled.
Yeah.
filling up the nasal cavity.
Yeah, it is coming out of the anterior nares. I tell you, we have seen couple of times, and this is something, this poses a lot of difficulty because our purpose, our goal is defeated. Our goal is to not go inside the tumor first. And the tumor is coming out of the nose, you don't have place, you don't have space to maneuver your endoscope. And obviously then you have to debulk. And that debulking without taking the vessel into control is so difficult. You can imagine how much bleeding it is going to give.
Okay.
So, but we now with the help of coagulator have been able to control that, able to acquire some space and have done now cases we can tackle them, but this is something what you have mentioned is a very important aspect. Our purpose, our goal is defeated. Our goal is to not go inside the tumor first. And the tumor is coming out of the nose, you don't have place, you don't have space to maneuver your endoscope. And obviously then you have to debulk. And that debulking without taking the vessel into control is so difficult. You can imagine how much bleeding it is going to give. So, but we now with the help of coagulator have been able to control that, able to acquire some space and have done now cases we can tackle them, but this is something what you have mentioned is a very important aspect. and that poses a significant difficulty. Now, as I said, this tumor has a maximum vascularity on the surface. Okay? See my tool. I call it as a man of the match. Can you see this?
Yeah.
Yes, sir.
This is ProSize Max from Coblator. And what I am going to do first is, see this surface decongestion. Can you see this?
Yes, sir.
Every time whatever tumor I see, whatever tumor surface I see, I will keep coagulating. Keep coagulating so that in manipulation of the tumor, any time point of time during surgery will not lead to bleeding. And this surface coagulation, it will take care of very significantly the vascularity, which otherwise contribute to the overall bleeding. It can spoil your surgical field if there is too much of bleeding going on during surgery, and that is something, a major cause inviting complication. Yeah, if you remember, Dr. Sethi was delivering a lecture on complication in sinus surgery day before on TSCSI, which Professor Tarabichi has started a center in Dubai. His talk on complication was a mind-blowing one, and the emphasis, to my surprise, he emphasized so much on surgical field. The more is the bleeding, more are the chances of complication, as simple as that, whatsoever you are doing. So this coagulator is a key tool, serving a lot to us in terms of minimizing complication as well, by means of keeping our surgical field good. See this?
Yeah.
Yes, sir.
So I devascularize the tumor surface.
Does this embolization affect the consistency of the tumor?
Pardon?
Does this embolization affect the consistency of the tumor?
Yes. May not affect on the surface here, but this tumor, as I said, has a tendency to invade the canals and the crevices around. And this tumor, if invades those areas, embolize, sometimes you may not be able to appreciate the tumor going on in all these areas. And the tumor is embolized, it gets collapsed.
Yeah.
And that's why there are a lot of publications saying there are more chances of, the so-called recurrences in the embolized tumor as compared to non-embolized tumor. See this, my tumor is shrunken behind. I am using only on the surface. Can you see this?
Yeah.
Yes.
How it has shrunken. Second thing, this saline adrenaline will help me all the time in keeping the tumor away from my instruments and taking care of the small oozing if there is anywhere on the surface. Now number 2, the exposure, the dankers. We have seen in this webinar dankers several times. I showed in the inverted papilloma case last time in the live surgical situation, and you saw the cadaver as well. So again, I mentioned during the cadaver time, doing a dankers is much better, much simpler on a live situation than on the cadaver. Now the landmarks for the dankers. What I mean to expose is, my tumor is laterally going there up. I don't have access from here. So I need to have a wide access, and see, this is my anterior limit, this is going to be my pyriform aperture at this level. So I need to remove this entire medial wall and part of the anterior lateral wall staying below the orbit. My superior limit is the floor of the orbit. Okay? Now see, this entire anterolateral and the medial wall structure has to go so that I can go laterally with my 0-degree endoscope. Okay?
Yes, sir.
In lateral wall, another important structure.
Can I disturb you for a minute?
Yes, please, boss.
Satish, there is another question from a friend of mine, who says that although it is repetitive, but there are 3 words which are commonly used: endoscopic dankers, prelacrimal, and endoscopic medial maxillectomy.
Yeah.
Very simple, short answer if you can tell about it.
Okay. Again, I will tell you again. Number 1, I mentioned in detail and demonstrated prelacrimal in the cadaver as well that day, on Sunday. For that matter, this dankers is removal of the medial and part of the anterolateral wall or the maxilla
Yeah.
The pre-lacrimal is not removal of the complete wall. It is removal of the, it's an entry into the maxilla through the medial wall and the anterolateral wall, you can say, staying anterior to the lacrimal apparatus without damaging it.
Okay.
So you can raise a flap anterior to that, make an entry inside and put your flap back. That is pre-lacrimal. Okay?
Right.
Now, what I am doing with the cobbleter here again I told you, this is my man of the match tool. Every time this tool is like a magic wand, it is serving so many purposes. It has an irrigation, see this? It has the ability to coagulate, it has the ability to ablate, and at the same time it is having a good suction in it, inbuilt suction, so it can take away the blood and the fluid from your visualization. So the wall I am going to remove to avoid the bleeding. What I am doing? To minimize the bleeding, I am coagulating the surface because this is going to go. And this is the inferior turbinate which is a part of the lateral nasal wall here.
What is the setting of the cobbleter right now?
On 9 coagulation and 5 ablation.
Okay.
Okay.
See this. Now, how much high up I need to go from endoscopy to avoid entry into the orbit? I told you to show this reference every time. I went inside the maxilla and showed you the roof of the maxilla. Here, without opening the maxilla, what you can take reference, this is your axilla. Stay at least a centimeter below the axilla, okay? So that you don't enter into the orbit by and large. Though when we remove this, I will show you where exactly the orbit is. Now this was coagulation. All the time it was coagulation you saw. Now I am going to show you. I will remove this mucoperiosteum by means of using the ablation.
Sir, Dr. Jagdish from Ruvi is asking that will this surface coagulation affect the histopathology?
Not really. Dr. Jagdish from?
Ruvi.
Okay, see, I mentioned this very well, loud and clear in the beginning. I am not going to use the coagulator inside the tumor. This is just for the surface coagulation. See, now I am removing this mucoperiosteum of the lateral nasal wall, which is otherwise so richly vascularized, you know, and I can remove it as good as bloodless. Can you see this?
Yes, sir.
Can you appreciate this?
Yeah.
Now I am coming towards the pyriform aperture.
Jankar.
Pyriform aperture anteriorly, which is going to be my anterior limit. I mentioned earlier. To the level of the anterior attachment of the inferior turbinate. That is the pyriform aperture where I am coming to now. See this? The beauty of the coagulator is it maintains your visualization, takes your blood away from your field, and see the bone at the anterior end? Now very clear?
Yes.
Can you see the bone edge here?
Yes,
Yeah, very
yes,
clear.
yes, very clear.
I am going right down to the floor. See this? I am going right down to the floor.
Yes.
Yeah.
And everything I can coagulate so easily. Now this is part of the inferior turbinate mucoperiosteum. You can see easily. I am elevating. This is the inferior turbinate bone. That is a separate bone I will show you.
Yeah.
Yes,
And
sir.
this is my anterior limit. If you remember, there were a lot of questions during cadaver
Yeah.
that this may affect the aesthetics. It can it lead to
Yes.
depression if you remove this bone?
Yes.
Not really.
Yes.
What you all need to do is, see, this is your lower alar cartilage here, far anteriorly. I am far behind that. You are not supposed to damage that, otherwise you will need plastic surgeon to reinforce your ala. You need a cartilage to reinforce your ala. And I always discuss this thing, how to reinforce and all that. You know Dr. Virendra Gaisas is a prominent rhinoplasty surgeon.
Rhinoplastic surgeon.
in our country. इसमें betadine मिला, betadine. Okay?
So Dr. Ravi Kishore is asking, is this the same precise max wand that you're using?
Yes, yes, always. Can you see the wall of the maxilla much better now?
Yeah.
It should be crystal clear. My aim today is to make very, very simple and clear to remove your fears regarding this vascular lesion, so you yourself can do it. Any endoscopic surgeon doing sinus surgery can really do it. Believe me.
Yes, yes.
If I can do it, anybody can do it. As simple as that.
So what about the intraoperatively blood pressure and pulse rate that you're
Yes, that's a very important question, Paramita.
Yes.
For that matter, in the sinus surgery, I mentioned our concept. Because then in sinus surgery, the major source of bleeding was capillary. Here, the major source of bleeding is arterial, pure arterial.
Yes.
And here, the hypotension matters a lot. See, now I am on the anterolateral wall.
Yes.
See carefully, can you see the small nerve endings?
Yeah.
Yes.
While only these are the branches of anterosuperior alveolar nerves. Can you see?
Neurovascular bundle.
I showed in cadaver as well. These are the branches of anterosuperior alveolar nerves. Can you see this?
Yeah.
Yes, yes.
Now, how much to go anterolaterally? In this case, I don't need to go far laterally. In the next case of JNA we'll keep, I'll show you a far lateral extension, and then we really need to go far laterally. So depending upon the need, you can go far laterally and you can take the vessel under control like this. Okay? See, only one tool is doing everything, that is your magic wand, and that is your cobblator. See this? It doesn't affect the visualization of the tumor. It doesn't go inside the tumor. It doesn't damage anything, and the collateral damage, believe me, is far less than what you achieve with what you get otherwise with a cautery. Because of the constant irrigation, so many studies done, the temperature doesn't go above 60 degree. So now see, I have flushed with the floor of the nose. Can you see this?
Yeah.
Now this is your medial wall. See that?
Yes.
This is your medial wall. This is your inferior meatus, you can see. And I am flushing it with the floor. Purely with the floor. Okay? Now for everyone, this cobblator doesn't work on the bone. And don't even try, otherwise you'll end up ruining this wand. Anything coming from the bone, either use a diamond or a dry diamond, or you can use a bone wax. So there are other means when you use on the bone, but don't try to use this cobblator on the bone. Okay?
Yes, sir. So what is the incidence of atropic rhinitis in this surgery post-operatively, Dr.
Not really. Not really. The reason is, I tell you, we mentioned last time as well this same fact. You have to follow with the proper douching protocol post-operatively, and for that matter, the allergic rhinitis you mentioned, the atrophic. Atrophic rhinitis is an immune complex disease affecting the vessels, supplying the nasal wall. So that is an immune complex disease. That is not something related to this thing. Now see, this is inferior turbinate.
Satish, can I answer that question too?
Yes, please. Yes, please, boss. We are waiting for your call.
Oh, no, sorry, I had to take a phone call with my neurosurgeon, sorting something out. Now, listen, that's a question I often get asked when people do tumor surgery.
Okay.
When people who aren't doing tumor surgery, who are just doing simple functional surgery, there's a lot of dictums in our profession of people worried about stuff. Simply removing parts of the nasal and paranasal sinus anatomy doesn't bring about in itself any terrible disease condition. There's nothing. Atrophic rhinitis, as Satish said, is really it is a problem of failure of the mucosa. It's got nothing to do with whether surgery's occurred. And the condition that gets confused is empty nose syndrome. So empty nose syndrome
yes.
is not atrophic rhinitis. Atrophic rhinitis is a real condition where people get cachosmia and crusting and other problems. Empty nose syndrome is the hyperventilation condition of the upper airway. These are patients who feel like they can't breathe, they're out of breath, but not in their lungs, in their nose. So it is the hyperventilation syndrome of the upper airway. And very sadly, they see enough ENT surgeons that someone eventually operates on them. It's a traumatic event for them, and they often feel worse. Even in the anesthetic bay, they start saying they're feeling worse. I mean, that doesn't make any physiologic sense, because all our patients are congested and swollen in the anesthetic bay. You know, after the surgery or the recovery room. So that is a condition of operating on someone who has a mental health, a somatosensory disorder, not a byproduct of surgery. So I'm sure Satish has probably said to you, he's probably operated on thousands of patients, as we have, had to do terrible things to the nose. I've never seen a situation where someone then wants to kill themselves and says they can't breathe after their tumor surgery. And I can tell you right now that tumor patients will complain of symptoms. Don't you worry. They'll complain of crusting and stuff when it's not quite right, and when their nose leaks, you know, when you get radiation mucositis. So they have no problems complaining of symptoms, but they don't ever complain of empty nose syndromes. They don't ever say, I feel suffocating, I want to end my life.
Absolutely, I agree with you.
Yes.
Totally agree with you.
Keep going, Satish. I'm trying to keep working until you finally get that turbinate off. So I don't know how much more I can say about empty nose. So the only thing about empty nose is empty nose is all about patient selection.
Okay.
And you got to make sure you operate on people that actually have disease, and don't try to fill your private list that's empty 2 weeks from now. You know, that's the downfall for empty nose.
See what I've done until now.
What did you? Yes. What did you do, sir?
Okay, good. You got the turbinate off. There you go. It's your show, your floor again, Satish.
Paramita.
Yes, sir.
See what I've done until now.
Yes.
I have exposed the anterior wall of the nose, anterolateral wall here. See there?
Yes.
And the medial wall, I have removed the inferior turbinate and flush with the floor of the nose.
Yes.
Now, when you remove the inferior turbinate, some bleeding is likely to come. If you have a coagulator, you can minimize. The reason is the blood supply to the inferior turbinate is coming from behind. Majority of the blood supply to the inferior turbinate comes from the sphenopalatine, which we have not taken into control yet.
Yes.
So once you go from anterior to posterior, removing this turbinate, the little bit of the bleeding. See this? You can control very well with your coagulator. What a tool it is.
Yes.
Only single tool is doing everything.
Yes. Then now what about the valve of Hasner?
Pardon?
So,
What about the?
the valve of Hasner?
Yeah, the valve of Hasner.
That's well and truly gone. I'm a little concerned to this. This person may be able to squirt some milk out their tear duct system if they try hard. That's all. Don't worry, there's a few valves up the top actually in which they still may not get reflux.
Now, Paramita, what I am going to show you, I am going to remove both these walls to enter into the maxillary sinus head on. Again, to show everyone, I am going to show you how you can, ascertain that you are not going to violate the orbital floor. Wash. Lux. See this. So my important thing to mention here is how to avoid orbital entry. See now this anterior part of this bone. Remove this. Wash. Let me give you endoscopic picture. Wash.
So, what is the youngest patient you have operated for JNA? Someone's asking from Oman.
Me?
Yeah.
Eldest patient?
Youngest.
Youngest I have operated is 7 years, and the eldest I have operated is 48 years.
Okay.
And that was a demonstration in Calcutta with our dear friend Dr. NVK Mohan in his hospital. That was a revision patient, was operated 25 years before for the JNA, and now he presented with a huge mass going into the cavernous sinus.
So, Satish, as you do this, can you point out, I think you might have it there, the little tiny nerve branches that make up the anterior superior alveolar nerve?
Yes, yes, I showed that.
Yeah, because the maxillotomy approach is an excellent approach, but the only downside is that you get a little bit of dysesthesia around the area, and that's just comes with the territory if you need the extra exposure.
Yes, yes, I mentioned, boss, about that. The anterior superior alveolar branches, when you sever these branches, the anesthesia in the upper incisor is inevitable.
Yeah, there they
For
are.
some time.
You're into the canal right
Yes.
there, aren't you? Yeah, just there.
And we went to the literature to know what can we do, how it can be avoided, and what can we do. To our surprise, there is a network of, see, this is my favorite stylus. This is diamond bar, this is coarse diamond, and what I am trying to show here is the level of the level of the orbital floor. Just I will show you. Just I will show you the level of the entry into the maxilla. ये कर रहा है परेशान. And where the level of the roof is, so that you will never be confused where not to go, how to avoid entry into the orbit. Yeah, give me just a minute. I can remove this wall straight away, but here this is important to show you.
Satish, there is another question that would you demonstrate the inferior orbital nerve here when you are lifting up the periosteum?
Pardon?
The inferior orbital nerve.
Yeah, I will show you. See, first of all, I mentioned in the cadaver as well. My lateral limit is the inferior orbital now, but in this case, I don't need to go far laterally that much, because my tumor, my area of interest is not laterally. Now see, this is the anterior of the maxillary sinus.
Right, right.
For that matter, I mentioned during cadaver that in case you have to go far lateral, I may transpose the inferior alveolar nerve very well. And that is a landmark publication from Paul Casanova on transposing the inferior orbital nerve, and we have done couple of times, and that makes your life easy. That keeps the nerve away, and you can remove the entire walls, the anterolateral and posterolateral wall of the maxillary sinus, patla. And that is a very useful technique so that you can preserve the inferior alveolar nerve. Wash.
Okay.
Now see, this is the entry into the maxilla to show you.
Yes.
This is just to show you the entry before I remove the walls. And see, my level is to the level of the roof of the maxilla, because I have to transect a very important structure here. That is, here it is. That is nasolacrimal duct, and that I will show how you can avoid almost always an epiphora in the post-op period if you transect this duct close to the roof. Okay?
Okay.
I thinned out that. The same thing we saw in the inverted papilloma case as well.
Yes, sir.
See, I am removing a part of this wall as which I have thinned it out. You can slowly remove this. Keep thinning, keep removing, so everything remains under control and you don't damage the surrounding tissue at all. Drill. My aim is not to go high up to damage the orbit. See, this is coarse diamond.
Yes.
I told you in a live surgical situation, I do my Lothrops in 15 minutes with this, not this one, the bigger size, that is 4.5 mm. This is 4 coarse diamond. It is pretty safe. Being diamond, it is quite safe, and it is quite fast as well as it is robust. वो देख कैरिसन. Keep thinning this bone and keep removing it. You have to have some patience at this point to prevent injury and to stay very, very precise. Because now we have our landmark in view, the maxillary sinus you can see very clear. And now I will work in the paramedian plane with a 0 degree. The entire paramedian plane I will work with a 0 degree. This is interior of the sinus, that is level of the roof. And see, this is the nasolacrimal duct. Can you see this one?
Yes.
Yes, yes.
See, I am opening the duct.
Yes.
This is the frontonasal process surrounding it.
Yes.
And I will remove this bone all around, flushing to the level of the floor of the orbit. That is most important. If this duct is hanging and you cut it flush, this is bound to go in fibrosis and close it. That is something need to be avoided.
Okay.
See my duct, everything in under view, under vision. Now give me calculator.
Satish, there's another question that in usual surgeries like these, how many blood do you organize prior to starting the surgery?
Blood?
Yes. How many pints do you keep in store?
Yeah, 1 unit we keep. 1 unit we keep. That's it. And most of the time it is not required to be transfused, I tell you. Most of the time.
Right, right. Speaks a lot about your confidence actually.
See this nasolacrimal duct
Yes.
Yes.
standing in front of you.
Yes.
At the end of the surgery, still if you find you want to stay more safer, not convinced the way the duct is managed, debrider, what you can do? You can do a formal DCR. Go up and do a formal DCR. No issues. I am not against it, but most of the time it is not needed. It depends on how you do it, how good you are at it, how used to you are to it. See the immediate posterior structure to the nasolacrimal duct. What is there? Uncinate process. See this?
Yes.
And we always discuss during sinus surgery that when you do uncinectomy, stay careful as you come anteriorly, as you may damage the nasolacrimal duct. See, I am just defining my maxillary sinus. I hope you are all
Yeah.
oriented.
Yes.
There are 3 things going on in the nose. There are 2 instruments and 1 endoscope.
Yeah, with my assistant.
So we want to see the PIP of it.
Yeah,
Interesting.
we will show you.
Interesting.
I will show you.
Yeah.
I showed you that time in the cadaver, if you remember. I will show you again.
Yes. Yes.
We'll show you again later. Let me finish this.
Yeah, sure. Take your time.
Yeah. We'll show you definitely. It's a good point. And see, unlike the classical, four-handed approach where the surgeons are standing opposite to each other, this is our own approach where my assistant is standing besides me.
Okay.
He is not across the table.
Okay.
See, this is middle turbinate.
Yes.
Yes.
So what I have achieved until now, I told you my maximum part of this surgery will be spent in exposure. I'll expose, I will remove the bone around the duct first, all around, and then I will take away the duct. Give me drill. See the bone around the duct? I will flush it to the level of the orbital floor.
Yes.
This is very important. See how precise this burr is. How precise this drill is. The beauty about this drill from Mactronic is it has an inherent 15-degree angle. My shaft is not coming in the way. See this?
Yes.
This is the floor of the orbit. Can you see all?
Yes.
Yes.
That is the level of the floor of the orbit you see. And that I am defining from all around. All around the duct I am defining the same thing. You see that? Yes. Now pakad. And at this point of time, pakad niche se. At this point of time, see this? See this? Flush to it. I will transect
Yes.
it. That's it.
Yes. Yes.
So where is my duct now? You see, we advocate these patients in the post-operative period. Can you see here?
Yes. Yes.
Can you see here?
Yes.
Completely flush to the floor of the orbit, so it doesn't hang down and doesn't involve in fibrosis.
Yes.
And that's the beauty if you cut it flush close to the orbital floor. See, all these are simple ways to prevent complication. As simple as that.
Sir, is it not better to split the nasolacrimal duct vertically and reflect on the either side to prevent restenosis? It's asked by Sangeet Poddar from
I have already mentioned, if you are not convinced, if you still feel like doing something more, go up and do a formal DCR, remove this bone and marsupialize it. There is no point in discussing. If you feel like this, just go ahead. As simple as that. But I tell you, if it is done properly, it works like anything.
Yeah, I must admit I agree with Satish. It doesn't really matter what you do with the nasolacrimal duct. As long as you cut the duct cleanly, it'll work fine. I mean, you do see us sometimes at the end of the case, we'll go back and check it and maybe run the iris scissors up into it and marsupialize it open a little bit. But really, I agree with Satish. Doesn't matter what you do to it, it survives.
किसकी आवाज है? तू सोया मत कर यार.
Okay, sir. What is your next step, sir?
Yeah. So this is my nasolacrimal duct and see my floor of the orbit all the way. Okay?
Yes.
Now see the mucosa of the maxillary sinus.
Yes.
I am stripping off because my target is this posterior wall.
Yes.
So let me first give me a debrider to expose this mucosa. And then I will tell you how will I increase my exposure more. पानी रख. See, I am removing simply this mucosa.
It's probably worth, Satish, to point out there that you're not just simply ripping all the mucosa out. You're actually just taking away the bit of mucosa that you need for access because it makes the hemostasis so much better. Is that true?
Yes. So this is to expose the posterior wall of the maxilla. Can you see?
Yes.
And behind that posterior wall, we all know, is our pterygopalatine fossa,
Yes.
where our vessel is passing through. I told you in this surgery, my first goal, besides this exposure, is किसकी आवाज थी ये पूछा सोता रहता साला. The first goal is to expose the vessel and take the vessel into control.
Control. Yes.
ध्यान दे. See in between what I am doing, what solution I am using. Can you see?
Betadine.
Hello?
Yes. Yes.
What solution I am using here?
Betadine.
This is 0.5% betadine.
Okay.
You know why I'm using this all in my surgery these days? And this is an amazing publication from our friend who was recently published in the International Journal. In this era of COVID, this is 0.5% betadine, which is very, very effective against COVID, which is a patients have a high viral load in the oral and nasopharynx, and if you irrigate all these areas in between, pre-op, per-op, post-op with a 0.5% betadine, you can certainly help reducing that viral load. If it is, though our patients are COVID negative, all these patients we are getting tests, but in this era, you have to be extra careful. And this paper is published by none other than Mubarak Khan, our friend from Pune, who recently published, and this is something, I believe me, it's landmark. Betadine or povidone iodine, for that matter, we have been using for years as a disinfectant drill. For years together, we all know it's a time-tested thing for the against the bacteria, viruses, fungus, everything. You know, and for this COVID, this betadine is, the povidone iodine is very, very effective, and they have proven it, published it in a very reputed journal, and following this, we are using it. And for that matter, if you fall into that, whether it works or not, I don't know, but there is no harm in doing it. Betadine is, povidone iodine is pretty safe to use here, and we have been using for years. For that matter, the same thing. And if really helps it, it can certainly help all the healthcare professionals to protect themselves. So this is
Dr. Mubarak Khan is a king of innovations.
yes. So boss, thank you, Mubarak. Thank you for giving this, life-saving information to us. This is something really useful.
Yes.
Mubarak Khan is a eminent endoscopic ear surgeon in our country, and this publication with from Mubarak and Dr. Sapna Parab is maybe really helpful. I don't know how exactly it is working, but it is.
He's king of publications also. He does so many publications, so many innovations, so many
Yeah.
things in.
See now what I am doing to improve my exposure. I am flushing the floor of the nose. Can you see?
Yes, yes.
See, in the entire situation, I told you, I mentioned in the beginning, I will not go to the tumor. I will stay all around, take the vascularity in control, and then I will go to the tumor. Okay? And that's what I am doing.
Yes.
Now I have a true head-on exposure with a 0 degree. See this? Divider.
Yes.
Straight. Head-on exposure with a 0 degree to reach in the paramedian plane. I mentioned during cadaver, this is the access to the paramedian plane which can take you anywhere to the middle canal fossa and anywhere in no time. And this particular approach, I really request everyone who is doing endoscopy must be well versed in it. This is our commonest approach. Every day we are doing in our practice for some or other lesion, and this is something, it opens up the area for us to go beyond with 0 degree. See, I am removing further the part of this thing, the inferior turbinate.
Inferior turbinate. Yes.
And I told you this is accepted. This bleeding is going
Bleeding.
to
Yes.
a little bit because the supply is coming from behind.
Phenopalate. Yes.
But this is hardly any. See, if you have a coagulator, you can immediately bring under control. See this?
Yes, yes.
So wherever the tumor is exposing, I will keep doing surface coagulation. Can you see this?
Yes, yes. So Dr. Tejpal from Mumbai is asking, if one had a descent or an intruding inferior orbital canal, how to avoid injury while carrying out the same approach?
Inferior orbital nerve. I mentioned just before, it has to be protected all the time. I will show. Particularly this tumor, it is a challenge as the tumor is eroding the entire pterygoid process till roof, and through the pterygoid is the inferior orbital nerve passing. So I will show this. I will mention at that point how this nerve is to be protected all the way. But for as an information, this nerve has to be protected. See now, more tumor here coming in exposure. and more I am doing a surface coagulation. Can you see this? So more
Yes,
and more
yes.
tumor coming in exposure, keep doing surface coagulation. See, this tumor will behave so well. Believe me, the primary JNAs are well behaved tumors. They have a predictable, spread. We know where the tumor is going, how it is going to behave. If we take all the vessels into control, this turns out to be very good. ये छोटी क्यों लगा दी? छोटी लगाई है. इसको लगा कुछ लग गया. See, I am removing this part of the bone to flush it to the posterior wall now. Lux. Can you see this?
Yes, yes.
I have already flushed with the floor. Now I am flushing with the posterior wall. And which bone is this? I mentioned during cadaveric dissection. Which bone is this?
Palatine bone.
Yes, perpendicular plate of the palatine bone. That's a very important landmark in the lateral nasal wall to the skull-based surgeons, endoscopic surgeons. See now, I am going to flush it with the posterior wall, and at this junction behind, at the junction of the posterior and medial wall, is a canal, which is a useful anatomy I opened up during cadaver to show you the greater palatine nerve at this medial angle. So first of all, let me flush it.
We are fan of this bar actually.
पानी डालना, बुलाना उसको.
Please, how this bar is different from that autology bar, and what is the cost?
The cost of this, the tip of this bar is almost $500. See, this is the greater palatine canal. Can you see this?
Yeah, we can.
Is it visible? Give me the coagulator. And this is the anatomy at this point at the medial edge. See, that's a greater palatine artery. Oh, the
Yes.
right angle there. See, this is the tumor behind in the pterygopalatine fossa. See, this all entire bone has to go. There should be no bone left between the tumor parts to remove it thoroughly. And see, this tumor is bulging here from medially. See, the bone has already gone so thin. Because of the pressure from behind a little bit here, the bone has become more and more thinner. Hata. And see this bone I am removing to open up the pterygopalatine, expose the pterygopalatine fossa. I hope you are oriented.
Yes. Yes.
Yeah, so let me know any point of time if I need to orient you. See this bone, thin bone?
Almost one.
Yes.
And see what this little bit of the oozing from the periosteum. Give me the coagulator. We have the man of the match tool for everything. And that is coagulator. See, it controls so well. इधर दिखा दिखा.
Sir, Dr. Kusum Patidar is asking, most of the people are scared of operating JNA because of fear of bleeding. What is your advice for them to operate without fear?
Yeah, that's what Kusum madam, I'm showing all the way right from the beginning, right from the radiology our focus is on this. how to identify the bleeder, how to control the bleeder, how to tackle it, and see what I'm doing here using the cobbleter. That's why I call cobbleter as man of the match. ये बंदा है. Peg देना. See now, this medial wall is exposed better, and I'll just leave a piece of gauge piece here to segregate this. See now, much better now. You can see the posterior wall of the maxilla in view. So we reach to the anterior wall of the pterygopalatine fossa. Very clear?
Yes.
And I need to remove this bone more if I expose laterally. See this?
Yes.
This is the that is the periosteum of the pterygopalatine fossa.
Fossa, yes. That has to be.
See my cortals. My cortals only is breaking everything. I showed you that day this cortal from Karl Stores.
Yes. So we have to keep the periosteum intact so that we don't enter into the tumor.
Yes, obviously you have to go layer by layer. Because just behind this periosteum is going to be the vascular layer. The network of internal maxillary. And if you're not careful, you can easily damage that.
Damage it, yes sir.
Why to do that? See now periosteum, I will again, see this? Coagulate the small periosteum oozers.
Yes sir.
So go layer by layer. See, it is so clear, bloodless. I hope the field is good for you.
Yes, yes.
Very nice field actually.
Professor Harvey, are you using cobbleter?
I don't think
He's just disconnected right now.
Yeah.
Professor Sethi, are
Yes,
you?
I always use cobbleter for this. Yeah, excellent instrument. Like you have correctly pointed out the advantages. That you get very good hemostasis. It's a single instrument that is provides suction all the time in irrigation, clear view, and helps you to coagulate and ablate at the same time.
So this is amazing tool. I love this tool for the reason you have enumerated.
In fact, I'm doing an inverting papilloma tomorrow morning, early morning. So I'm going to be using a cobbleter for that. I use that for inverting papilloma as well.
Okay.
Yes, at many places we don't have a cobbleter like in so many medical colleges or those who are in the starting practice. What instrument you will recommend at this place? Bipolar or unipolar or what else?
Bipolar, never unipolar for everything, but bipolar. But that cannot replace the, the blade. Barber. That cannot replace the cobbleter. This beauty, the way it, expedites the entire process is so useful. पानी डाल टेलीस्कोप पे तो See, I am exposing the entire wall here.
Sir, you are using the coarse diamond burr, you said, right?
Pardon?
You are using the coarse diamond burr?
Coarse diamond.
Yes.
That's the only burr I use in the skull base.
So,
Never
Dr.
use-
Raj
never
Kumar
use-
is asking why not cutting burr?
No. I never advocate cutting. Cutting can be dangerous. Dangerous to control. And
The PIP also the outside camera.
this burr I'm using at a speed of 70,000 RPM. So coarse diamond at 75 is such a fast cutting tool. You don't need or you don't feel like using a cutting burr to unnecessarily endanger the things around.
Satish, is the stylus you are using?
Yes, boss.
And did you say it's $500 a piece? I mean the burr?
Yeah, the transnasal burr, yes.
Yeah, it's very cheap there because it's $1,200 here.
Oh, boss, if you want to buy any time, please place an order here.
But you probably, that's in US dollars, here in Singapore dollars, $1,200. So
It's
imagine
not-
every single burr you're using is $1,200.
and you use as a, disposable.
Yep, you throw them away after that.
So where do you throw, boss? Can you give me that address? Where do
Yeah,
you?
I'll give you the address because I already have people lined up.
Here we can sterilize using ETO.
Yeah, that's why, it's very, what shall I say, when I see you, you have all kind of armamentarium there, you have angle bird, you have straight bird, you have drills, you have all, we don't have that. If I were to have all this drills that you're having there and have the micro debrider there, the charge for the equipment alone will be close to about $10,000 to $12,000.
Oh my God.
As it is, the facility fee, even with a single bird, runs into about $12,000 for a case like this, for a pure endoscopic sinus surgery
And
case.
here, I am using 5 blades of the debrider. This ProSize Max vent. Then I am using this transnasal burr. All these things in every case.
This ProSize Max that you are using, is it the Easy View?
Yes.
The Easy View, there are two types ProSize Max. One is the Easy View and the other one is the regular ProSize Max.
That's a regular ProSize. I don't think it is one
There's
variety
Easy
only.
View which is meant for nasal work. The other ProSize Max is for adenoids and mainly for
That is EVAC. That is EVAC. That is
No,
not
EVAC is for tonsillectomy. You use EVAC 70 for tonsillectomy. There are two ProSize Max. One is the Easy View and the second one is the regular.
Maybe. But I am using this same one only. I cannot afford. See this greater palatine vessel.
Yeah.
See this ascending in the pterygopalatine fossa. Talis. Now give me a wash. My entire posterior wall of the maxilla is exposed, completely exposed. You can see now. Okay? Now moving anywhere. See now, it is pure bloodless field. You can see.
Yes.
At this point of time, my next goal is to expose the vessel. See now, I am opening the periosteum. Behind that is a pad of fat, you can see.
People want to see you, Miss. They want to see foreign techniques. So can we put someone put you in the PIQ also?
Yeah, we will, boss. I told you, we'll show you. Now see, as I tease out little bit of the fat, we saw in the angiogram the vessel looping inside the pterygopalatine fossa. Do you remember?
Yes, yes.
I will show you. So this is just surface coagulation. Now here I am using this debrider as a coagulator, as an elevator, to tease out this little bit of fat, to coagulate this little bit of oozing. I can use my debrider also sometime to tease out the fat. But be careful.
After you lift the periosteum, the first layer is the fat that you come across.
Pardon?
So after you lift the periosteum, the first layer that you see is the fat.
Yes. And now underneath that is my vessel. Can you see?
Yes.
This vessel, being a JNA case, this is so big. I will pass around my instrument and loop this vessel from all around. Can you see the vessel very clear now?
Yes.
Everyone?
Yes.
Yes.
नीचे लगा रिट्रैक्ट कर हाँ इससे see this vessel, the huge one, and I will loop it. See this?
Amazing.
Yes.
And at this point of time, I will place a, say this huge vessel, and this is the main supply to this tumor. You know, वो देना अपना वो वाला दे तो सही. So I have different clip applicator, different clips. So first I will try with this my favorite Karl Stores with a 100 size clip. And see, it is, believe me, so simple. See, this is a clip applicator,
Yes.
and this is the clip, and you can take this vessel. Can you see this?
Yes.
Or dekh. So to stay on the safer side, I will use 2 clips. Okay?
Yes.
And this certainly devascularizes the tumor like anything. See, so simple. Anybody can use this. This is from Karl Stores. Yes. Chata de. Oh. Now, give me the coagulator. See, having clipped this vessel at 2 places, can you see?
Yes.
Now I will coagulate this medial end of this vessel.
Okay. So Professor Majumdar from Pondicherry wants to know whether the same approach has been used by Goldenwood for videoneurectomy.
Yes. No, not this big approach for median neurectomy. You can see I am coagulating the greater palatine. Can you see?
Yes, yes.
I have coagulated and now I am ablating it. See, now I am ablating, removing this completely. See this?
Okay, yes.
And now see my vessel.
Ever use navigation at this place in angiofibroma?
Pardon?
Any role of navigation in this surgery, like angiofibroma extensive?
See, navigation is useful, I don't deny. But I use it. See, it depends. When you start using, you get to know when you feel like. And Professor Sethi mentioned in his talk day before, it's a good teaching tool. You know, in difficult situation, to improve your localization, it can be. See my vessel?
Yes.
Beyond the clipping, see how big the vessel is. See this? And I am cutting this off. Can you see now?
Yes.
I completely segregated it. See this, the vascular system coming from the internal maxillary, completely segregated. See this? Can you see it very clear or not? And what is there behind is the pterygoid. You know? See, this is the bone, pterygoid bone.
Yes.
Yes.
See, my idea of showing this each and every, step slowly, clearly, so that nobody should remain with any doubts. If anybody has any question, please come forward.
Yes, Satish, can I ask you a question?
Yes, please.
That was very elegant. That was very elegant, the way you identify the internal maxillary artery, your ligated is beautiful. But let us say, if the clip slipped and you suddenly have a torrential bleeding.
Yeah, I will catch it.
What would you do?
I will catch it. If you want me, I can show you now.
No, don't do that. Don't do that.
See, if this clip slips, I can again show me the. I said now. See, I have insulated alligator forceps. Let me show you. Look at this forceps. Can you see this? Can you see this forceps?
Yes, yes.
I can catch this and coagulate with a monopolar.
Okay.
I can coagulate with a bipolar. I can catch this vessel and put a clip again. See that?
Hmm. 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 Hmm.
So
Yes, yes.
if the clip slips, still you छोटा से ना रहे. Still you have
You
a
will first, you will need a very good suction, which will be
yes,
basically suck out all the blood, so it
yes,
doesn't
yes, yes,
stand.
Hmm.
yes.
Hmm. Hmm.
Obviously, your visualization should be maintained. Otherwise, you can't do
Visualization.
anything.
Otherwise, you can't see.
Now see,
Sir,
So,
here you can show us the posterior superior alveolar, no? That will be.
posterior superior alveolar nerve was behind this wall. Probably I have coagulated.
Okay.
I don't know whether it was.
Okay.
It came under.
okay,
I
Satish,
could show you. Had you asked earlier, I would show you. Yes, boss.
Satish, are you using a four-handed technique at the moment? Is there somebody
Yes.
Yes,
helping
yes.
you?
Yes, yes.
Sir, many want to see that. Can you show?
Yeah, yeah. I will. I will. Don't worry.
I think that's a very important point because this is not one-man show. You have to
Yeah.
have a whole team here.
Yes, yes. Definitely.
Issue is with the transmission actually. The quality will compromise the surgical. That's why they will do in next case. But that means they will do the show you the full technique next case.
Okay.
Right now they have compromised. They will compromise the quality of the transmission. That's why he's just.
See now. What I have achieved is I devascularize this tumor by means of segregating its main vascularity. Okay. What I have achieved is I have had a huge exposure. See, with 0 degree head on.
Yes.
Everything in front of me, I have a huge space to maneuver my instrument, huge space to take care of any vessel coming in the way, huge space you will see later to maneuver your tumor now. Amazing space with these dankers. This is what a gift this two guys, the Stunman and Canfield, has given us. Amazing. Now see, I am using carburetor again. Now I have improved my anterior exposure so far. See this anterior exposure, lateral exposure. I have taken the vessel. I have to improve my medial exposure, my exposure from behind, my exposure from down, everywhere. So the next structure I will take away is this middle turbinate. Yes, for the audience, there was a question. The other cases, yes, we have the other cases lined up. After this is an ossifying fibroma, again in a 10-year-old child, the huge one, compressing the orbit and the skull base. Then we have a class 3 Shamblin carotid body tumor. Probably we may have to reconstruct the carotid
There is a
artery.
question from Nigeria.
Yes.
Dr. Sunausi is asking that is this patient having upper airway obstruction from JNA? If yes, was tracheostomy done before this surgery?
Yes, we have done in couple of cases. Cases coming to us with a huge component going behind. Not only that, the huge component, the parapharyngeal component compressing the airway.
Okay. Okay. He's also asking, can we see the brown sign endoscopically after opening the antrum?
What?
The brown sign
What is that?
endoscopically that we can see after opening the antrum.
Yeah, but I am very poor at these names of the signs. I don't know. So can you ask him again what is brown sign? I don't know.
Yeah, I think he will tell us.
Now see what I have done. I have taken a part of the middle turbinate. Can you see?
Yes.
Now this is the middle turbinate which is pneumatized. See this inside?
Yes.
This is middle turbinate. Our nasolacrimal duct is here, far anteriorly you can see here. Nowhere in the scene. This was our uncinate process. So my next structure I wish to identify here is my lamina papracia. That is the most important structure here. So that you again don't get disoriented. Lamina papracia is the next structure. Yes, divider. And see, I am in the ethmoidal cavity. This is bulla ethmoidalis. And can you see the medial wall of the orbit?
Yes.
Very clear. See, this is the maxillary sinus in the floor. See, this is the maxillary sinus in the floor. And this is the bulla I am removing. See, very clear?
Yes.
So I will take away this entire, the inferior part of the middle turbinate and bulla, and I will dissect to the paranasal sinuses to go behind. This tumor has a tendency to invade the paranasal sinuses, particularly, most commonly, the sphenoid sinus.
Satish, as a matter of interest, may I ask why didn't you do a ethmoidectomy first before doing the dankers?
The reason is I wanted to take care of this vessel first. Because as I go behind any point of time, the overall bleeding will be less, number one. And number two, I may damage make an entry into the tumor accidentally as I go behind and work around the tumor. So best is to make an entry, take the vessel into control to devascularize it. Now these are the ethmoidal cells. Simply I am doing a sort of quick, sinusotomy. All sinuses being opened. See this? And that is what see this lamina papyracea is my limit.
Yes.
Here my goal of opening the sinuses is to ensure my tumor is not going up. Confirm and define from above that my tumor is below, I am away from the tumor. Can you see there? In no situation I should leave behind any tumor. And this tumor we know has gone inside the sphenoid sinus, which I am going to open. Hello boss. See this. This middle turbinate is a huge landmark. See this, I am removing the lower part. This all bone, this is garbage now for me. I will remove this completely so that I can expose everything behind quickly. Keep in eye your maxillary sinus all the time, so to orient you. See, my tumor is pushed, coagulated on the surface and pushed. At any point of time, I am not going to enter into the tumor. That is, I told you in the beginning my plan. These are all post-ethmoidal cells. Now you can see. See the post-ethmoidal cell?
Yes, yes.
Now I told you this tumor doesn't enter into the sphenoid through the natural ostium. Never. This tumor has a certain predilections to involve certain surfaces, predilection or characteristics not to involve certain areas. Like for example, it has a tendency to involve turbinates. It has a tendency to involve nasal septum. But it will never enter through the natural ostium. It will never involve the nasal floor. It will never involve the mucosa of the sphenoid from inside.
Yes.
Now see, I am close to the septum. This is my superior turbinate. And what I am looking for here is sphenoid. See the sphenoid below. Can you see?
Yes.
See, on above all sinuses are absolutely clear. Can you see?
Yes.
Absolutely clear. And this is the region where I have to stay careful. Here because the tumor is, see this tumor is attached to the anterior wall of the sphenoid here and to the nasal septum. Go the cobbler. No, go the cobbler.
Sir, Dr. Pawan Singhal is asking how to deal with a large median artery.
Blood wash किया करना सो रहा है क्या? What?
Dr. Pawan Singhal is asking how to deal with a large median artery.
Large?
Median artery.
Median artery, that's a good question. So median artery sometime can be a big source of bleeding. Median is something we all know, we saw in the dissection.
Yes.
The median now coming from the foramen lacerum towards the pterygopalatine fossa. You know? And the artery associated it, 70% of the time it belongs or it carries the blood from the external carotid system. But in up to 30% of the situation it carries the blood from the internal carotid system. So if it is, then it is a principal source sometime of the bleeding. And you should be able to control that. See now what I am doing? this part of the nasal septum, I am going in the subperiosteal plane to segregate it. See this? This tumor attached to the anterior wall of the sphenoid, can you see?
Yes.
And I am segregating in the subperiosteal plane, you can see now. Very clear?
Yes, yes, very clear.
See, to carry out this surgery under vision, you have to follow all these principles. Now I am removing all this intervening bone. I had to remove all this intervening bone. The complexity to this case is added on by involvement of the, the pterygoid bone. And for that matter, to remove that tumor from there, I need to have a full exposure. I can't compromise with the exposure. Yes, yes. Yeah, there is a question here from Dr. Pankaj Gupta, who is the neurosurgeon. I call him as my neurosurgeon of my dreams, one of the best neurosurgeons I have ever seen. That when you divide this tumor, sometimes I plan a division, a planned division of the tumor. Like the case probably we'll keep next week or so, has a huge lateral component. I cannot bring in the entire lateral component at the same time along with medial component into the cavity. There is no space. So what we do in that situation, what we do in that situation, we divide the tumor at the medial end of the maxilla. Here at the medial end of the maxilla, we divide the tumor, remove the medial tumor first, get space to accommodate the lateral tumor later. Okay? So in situation when you have a less space and tumor is going far laterally, you can literally divide the tumor. Okay? And make your life easy. But mind it, you cannot divide this tumor until you take the vessel in control. So like we did in this case earlier, you have to take the internal maxillary first in control. Now see, I told you this is the vessel we clipped. This is the pterygoid process. Can you see behind?
Yes.
And you saw how the tumor is ascending into the pterygoid. See this tumor?
Yes.
It's all tumor which we need to remove. And this is again, for that matter, boss, I'll show you. This again can be a good example for dividing the tumor as well. I will tell you. That's you have pointed out, boss, at the right time. I will show you that how to divide this tumor and what is the advantage in this scenario as well. See, my medial component of the tumor is very well segregated. See this lateral component? And
Yes.
I have devascularized it thoroughly. See this. This is the lateral component which is going up there. See that? And this is the medial component you saw in the CT scan, if you remember.
Yes.
And we have a huge nasopharyngeal component like a cricket ball behind.
Yes.
So now we have got the anterior exposure, lateral exposure, exposure from above, behind. Can you see this?
Yes.
Now I want to see the medial exposure and exposure of the nasopharynx from behind.
Okay.
See, this tumor has a huge component in the nasopharynx.
Yes.
And before delivering it, I need to have full control all around. Control all around.
Yes.
See this.
Dr. Sandeep is asking when you would go for the posterior septectomy in such cases.
Dr. Sandeep from Bareilly.
Yes.
Yes, boss. So posterior septectomy is my next step for him.
Yes.
See now, my tumor is exposed from this side above. Very clear?
Yes.
This is the component which is going up in the pterygoid. And in this pterygoid bone here, see below. This is the bone. And the lateral component is all the way separate. Okay? Now to go behind this, I need to remove this posterior most part of the septum so that I can have a full control all around, medially and behind. See this.
Yes.
Otherwise, like you asked in the beginning, I forgot the name who asked from Mumbai,
Hmm.
that how this tumor acquires the blood supply from the opposite side. This is the area from the nasal septum, posteriormost part in the midline, and in the nasopharyngeal roof. And now I will show you how you can easily segregate this the blood supply from the opposite side. See, this approach I have done, this is the basic approach, Dankers, you know. For any given extension of the tumor, I will follow the same principle. If the tumor is going to the middle canal fossa, tumor is going to the superior orbital fissure, tumor is going to the cavernous sinus, my basic approach is same. Only thing is, I have to additionally go now. See, my superior orbital fissure is here. I have to additionally expose, remove this bone from both sides, open up the fissure and remove the tumor. So the basic approach is Dankers. Believe me, everyone who is watching doing sinus surgery can do the Dankers. And if you can do the Dankers, follow certain principles about the JNA, you can do it. No need to refer to anybody. You can certainly do it. Yes, I will show. See now, this part of the septum I have exposed. Because I want to go to the opposite side, you know. To control the tumor from the opposite side. To control the tumor attachment to the roof and the vascularity coming from opposite side. Okay?
Yes, sir.
I hope you are oriented.
Very much.
Yes.
Sir, Professor Sethi,
Incredible. I'm just watching, amazed here.
Please.
Very nice. Very nice.
Feel free.
One very interesting question somebody asked just now, not in relevance to this current case that you are doing, is how to improve exposure from the contralateral side for any disease, even for invertic papillomas, that is when the tumor is very large. And just yesterday morning, I attended a webinar by Ricardo and Omura from Japan. And Omura has actually described a technique whereby he raises two flaps on both sides and elevates those flaps. One is superiorly placed and the other one is inferiorly placed, and removes the entire posterior nasal septum.
Yes.
And this way you have an incredible exposure from both sides. And you can remove very large tumors this way, and then he reapproximates the flap again and then sutures them. So that's another way of doing it.
Yeah.
Okay.
See now,
Professor Sethi, Dr. Pilu Hakim is giving you compliments and regards.
oh, madam is watching.
Compliments as well.
Yes, she is very much watching.
Yeah, I am blessed. One of the senior most, ENT surgeon in our country, Professor Majumdar watching,
Yes.
Professor Pilu Hakim watching. They are like grand teachers to me.
Yes.
See now, I am on the opposite side. What I have, came in contact with my this thing here, which is giving a little bit of the ooze here, which I have now coagulated is the inferior turbinate of the opposite side. See the tumor in the nasopharynx, can you see? Okay. Good. Tumor in the nasopharynx,
Yes.
and see the Eustachian tube of the opposite side now. Can you see?
Yes. Very clearly.
Very clear?
Yes, yes.
So Satish, you haven't mentioned how are you going to control the ascending pharyngeal artery?
Yeah, I will tell you, sir. That's why I'm
When
coming
will
in.
you coagulate it?
Yeah, I know it's a source of bleeding in this case for me because I caught on the CT angio, the branch of it is small, is coming from behind. So what I will do, I will here coagulate in the subperiosteal plane. This attachment in the roof of the nasopharynx, see this? Can you see this attachment here?
Very nice.
See the roof? Now I will draw a straight line deep to the bone. See now?
Yes.
Straight line deep to the bone to segregate the blood supply coming from the opposite side through this soft tissue. So that will not leave any question regarding segregating the blood supply See, it is the region of the roof of the nasopharynx where this tumor takes an attachment. See this? My, see my segregation from the opposite side is right to the level of the bone. Can you see?
Yes, yes, sir.
So that itself takes away the blood supply from the opposite side. Number two, this is the level of the adenoids below. For everyone information, this tumor never takes attachment onto the adenoid surface. See only the roof which I have devascularized. Can you see very clear?
Yes, yes, very clear.
I have drawn a line through the soft tissues, periosteum, deep down to the bone, absolutely in the midline, to completely segregate the blood supply from the opposite side.
Yes.
So Satish, are you using the ablation mode most of the time or the coagulation mode?
Yeah, when I cut ablation, most of the time coagulation. When I cut this periosteum, see this, I use the ablation. If I cut like this, I use the ablation, you like this. But once
So you are controlling it yourself or you have somebody else controlling
yeah, with my pedal,
your
with my foot. So my both hands, both eyes, both feet are using different tools. My one foot is controlling the coagulator, the another foot is controlling the debrider and the debrider and the drill.
Okay.
So everything is occupied.
And who is providing the irrigation?
Yes, see this, how beautiful this, the field it gives.
So who is providing the irrigation, Professor Sethi is asking?
Yeah, this is the inbuilt irrigation in this, see this,
Yeah, all right, good, got it.
in the coagulator. Okay?
So Dr. Manish Munjal is asking, the tumor that invades lies beneath the nasopharyngeal mucosa, unlike the other type where it lies over the mucosa.
Pardon?
Unlike other type, the tumor that invades beneath the nasopharyngeal mucosa, any tips in tackling this variant?
Any tips in tackling?
This variant where the tumor lies beneath the nasopharyngeal mucosa.
No, I told you, this never ever contacts the nasopharyngeal mucosa. I told you, mentioned it, it doesn't contact the adenoid surface. It is the periosteum in the roof where it takes an attachment.
Okay.
And see, I have segregated and put a gauge piece to segregate it from behind and medial opposite side, okay? Is that clear? Now, I will remove this anterior wall of the sphenoid better. To go inside the sphenoid better. And now, like Dr. Pankaj Gupta mentioned about how to divide the tumor, I will show you how I'll divide and remove this medial component in no time.
Many people do temporary ligation of the external.
Can you see this tumor in the sphenoid there?
Yeah, we can see.
Can you?
Yes.
Yeah.
Coagulator. Pardon?
Is,
Yes, boss.
many people do temporary ligation of the external carotid artery in the neck. How effective it is, and does it means help a lot during surgery?
Not really, not really. The distal ligation of the vessel doesn't affect the blood supply. I mentioned earlier, that is not an end artery, and it actually doesn't affect.
Many people ask this question.
See my tumor I am segregating?
Yeah.
Yes.
And leaving this tumor behind now, for our convenience and here for the sake of demonstration, see this my pedicle of the tumor here. Can you see this?
Yeah.
On both sides, segregated on both sides. And I can easily now divide with my coagulator and get this big tumor out. See this? So I can concentrate better on the rest of the tumor. See how this tumor is behaving after controlling the internal maxillary. Do you agree with me? Voshkar.
Yes.
And how much was the bleeding overall? Hardly.
Hardly.
How my embolization would additionally help me? I have seen people having embolized and a lot of bleeding. See, I tell
You
you,
know, Satish, I showed the video yesterday during the talk on complications, and you saw that
yeah,
diffuse bleeding, and that patient had been embolized actually.
embolized.
Yeah, that was
Oh, chota.
post-embolization.
Yeah, so, yeah, so embolization doesn't guarantee that there will be no bleeding. There are so many factors which controls. Now another thing is, for that matter, if we analyze embolization, there are three sources of bleeding overall. Three sources. One is the external carotid system. Obviously, the embolization will definitely help. If it is properly embolized, then only. Venous bleeding, embolization will have no effect. Believe me, agree?
Yes.
Internal carotid bleeding, embolization we don't do, so it will have no impact. So what are you achieving overall with the embolization? You are taking away the bleeding from the external carotid system, okay? And that is in majority or almost you can say majority of the bleeding is through the internal maxillary. That we have taken in control intraoperatively as well. See now what I am doing. See this?
Yes.
Dividing. See, like I am cutting a butter.
Yes.
Like cutting a butter, dividing my JNA, after taking the vascularity in control. That is the whole game. Now see, this portion of the tumor, which is here behind the pterygoids, I will remove separately. That's what. This is just to show you how you can divide and take the advantage. Dividing is you are taking the advantage, you are improving your exposure, you are improving your area to maneuver more, better,
Satish, which muscle are you dividing now?
Pardon?
Which muscle is this which you are dividing now?
No, it is tumor, not muscle, boss.
Behind that?
Sir, do you always
There is
divide
no muscle.
tumor?
Forceps. I am dividing the tumor, not muscle.
Okay.
Sir, do you always divide the tumor for delivery or in selected cases?
Yeah, this is to show, as boss asked, and to show you guys how effectively you can divide. Easily wash. See, this is coming in the way, I will divide it.
Satish,
Yes, boss.
Richard has just sent me the CT image of the case you gave him in Bangalore.
Not me. It was Gaurav. It was Gaurav.
This was the 23, yes, a 23 kilogram tumor
Yeah.
child with a 10 kilogram tumor.
Yes. Boss, once I was demonstrating in the Max Hospital in Delhi, and the guy who organized was Sumit Mrig. So he kept a case of JNA. Can you believe? Almost a kg tumor, 1 kg tumor. I had to divide almost in 12 pieces to get that out. See, it is like a ball. See now?
Yeah.
And this is where they are,
Ascending French.
yes, this is the area, parapharyngeal area where this vessel supplies. And I am not here, doing anything to this blood supply. I am just getting my nasopharyngeal component out. See this? Just to segregate this,
Yes.
Just to segregate this. And see, my tumor is out.
Yes.
Hello.
Yes, sir.
Excellent,
Beautiful.
See this? This is one part, not the entire tumor. But I have divided. With hardly any difficulty or hardly any bleeding,
Yes, yes.
forceps. So
So what
now
is the
let me
most
show
common?
you. Let me show you. Remove this for everyone. See, this tumor is pushed in the oropharynx. Can you see all?
Yes,
Excellent.
yes,
I
Excellent.
divided this attachment here in the roof where it was taking to the periosteum, and this tumor is still. See this pterygoid.
yes,
There's a huge tumor we saw in the CT scan
yes.
occupying this pterygoid and the base is sphenoid, which I'm not going. I will remove now. So why I divided this tumor. Now let me remove this component and see now how much space I'll have to for instrumentation and see everything under control. There is no bleeding.
Yes, sir.
You tell me any single region to subject these poor patients for unnecessary embolization. Indiscriminately embolizing every tumor in the present times is not justified if you ask me. Better we improve our surgical technique and we can avoid that. Embolization is, the cost involved, the risk involved, and you are dependent on a good embolization on the intervention radiologist. And see this tumor?
Yeah, big hanging over there.
I told you like a cricket ball.
I
Difficult to.
remember we used to keep 5 or 6 units of blood in the OT, two, three in the blood bank. At that time is 10, 15
Sir,
years.
what is the common site of residual tumor in
Suction
case
laga.
of revision surgery?
Pterygoid. Now the coming component where I am going to remove. अरे इसको वो लगाना retractor. See this huge component which is playing game with us. दिखा. कोई बात नहीं दिखा. See now this part is slipping out. दिखा. And now I have got it out.
Yes.
See now how much I have. This was the part which was hanging in the nasopharynx. This was nasal cavity. And give me a syringe, 5 cc. See this big component?
Yes, yes.
So what it has given us, this dividing this tumor, what it has given us? The space. See this? This is the tumor which was in the nasopharynx I have removed. Okay?
Yes.
Now wash. Section. And give me a wash. So now you can orient yourself that how much of the tumor, how much of the exposure I have given all around to get this tumor so easily.
Yes.
We took the vessel in control here, see my clip,
Yes.
and got this tumor out by exposing from all around. Okay?
Yes.
Back. Now to get this tumor from the most difficult area, see this, from the base sphenoid, from the pterygoid up to the middle fossa base. This is the most difficult region, and I tell you, and I have already told you, that is the reason for 99.9% recurrences, so-called. So now I will be very, very radical. Many a times I drill this pterygoid like at the end it doesn't exist. अरे वो दे coagulator. Paramita, meantime you can
Yes, sir.
take questions. Don't forget.
Sir, what are the chances of getting rhinolalia post-operatively? Dr. Ajit Dharawal from Raipur is
Yeah,
asking.
see, once you open up the nasopharynx which has been blocked, such things can happen, temporary. Well, that is not a big issue. We are on,
You get deviation of the septum because of this mass. Do you correct the septum in same sitting or you
not most of the time you don't need to. Yes, but sometimes in extreme deviations, it is always better to correct it.
Sir, is it,
Lux.
marital blockage because of one side is septum is blocked and second.
Yeah. Yeah, and one more thing. See here, Many times you must have seen me for a little bit of the oozing what I've been doing. Either I was using a gauge piece or I was using a, see this Surgicel.
Yes.
So you can use all these maneuvers. Now see, this is the floor of the orbit section. Can you see this?
Yes, sir. Sir, you were also supposed to show us the ascending pharyngeal artery.
Yeah. That was, I divided here. That was the bleeding when Seti sir pointed out, no? Which I coagulated.
Okay.
That was, I told you, that's why I am not bothered. It was a small component we noticed on angiogram. Now, I will drill this pterygoid completely. Okay?
Okay.
Uncover this and then remove the entire tumor as a whole. Again, the most important thing is exposure.
Yes.
वीरू बीमारी है तेरे
Have this drill.
कुर्सी लेके बैठ जा
Gauss and hammer at this place. It also works very well.
Pardon?
We don't have this drill, so we use Gauss and hammer at this place.
Boss, you can use that is crude. I would say वो मोटी वाली ले अपने straight. That is too crude. I would say.
Yeah.
See, that is not so precise. See, you can use all that, but I will never advocate. See, we are striving for the betterment. I have no answer if you don't have or something like that, but something is what you can think of betterment is here. I am using a different drill now, the straight one. See all this bony bleeding, see this? What I am using the dry diamond. Can you see?
Yes.
Like in otology, if you use the dry diamond, you can take care of all the bleeders. You know?
Yes.
Now I am opening this pterygoid fossa by means of drilling this pterygoid bone. Pani dal.
So Dr. Mohan is asking tips to prevent injury to nerve in the pterygopalatine fossa.
What?
Tips to prevent injury to nerve in the pterygopalatine fossa.
Okay, so that's a good thing. Dr. Mohan from?
Kolar Goldfield, I don't know.
So, we discuss in detail. See the soft tissue of the pterygoid fossa behind. Can you see this?
Yes.
And this could be tumor as well. As we saw, it was occupying. So, the tips to avoid injury, number one. In pterygoid fossa, in such tumors, I will go back to the CT scan and show you how the median nerve is completely destroyed by the tumor itself on this side. Completely widened. The only thing I have to respect, see here, that is infraorbital V2. That is my goal, to respect and protect. Rest, the median and the palatovaginal are going to go because this is already destroyed by the tumor, not by surgeon. See this pterygoid fossa and the tumor inside?
Yes.
That's the medial pterygoid plate I have removed. See this?
Yes, sir.
And see the tumor inside. I told you again the exposure. Okay, Carison. See this?
Yes.
I am exposing the pterygoid fossa completely. Whatever this surface bleeding coming out, I will control with my magic wand.
So Dr. Nageshwar Rao from Vizag is asking what is the maximum diameter of the vessel that we can coagulate with a...
It's not fixed, but yes, it should not be used for larger vessel for that matter. If the vessels are larger, what I use my vessel sealer, we have Martin vessel sealer, we use vessel sealer, that we can use up to vessel up to 7-8 millimeter. But coagulator, even if you use, I don't rely for the larger vessel. We should not use, I would say.
Okay.
See the surface coagulation I have given. Now see behind is a Eustachian tube, can you see?
Yes.
And this is what I remove the medial pterygoid plate. So this is the periosteum over it, which I am removing.
So sometimes an
In
early
any given situation, you are not supposed to damage the Eustachian tube. Yes, 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 please. What?
Dr. Reena from Cochin is asking, sometimes an early nasopharyngeal carcinoma mimics an angiofibroma. So how to differentiate that preoperatively?
I mentioned that diffusion weighted MRI. I given that example, and that is not uncommon. MRI is something in my practice every day we, change one or two diagnoses on the basis of MRI. See this, the pterygoid fossa, which is completely hollowed out by the tumor.
Yes.
See, inside is only tumor, there is a thin bone all around.
Yes.
And this bone is a cancellous bone, and this bone is, invaded by the tumor, and there is high chances, if you don't have a good exposure and a good drill at the end, you can leave the tumor residue, the microscopic residue here, and if you leave any microscopic tumor, it is bound to come back.
Recurrence.
See, I am removing the entire bone facing the pterygoid, I am not in hurry of removal of the tumor here. Improving the exposure.
So can you repeat the landmark for this extension of drilling that you did, the posterior extension?
Okay, let me, just a minute. See this, wash. Give me the goblet. Yes, I will show the orbital fissure. I will show the V2, like you saw in the cadaver, you remember?
Yes, yes.
Let me. Anybody who has not seen the cadaver can go in YouTube and see. See, it is the anatomy which is most important before carrying out all this. See, this is tumor surface. All this is tumor surface. See, this is. I can devascularize if you have this. You can do this. If you have this magic wand, see, so simple. See, so simple. This is all tumor. This is all tumor. Now, see what I have done.
Where's that area that Richard was pointing out, that there will be a pad of fat and you will be able to use your finger to dissect the tumor out?
From which area?
Remember, Richard pointed out one.
Yeah. See, here in the infratemporal fossa.
Yeah.
Right.
See, here in the infratemporal fossa, here, see my fat behind. Can you see fat?
Yeah. Yeah.
Lot of fat tissue.
So maybe if you go through there, you can push the tumor easily from there?
Yes. See, if you remember, if you have gone through the publication from Madam Renuka Bradu, you know what this technique I am showing. I will discuss positively the pros and cons. She described a good technique way back, 4-point technique. Sir, what the same thing what you are saying. So in 4-point means 4 ports, not points. One port is this side nasal cavity, okay? One port is after the posterior septectomy, the opposite nasal cavity.
Yes.
Third port is sublabial to the anterior wall of maxilla, okay? And the fourth port is what you are saying. She comes for the fourth port, see this, in the vestibule, laterally behind the maxilla. See this here, towards the cheek, towards the infratemporal fossa. So make an opening here, and any tumor going in the infratemporal fossa, you push with your finger. You push with your finger and it will come out through here. Got my point? That is her 4-point technique. Her idea is to preserve this wall. This wall we have removed. The pyriform aperture and the anterolateral wall of the maxilla in order to preserve that. Okay? Now that's a good technique. Now if we discuss the pros and cons, my question is, even if we do and get the tumor out, how will we do a surveillance? Having done this, see this, Dankers, my only surveillance is endoscopy in the post-op. You put your 0 degree and everything is in front of you. No need of radiology. Now, keeping these walls intact from here and here, and what is happening behind any recurrence or anything, you have to rely all the time on radiology. Got my point?
Yes, sir.
So this Denkers in the present context is the approach for distinct advantage. And we need to know the pros and cons of everything. See, science is evolving. Earlier the open approaches were the only thing which were the weapon to the surgeon. Still, certain open approaches, as I mentioned in the dissection, everyone should know. See, this is the tumor, all tumor, completely. Come later. And this tumor is the most important part I told you, which is the region for 99.9% recurrences.
Recurrences.
So I have to be
So,
very,
sir,
very...
you were showing us the landmark for the posterior extension of this drilling that you did. It is where
Pardon?
the landmark for the posterior extension of the drilling that you were about to tell us.
Okay,
The extension.
okay, that was the pterygoid process which I have removed, you can see,
Yes.
and opened up the pterygoid fossa. That was the medial pterygoid plate here, and the lateral pterygoid plate is still intact there. I didn't remove. See this lateral pterygoid plate.
Yes, sir. Yes.
If I elevate this, something from here, this is lateral pterygoid muscle. You know, lateral to it, but my tumor is not going there. This plate is a barrier, so I don't need to go lateral to it. See, I will stay all the time medial to it. See, this tumor is here.
Okay. Yes, sir.
And medially is your nasopharynx, you can see, and here is your sphenoid sinus. So now, in order to get a better view, I need to drill a little bit of this, to expose this sphenoid better. This is the last drilling I am doing here. After that, I will do the drilling for the tumor, and in next 10 minutes we'll be through. Those who have got bored with this surgery, in next 10 minutes we'll be through.
Satish, just to disturb you once more, where would you drill out for the inferior orbital fissure?
Yeah, inferior orbital fissure, I told you it is here. See this here. And when I remove this tumor, this inferior orbital fissure is where this V2 runs. I will show you exactly where the V2 is running. Okay?
Okay. Okay.
But that is in the superior lateral part of our limit section. Wash.
Okay. Sir, is there an
Wash
ONOD in
section.
the skin?
Superior lateral part of our limit, that is not something which we need to damage. Yes, boss?
Sir, is there an ONOD here?
Pardon? Paramita?
Is there an ONOD here?
ONOD?
Is there?
Yeah, could be above. This looks like
optic nerve up there.
Yeah. This is right. Good observation. Since that was not of area of our interest, we stayed inferior-medially. But this is for the audience. That's a good observation from Paramita.
Spread through inferior orbital fissure. What exactly it goes with, along with the V2, and what is the maximum spread?
Pardon?
What is the spread of tumor along with the inferior orbital fissure, where it is through V2?
Yes, inferior orbital fissure is a common area of spread. Then to the superior orbital fissure, and from then it is a continuation of cavernous sinus. It can go easily behind. We saw the anatomy of the how superior orbital fissure is in continuity with the cavernous sinus. Okay.
Satish, if the optic nerve is visible, then can we have a kind of a glimpse to the maxillary strut also here?
Maxillary strut.
Yeah.
Yes, separating it. Separating it from the fissure below. Let me show you.
Yeah, okay.
I will. Now see, coming to removal of this tumor now. This was our pterygopalatine fossa with the artery there. This is our lateral pterygoid plate. See this?
Yes.
And this is our tumor. See now, you have to gently see the section the Cooper. Can you see the cancellous bone there? Yes. See how it invades. Can you see?
Yes.
See how it invades the cancellous bone. Come on, see this.
Yes.
So you have to gently pull this out. See this?
Yes, sir.
See how this component of this tumor is. See, I am not pulling everything as a whole.
Yes.
You have to literally bring it out gently. It's a matter of traction and counter traction, I tell you.
Yeah, yeah,
See this?
yeah.
Yes.
Very, very clear.
Gentle. Suction. And this bleeding is inevitable here for some time. See this? That's why I wanted to drill this bone more. Yeah, yeah. See, there is something is there in the cup of the forceps. Not catching it. See this?
Yes.
Coming out from the sphenoid. Now the sphenoid is empty.
Yes.
Can you see this all the way?
Yes.
See how this cancellous bone is invaded by the tumor. See this? Professor Sethi,
Very nice.
this is the key area, sir.
Yes, absolutely.
The
It's a
Richard
good
is
reason
back.
why, Satish, you need to get to it with a bone, don't a drill. Sorry.
Is
Because
Professor Harvey there? Richard there?
He's back.
He's joined
He's
back.
back.
He's joined back.
I'm back. Yeah,
Yeah, boss, I am removing from this cancellous bone.
I had to do a quick case, Satish, while you were busy.
No, I am happy interacting, no issues. Feel free.
Beautiful.
That just shows to how why you need a drill at the end of
See
it,
this?
isn't it?
See, it's a matter of traction and counter traction.
Yeah, yeah, beautiful.
See, this is the pterygoid fossa from where I am pulling the tumor. See this?
Yeah.
This is the tumor which is going down in the fossa.
Yes.
See, this is coming out.
Yes.
Yeah, yeah.
See, this is. See, this is coming out. See, this is leaving the place completely intact. You suffer. Everything intact coming out. And this is the pterygoid venous bleeding. Can you see? No embolization is going to control this. That embolization doesn't control the venous bleeding for that matter. Embolization doesn't control the bleeding coming from the internal carotid system. And see this entire cancellous bone, I told you the most difficult part of the surgery. And see how our division of the tumor helped us handling this better.
Plus point.
See this entirely coming out. This part is coming out. See this?
Yes.
Now I will use my diamond to flush that bone completely. Even a microscopic residue can be a disaster, you know. So now let me tell you how to handle this pterygoid. That is my last thing to do. Otherwise mostly the tumor is out, you know. This is part of the, this is part of the median now. Can you see this?
Yes.
See the median canal?
Yes.
And how the nerve was invaded. I told you at the end, I will show on CT scan how it was invaded. No, मेरे को उधर पहले कॉब later. So I don't mind this pterygoid venous oozing a little bit here. That is all expected. You know, these are the muscles, laterally. This is your lateral pterygoid muscle. In no time I will control this bleeding. I am just letting it go.
Yeah, will flow seal help here?
Yeah, boss, you can use flow seal. In Singapore, you can afford, you can add on in bill another $1,000, no issues. In India, we have to think twice.
500.
In India, this is India, boss.
Hey, but you have better equipment than we do.
Yeah, but I use here Surgiflow sometimes. Sometimes the simple poor man's solution, gel foam paste, and it works like magic,
Surgical also.
See, it will come down on its own. See, it is coming down. See this?
Yes.
Now why I am leaving like this? because I will drill out this entire surface, you know. I will not leave any opportunity. That's why I gently pulled it up so that I don't leave any tumor residue there. And I will now take care of this entire cancellous bone. वो मोटी वाली
There
दबा.
is a very interesting comment from a person
Yes.
that is this step meant for lesser mortals also?
Pardon?
Is this step meant for lesser mortals also, or it is meant for only Dr. Satish Jain?
Anybody can do, boss. Believe me. My aim here is this webinar, this course organized by Dr. Pachori. Our sole aim is to provide the evidence-based information and the absolute exchange of knowledge through these master. You know how much time these people like Professor Harvey and Sethi they have spared. It's amazing.
Yes.
And whatever discussion it is going on is pure evidence-based and is pure to promote any junior colleagues. This is to encourage, not to frighten you. You can do it, believe me.
Yes.
This is how we have learned, this is how you can. If I can do, you can think like this. Take it positively. If this bloody nonsense Satish Jain can do, anybody can do it. As simple as that.
But Satish is right here in the fact that this is the operation. If you said to me, Satish, what is the most important part of the operation is what you are doing now. I think many people could feel comfortable just cutting out the exophytic part of the tumor.
So what I'm, so your question is what I'm doing now. See, yeah. So now I am doing, this is the most important part of the tumor I am doing now, believe me. I am letting this venous blood come out. I have no intentions to, pack this area, to pack the tumor residue inside. See this? This little bit of 50 ml bleeding, 100 ml, I don't mind, but this will certainly ensure, I want to ensure here that no tumor residue remains inside, This is not the area where some bleeding is coming and you pack and come out. Never.
Same point Dr. Harvey is saying, this is the most important part of the surgery you are doing right now.
Pardon?
Same point Professor Harvey is saying, this is the most important part of the surgery.
Yes, obviously. I've been saying again and again.
I was going to say, this is not some special part that only the masters like Satish Jain should do. This is it. This is the bit of the operation that stops you getting a recurrence. This is the key.
This you have to do it.
You have to do it. You have to do it. Yeah. If you take this case on, this is what you have to do. This is not special Satish Jain method. This is what you. This is what.
Boss, believe me, अरे इस पे डाल.
True.
नहीं.
We are so grateful to have.
Believe me, anybody can do it. I don't want to make it difficult to show that I can do it. Believe me, and I have seen many junior colleagues who are calling me almost every day from some other part of the world that they did it. They never did it and they have done it now. So this is something, it makes me happy. And this pterygoid bones, this is additional work I am doing. This is without using any pressure. See the carotid behind?
Yep, that's right.
That's the foramen lacerum below. That's the median. Can you see the median here?
Yes.
What a great landmark. And you remember the traditional teaching, the median, once you see step inferiorly and medially to median. Drill like this, the medial canal, and you will never damage the carotid, and you can see the live example. The carotid is just above and behind. Can you see?
Yes.
So I am right on the carotid canal. Some of the cases, I tell you, we had in revisions the huge carotid involvement, and in revision, when tumor adherent to the carotid, you cannot take the endoscopy. You cannot be there to, take out with the endoscopy. In such cases, on 3 of the cases, some in the Pune and some in the Jaipur, I have done with the tumor, you know, we did the cross flow studies with the cross flow good. And after counseling to the patient, we coiled that segment of the carotid again, right from the petrous to the ophthalmic segment, completely coiled, and then remove the tumor from around very well without having possibility of any, laceration. So in extreme situation, you have to have everything in your, basket.
So Dr. Tengli from Gulbarga is asking, have you used cobblator anytime over carotid?
See, first of all, yes, I tell you why. See, that is carotid.
Yes,
That is
yes.
carotid. If you want to see, give me the Doppler. I have my Doppler ready. I always keep in endoscopic surgeries my Doppler, and I will show you. Ajay, take my mic to close to the machine. Doppler, bring the Doppler here.
Amit Kesri is asking how to detect lateral extension of holes like curve. Yeah, we can.
Hello?
Yes, sir, we can hear it. We can appreciate very well.
And this Doppler will be very useful in the carotid body tumor case as well today.
Yeah.
As I told you, we most likely we may have to reconstruct the carotid with a saphenous vein or PTFE, anything, because the internal carotid is involved. And in that situation, the Doppler is very useful to show you flow in the distal segment. Panidal.
Sir, Dr. Papalaniappan is asking, what will you do when the tumor is extending to the parapharyngeal space?
Cobblator. Pardon? Parapharyngeal. See, the parapharyngeal space, to remove the tumor or anything in the parapharyngeal space, that day in the cadaver I was telling you the landmarks, though we couldn't drill the, this is pharynx. Can you see the nasopharynx?
Yes.
The space beside the nasopharynx is what? Parapharynx. So, remove this pterygoid and the muscle completely behind is the parapharyngeal space, as simple as that. And any parapharyngeal tumor which is pushed from here, it is something like which projects, you have to just pull it out. Just pull it out. See, this is superior orbital fissure area which I am coagulating. Why? Because this is carotid and this is just anterior to it is superior orbital fissure. Can you see?
Yes.
That day you saw the anatomy.
Yes.
This is my median now which I am coagulating. See this. This is median canal. Okay?
Yes.
What Amit Kesri is asking, how you will expose the case with extension?
This is on the periosteum of the carotid. I am using my cobblator. See this. You were asking. Yeah, who is asking what?
Amit Kesri is asking what you will do then this extension goes beyond the pterygoid marrow towards the greater sphenoid, and then what will be your approach?
Beyond the pterygoid?
Towards the greater sphenoid.
Beyond the greater wing. See, this tumor arises from here, boss.
Yeah.
And it circumferentially keep growing all around. So you keep following the tumor, keep enlarging your axis, keep following wherever. Greater wing of the sphenoid, middle canal fossa. See where the middle canal fossa is? I told you that day how this tumor grows in the middle canal fossa. This is the base of the middle canal fossa. See this? This is its supraorbital fissure. Cavernous, I told you that they lateral to the cavernous and the nerves are middle canal fossa. Temporal lobe. If I remove this bone, this is dura directly over there. See this? This is directly dura. Underneath this bone, this bone. So this tumor, the V1 passes through the supraorbital fissure. The V2 is passing here. V2 is passing here in the roof. If I remove this, I can show you the V2 here. Between V1 and V2, this space, see this bone is already thinned out. From here, this tumor enters the temporal lobe. Okay?
Satish, I think Richard wants to make a comment.
Yes, please.
Oh yeah, no. I was just going to say I was trying to give you a break, Satish, from that. I was just going to say he's absolutely right in the fact that because the tumor rises from the nasal cavity, it doesn't matter if it looks like it's heavily involved in the greater wing of sphenoid and the middle cranial fossa floor. The tumor's created the corridor and pathway for you to get there. So you really don't have to worry too much in JNA looking at middle cranial fossa or greater wing of sphenoid involvement, because the tumor, by the time you get there, you've got such a large corridor, you're usually pretty good.
Yes.
Exactly. And now see here, there is no bleeding now, whatever bleeding coming from the pterygoid, you see that?
Yes.
Professor Sethi was asking me to use flow seal in case required. Now, sir, is this really the flow seal needed?
Maybe.
I saved $1,000. At least $700 I saved. See, the policy here, what we follow is, for the pterygoid venous bleeding, let it come out. Let it come out and work in that region so you don't miss any tumor, because I know that is the major reason I told you. If see that venous bleeding you saw, so immediately the surgeon sees the venous bleeding and starts packing. That way, without looking at the tumor residue in this area, you end up packing the tumor underneath. And then it's a disaster.
Okay, Satish, how are you going to handle the cavity? Are you just going to let it granulate?
Yes.
Or
Yes. Granulate. We train them for the intensive douching protocol with the saline, these days now with the ringer lactate. And believe me, they do so well. See now the cavity. This is my pterygopalatine fossa. This is the maxilla. This is the maxillary sinus. This is my anterolateral wall here. This is the floor. This is the pterygoid, the pterygopalatine fossa. That's the pterygoid process. That is the cancellous bone of the sphenoid. That's the carotid artery, superior orbital fissure. That's between V1 and V2. This is the access to the temporal lobe. This is the floor of the middle canal fossa here. And that's the optic in the, ONOD. Entire region, no bleeding. But still I'll pack for a day or two, loose packing. I don't want to come in the night for a call of
Satish, you wanted to trace the infraorbital nerve?
Yes. Yeah. Okay, boss. Now, see this. See this
Sir,
now.
Dr. Ankit from Mumbai is asking that
Now,
should we...
see the now, boss. Can you see the now?
Yes.
And see the loop of this vessel. This is beyond we coagulated now. This is the loop of the vessel and the nerve is there behind. Can you see that? Follow this nerve and this nerve and this nerve is running in the floor of the middle canal fossa up. So this is the floor of the middle canal fossa. Can you see?
Yes.
That's it. So that is how the V2 is a landmark of the, in terms of height, about the middle canal fossa. Give me wash.
No. Agzin is asking, this
Orbit is below.
carotid artery, does it need covering?
Pardon?
This exposed carotid artery, does it require any covering or just you live?
No, nothing. The fibrous mucosa and everything will cover it. No need to do anything. See now, the beauty with this approach, number one, the post-operative surveillance. I need only 0 degree in my outpatient department to see what is happening. Number one. Unlike any port approach, that there is multi-corridor approach, so many publications, so many, you don't need to go into. Believe me, this Dankers is the need of the time and everybody can do it. Believe me, the simplest, you just need to remove the anterior medial wall. Just, leave this nasolacrimal duct. See this here beautifully? And you can go. Now, coming to any given extension, somebody asked me, I told that I'll answer in the end. If this patient had been having parapharyngeal extension, what would I do? I would remove this part of the pterygoid muscles and the bone, and I would be right here in the, see my instrument is in the parapharyngeal space. That's it. Number one section. If there is a cavernous sinus extension of the tumor, suppose supraorbital fissure cavernous sinus, what would I do? I would drill away this bone of the supraorbital fissure, and this bone around the carotid artery completely drill away. I mentioned in the cadaver that 1 square inch area. This is 1 square inch area. I would remove this bone, and like I with the traction and counter traction, I pulled out the tumor from here. I would pull the tumor from inside. See, it's so easy to remove this bone. It is like dying to come out, you know, here. I can easily flag this bone out, and then I will be right in this cavernous sinus. Now, this tumor, once it enters the cavernous sinus, number one, this always a periosteal layer between the tumor and the carotid intact. Always. So you don't have to bother that gentle pulling with the counter traction is going to, damage the carotid artery, number one. Number two, wherever in the cavernous sinus it goes, it seals the cavernous openings. It thromboses the blood, the venous, the channels in the cavernous sinus, so bleeding is never a big issue once tumor is truly invading the cavernous sinus. And whatever little bit of the venous bleeding comes, you have seen how to be managed. And if you are, if you are worrying, you just push a few drops of the Surgiflow and pack with the gauze for a minute, and it will stop. So cavernous sinus is easiest to handle. Now, this tumor going to the temporal lobe, very frequent extension we see in our practice. I would enlarge this axis completely. I would enlarge. Then what tumor is enlarged? Tumor itself is enlarged once it has entered. I would enlarge the bony, boundaries and pull this tumor like I pulled it from here. So everywhere it is going from this area of origin circumferentially, and from everywhere you have to pull it out. That is the simple mechanics you have to follow. Any given extension of this tumor, you can remove this with this Denker's approach. Believe me, if somebody says that I have removed from the cavernous sinus, there is no heroism. Once you can do a Denker's, you can remove from the cavernous sinus. You can remove from the middle canal fossa. The basic approach is this: you can remove from supraorbital fissure, parapharyngeal space, any given extension, and this is what I am using, the Mubarak Khan fluid.
Betadine.
Betadine, straight laga. So in practice, what we get the ready-made solution is 10% betadine, dilute it 20 times, and then this is COVID solution.
COVID solution.
Okay. The question is the landmark for the ascending pharyngeal bleeding. Let me tell you something more about the carotid and ascending pharyngeal here. Few words. Our next case is ready. That is a child, I told you 10 years or so, 12 years, ossifying fibroma. This induced everything ready. So the last point, and Paramita, you can collect question meantime.
Yes, sir.
See now, this is the nasopharyngeal soft tissue, okay? The carotid in the parapharyngeal space is in terms of depth, number one. In terms of depth, from this surface is 1 centimeter behind, and laterally and 1 centimeter behind from this surface of this nasopharyngeal soft tissue, number one. This was the end of the posterior end of the middle pterygoid plate, from where the Eustachian tube started. See the Eustachian tube?
Yes.
The soft Eustachian tube, and the cartilage going up behind. This is the Eustachian tube, cartilage going up there.
Yeah.
So from the posterior end of the medial pterygoid plate, my parapharyngeal carotid is exactly 2 centimeter behind. So 1 centimeter is up to here, and 1 centimeter behind from this anterior margin of this nasopharyngeal musculature. 2 centimeters. So don't get terrified with the carotid all the time. Now, going in this cleft behind this Eustachian tube, see this? That is fossa Rosenmuller, far behind and laterally it goes. Where it ends, the carotid is within a centimeter from there. Further posteriorly and laterally, posteriorly and medially. So again, you don't have to terrify about the carotid. And where this ends, on the surface of the carotid medially, is the vertically, the ascending pharyngeal trunk is passing up. And here it gives a branch. here in the vicinity of the, use taken tube, here, that branch comes out from here to supply this tumor. Mostly it supplied the parapharyngeal component, and here it was coming to supply this pterygoid component as well. So this is how, see, JNA is a predictable tumor, everything predictable. The only thing which terrifies the surgeon is the bleeding, and if you follow this principle, see, this patient we didn't embolize, this patient we didn't transfuse, and I don't feel like transfusing at all. This bleeding is less than any regular sinus surgery bleeding.
So now, after you discuss this, can you tell us then how will you manage if there is ICA injury or
What injury? IC injury.
Yeah.
Okay.
How will you manage it?
Go back to Professor Sethi's presentation day before. And we also discussed in our talk on complication. If you remember in the live surgical session, first live surgical session, if suppose somebody just quickly happens to injure the carotid, this carotid, the paracellular carotid, the cavernous carotid, the first thing he needs to do, our protocol I tell you, first thing is to control the bleeding by means of whatever you have in hand. Like I have this gauze piece in my hand, what I will do, keeping two suctions there, place, and I will control like this, not overpacking.
Okay.
Just to keep on the rent to stop the blood loss.
Okay.
Very gentle application of broad piece of, the gauze piece, marrowcell, gel foam, whatever in your hand. But not tightly to completely seal the vessel. Sometimes because of the fear of carotid, you keep it, press it tightly, that is counterproductive. And once you do this, keep more and more pack over it till anteriorly. And then you have a time. Because now your anesthetist is parallelly working to control the parameters and instruct the anesthetist not to let the blood pressure go down, to keep the brain perfusion proper. Now having done this like this, keep your forceps or anything in place, and the other team goes to the neck. You know what do we do? Harvest the sternomastoid, immediately crush it, and go to the common carotid and put a temporary clamp on the common carotid.
Okay.
I will show in the carotid body how you can put a temporary clamp.
Okay.
Just for few minutes, for 5 to 7 minutes, even if you put a clamp, the vascularity, the brain neurons are still going to remain functioning. They are not going to go necrose. So, that temporary clamping will help you remove this pack. After the temporary clamping, this bleeding will go down and you can see the rent properly. Okay? Once you have seen the rent properly, what we do, by the time this happens, we make the Surgicel balls. See that?
Okay.
So and make the tissue glue ready.
Okay.
Because once you have controlled the bleeding, you have time. You don't have to be panic. One team expose the carotid, take the muscle, crush it, and keep the bulldog ready. Other team make the glue and Surgicel balls. Now clamp the carotid, remove this pack, put the crushed muscle over here on the rent, because now keep two suction, you will find the rent. Because the blood flow will be lessened by taking the temporary control of the cervical carotid. And then you put the crushed muscle over here, put the fibrin glue over it, and then pack the entire cavity with the Surgicel balls. And refer the patient to angiography.
Okay.
Satish,
yes.
Is it worth noting that for some people, though, clamping the carotid in the neck won't actually reduce the flow that much, depending on how much backflow they get. You don't expect it to be an amazing reduction in some people. This would be my only thing. So I like the idea of proximal control, but for many people have enormous collateral circular Willis, and you, unless you really think clamping the carotid is going to achieve the neck, you might just be best to get on to packing it and getting hemostasis.
Thank you, Professor. And Paramita, any more questions before we move on to the radiology of the next case?
I think, sir, you have covered all the points, but there is one more question from Dr. Nageshwar Rao. Is every recurrent small mass has to be operated, or you will keep, or when will you operate it?
Pardon, every
small mass, recurrent mass, will you prefer operating it, or will you wait for some time?
Small recurrence.
Yeah.
Okay. There is one more question here. Meantime, so first to come to your question for a small recurrence. Once it is a recurrence, obviously, if it is a small one, that is the best time to address. Number one.
Yes.
Number two, the question here in the OT was when to order the radiology in the post-op, in the immediate post-op.
Yes.
Now, if like this case, if I am sure that I have completely removed it, your experience, expertise, and your how confident you are, depending on that, we generally don't order any radiology. In
Okay.
case having slightest of the doubt, external camera lama. In case having slightest of the doubt, I don't mind getting a contrast CT done. And if there is any residue, you can immediately take up the patient again and remove that. For follow-up or radiology is most important. This thing, endoscopy. Once the area heals, and you every time the patient comes to you, you just use your, mic idhar leke aao. वो इधर लेके आओ. You just use your endoscopy to see if there is any recurrence. If it is coming, then certainly you can take the measure. Otherwise, no need to get radiology done again and again. And for this follow-up, at least you need to keep patient at least for 2 years under follow-up to see any recurrence. Or any time if patient mandates, the symptom mandates, then you have to be very careful about, there is a possibility of recurrence.
Okay.
Professor
Can I
Harvey,
step in there
Another
and just make
Professor Harvey, what is your protocol of follow-up?
Yeah, because I know this is going to be different places depending on availability, but we do a 3-month MRI scan and a 12-month MRI scan, and I think this is very useful for picking up the possibility of small recurrence. The only thing I would say is that I'm at a hospital. We're very fortunate, and we do actually, Satish, do a day 1 MRI scan. And we do a day 1 MRI scan in all tumor patients.
All patients by default?
Yeah, all big tumor patients. Mainly the malignant ones, but we would probably consider it in a big spreading JNA as well. It is actually amazing, Satish, how much information you learn as a surgeon by looking at your day 1 scan, whether it's an MR or CT. It does actually teach you a lot. So I would say if someone's starting their career, don't be afraid of doing a day 1 scan. And it has to be day 1 because by day 5 or 6, there are now healing changes and things which make it look not as pretty. If you do it day 1, the very next morning, it does actually tell you a lot about where you were and what you achieved and the window of access that you thought you had, as well as just whether or not you got all the tumor out.
So, before we move on to the next case, I would like...
Sir, one last question. Many had this query that is it necessary to do the hormonal profile in all the cases of JNA?
Not really. Not really. Not really. I tell you, this question came to us in OT also about the medical management. I tell you in overview, certain thing works on JNA. And the huge research works, even I have referred almost 50 publications, recent ones, in the molecular journals, that what has been going on through the post-op histopathology of the specimen and the immunohistochemistry. A lot of things have been tried. Like, for number 1, as I mentioned, the glucocorticoids, they work because these JNAs have glucocorticoid receptor. Number 2, androgen receptors. Majority of the JNA in this young age, particularly post-pubertal, have glucocorticoid receptors, and the androgen receptors and the anti-androgen flutamide works. A lot of publication done, almost the maximum reduction of the tumor mass I have seen in a publication is 15%. You can use it pre-op to buy some time in case the tumor is compressing on certain important structure. You can start flutamide in the post-pubertal cases. Or you can use post-op agents. Some people use, but I don't use. I use only once in a patient. The other thing works, these patients have the vascular endothelial growth factor receptor inhibitors can be used, like bevacizumab Bevacizumab is a VEGF receptor inhibitor. We have been using for many indications in hemangiomas, in so many things, and recently in the, juvenile respiratory papillomatosis and many other vascular tumors. Here, a lot of work is going on in JNA as well on the use of this thing, bevacizumab.
Can I say though, Satish?
Yes, please.
There's only one medicine that works best for JNA, and that's one part endoscope, one part coblator, and one part drill. This recipe works very, very well.
Absolutely correct. This is the only answer, actually.
Yes.
Absolutely agreed.
So
And you demonstrated this recipe very well today. Well done, Satish.
Thank you. And before we move on to the next
excellent
case,
demonstration, sir. Such a bloodless JNA. I think everyone's appreciating, sir, from all across the world.
thank you. And would like to have comment from Professor Sethi to summarize anything you want to summarize before we move on. The boss.
One practical question is there. You have a long series of such cases, so much of dissection. Post-operatively, means you have any ear problem with those cases because you have, it does that.
Yes. In extensive dissections of the eustachian tube, and in the infratemporal fossa, when you denervate the eustachian tube, many a time these patients come with a effusion, and then you can't help. You have to put a grommet or any ventilation tube to handle those cases. So only in the situation when this area of the eustachian tube, the muscles are denervated. The tensor and levator pallati, they are important muscles.
Okay.
Satish, just as a completion, any role of radiation in recurrences?
Oh, that's important, boss. I forgot to mention. Radiation has a role, but in selected situation, I tell you. Not in all recurrences. If the recurrence is surgically amenable, that is the first choice.
Okay.
In recurrences where the surgery may result in a lot of morbidity which is not acceptable, like deeply involving the carotid artery, intracerebral tissue, branches of middle cerebral, we have seen such cases. And then it is better not to do than give that morbidity, and then radiation is used. Something as radiation doesn't kill the tumor. It induces fibrosis in the vessels supplying the tumor. So you can say at the most, you can contain the tumor. You don't kill the tumor, and it works. It works. It may not grow in the future after a good dose of radiation, 40 to 45 gray. A lot of studies are recommending it, but there are a lot of conflicts regarding the incidence of other complication in this juvenile patient if you use radiation, malignancy and all that. So it is uncommon, rare and long after the radiation, but still we are recommending in some certain patients who have deep, the skull base invasion involving or surrounding the critical neurovascular structures, and then you have to discuss with the patient about the pros and cons of the massive surgery, and many a time you have to resort to radiation.
Okay.
So radiation is something like rescue.
Okay.
It's never a primary choice. Yes, sir.
So what
You
about
asked me to make a comment, so maybe I'd like to do that. First of all, let me congratulate you. Extremely well demonstrated, incredible. Never seen anything like that before.
Arey, sir,
So
nothing. We all are your students,
No, what is very impressive is that you spent almost 1 hour on the imaging, studying the images before, and you did about 1.5 hours, close to 2 hours for the surgery. So I think that is a very good message that you must plan your surgery well by reading the CT scans and the imaging studies, and not just go on and be surprised during the surgery. That's a very important point. Secondly, what is I found very interesting or very commendable is your knowledge of the disease itself, how it spreads and all, and you really understand the disease before you go and operate. And thirdly, the way you handle the tissue, the way you handle the coblator, and the way you did the dissection is, I think, worth commending. It is unbelievable. So my congratulations, and I think one amazing job you did there. And to me, I think you deserve the Bharat Ratna for ENT.
Oh my God! Come on, there's
Really,
too much.
indeed, you do
Too
actually
much.
deserve, sir. Really.
My Bharat Ratna
Congratulations,
is
Satish.
being your student is the biggest thing. You know.
No, no, I'm learning from you guys now, you know.
Oh, come on,
I wish I was
sir.
20 years younger.
Sir, I have one last question. Is that how will you manage an accidental cavernous bleeding?
I mentioned that for the cavernous bleeding, first of all, not to frighten with that venous bleeding. Cavernous bleeding, particularly in the situation of tumor invading that region, is rarely a problem. Majority of the time, tumor itself clogs the venous spaces, and when you bring out everything, there will obviously be a little bit oozing. You can easily control with, first of all, the simplest, cheapest way, gel foam paste. You can use Surgicel. If you have Surgiflow, like if you are rich, like Satish sir said, Flow Seal or anything you can use. Place it for a minute, press it with a gauge piece and forget about it. Remove everything, it will stop. So cavernous bleeding is never an issue in JNAs particularly. In spite of the deep invasion of the cavernous space by the tumor, believe me, cavernous sinus behaves so well. You don't need to be frightened with the cavernous bleeding at all.
Okay, sir. Okay. Thank you, sir. I think you've covered almost all the important points. And
Or anybody, if anybody has any question, convey to Paramita, we can take up. Yes, yeah, the one is another point from Dr. Pankaj here. Never ever try to fiddle with any sort of coagulation to control that oozing or anything by means of using bipolar, monopolar, any cautery, anything. That will worsen the situation. In such venous spaces, the bleeding is like a filling kind of a bleeding. It is not like a single vessel which is bleeding. You can try to catch that. So just don't do anything. Don't do any monkey business. Just press it with a Surgicel or something and come out. That's it.
okay, sir.
So now coming to the next case, and after that is an important carotid body tumor. This patient again is a 7-year-old child. I forgot to mention the age. You can see here. This is a non-contrast CT scan to begin with. This child has this kind of he presented with proptosis. He presented with some sort of headache nowadays. And see how the orbit is pushed by the swelling, and nasal obstruction. He came with this symptom. This is the primary CT scan done. And let me construct. Our CT scan, our radiologist, he does in the Excel plane, and then we use this software to reconstruct. Now this one is the contrast picture, the contrast of the same patient. Can you see? Hello?
Yes, sir.
This is not enhancing much. Can you see? Some variegated area, some areas hypodense, hyperintense. See this variable. This is a classical example of a juvenile ossifying fibroma. There are many varieties of fibroosseous lesion you will see in your practice in this region. Sinonasal region, skull base, paranasal sinuses. But in a child with this kind of a circumscribed lesion, the fibrous dysplasia is never circumscribed diffuse with a ground glass appearance inside. This is circumscribed with a heterogeneous architecture inside. It cannot be anything else but, this is ossifying fibroma. Now you see all the aspect of this tumor. I will show the coronal part and some important implications here. Let me start from beginning. See this.
Satish, I just want to interrupt and just have to thank you very much for having me along, but it's after midnight here in Sydney and I have one more working day in my week, so I very sadly have to go, and I'm keen to see you do this case if you do it as beautifully as the last case, so I will have to watch the video on YouTube.
Thank you, boss. Thank you, and we are so thankful to you for sparing your valuable time in spite of your busy schedule. When we started was 8:30 in the Sydney, the 4 o'clock in India, and he was busy operating, seeing patient till 8 o'clock. Now it is almost going to be midnight there. Thank you, boss, for being with us. And sparing your valuable time and giving us so valuable information. Grateful to you and hope to see you again very soon with some or other academic activity. Thank you so much.
Thanks,
It's my
Richard.
pleasure.
Thank you.
I always learn something when I listen to you guys, so I appreciate it. Thank you.
Thanks, Richard.
Now, this patient, see, I am running this scan from anterior to posterior in the coronal. This is a frontal sinus on this side. Look at in the frontal sinus. This ossifying fibroma is occupying the frontal almost completely. Can you see? Except this most anterior region, I am going from anterior to posterior. It is almost completely occupying the frontal. Can you see this? Can you see, make out this?
Yes, yes, sir.
What does it mean? That in order to expose this tumor to completely remove it, I need to do some sort of drill out of this, the floor of the frontal sinus to drill out this to reach this area under vision. Got my point? We discussed during cadaver the various drill outs. Depending upon the need, depending upon the pathology dictates, you can carry out variety of drill outs. Now, secondly, as you go behind, now this is pressing on the medial wall of the orbit, reaching almost, pressing everything. It is not invading. That is a characteristic of a benign lesion. It is almost reaching up to the globe. See this far laterally into the orbit, and that's how it is giving proptosis. But see this entire periphery, see this periphery, can you see? See the thin bone is intact all around.
Yes, yes.
Can you make out?
Yes, sir.
That is the beauty of this tumor, and that shell of the tumor, the peripheral shell of the tumor is most important if you keep in mind and track it to prevent the surrounding neurovascular structures. We'll scoop out this lesion from inside, keep the periphery intact so that we don't damage the orbit and the skull base. Can you see everywhere?
Yes, sir.
So the peripheral shell of the bone, this tumor is intact, and that is going to be our, something we need to keep in mind all the time. Now, see this is maxillary sinus on this side and this side. This is because of retained secretion. Looking at the density, it looks like in a contrast, because this is contrast. And secretions never enhance. The secretions here, secretions up in the frontal, everywhere. Now see the sphenoid sinus is absolutely free. The tumor is extending far in the choana. Can you see this?
Yes.
This is the extent of the tumor. You can see in all planes. You can see, always see in all planes. This, one must make it a habit to see the tumor in all planes so that you get complete information three-dimensionally. Now see, once I see this tumor in this plane for the frontal, see this tumor is extending into the frontal like this. Being a 7-year-old child, you can't expect a big frontal than this. And this is almost completely, leaving little bit of this region, this is occupied as this tumor is pushed up, and the floor of the anterocranial fossa is pretty intact. Can you see?
Yes.
With a thin bone covering like a shell to this entire tumor, which is, see this, so pushing down the floor of the nasal cavity as it is occupying right up to the floor and extending behind right up to the level of the posterior edge of the septum. And similarly you can see in the axial. So in all three planes. Now see here, most important, what this area is. This area, what is this area? Let me show you. This is the orbit. And what is this area? This is the upper part of the maxillary sinus. Let me show this area. This is the maxillary sinus. Can you see here?
Yes.
Corresponding maxillary sinus here.
Yes.
So by three-dimensional radiology, you can make out where exactly you are. Now we have MRI as well, and there are certain characteristics of the MRI on certain sequences which can help you differentiate these densities. Number one, this is a, let me show you first the contrast one and the fat suppressed. Let me put both together. This is the contrast, and let me put together the coronal T2 as well. T2, yes. Coronal fat suppressor, T2. Yeah. This is T2 weighted image on this side, and this is the contrast. Now see if I run. This tumor is hypodense, and this is something why I am pointing out, what I am pointing out. Hypodense lesion on T2 gives you a suspicion of a tumor could be malignant. Because of the huge cellularity, they show hypodense on T2, but here it is hypodense because of the fibro-osseous component. The MRI doesn't pick up the bone so well, it doesn't pick up the fibrous tissue so well, that's why it is hypodense. And see this, hypointense, you can say this, and this is reasonably patchy enhancing. And as I go up, see this secretion, on T2 weighted secretion up on the tumor in the frontal. So the distal part of the frontal is free of the tumor and there is secretion, tap secretion. See the tap secretion in the maxillary. See this white is secretion on T2, white is secretion on T2, and this is tumor. And this is the complete, and see the border of the tumor which is enhancing. Can you see the shell? The entire shell.
Yes.
Can you see the entire shell of the tumor?
Yes, sir.
All around is a shell. So my treatment is to go inside the tumor, scoop it out from inside, and then punching out the shell, and in the critical areas I will be using my sharp, not the sharp instrument, the periosteum to separate from the surroundings. If this tumor is somewhere on the critical area like dura, difficult to separate, or the carotid or the optic nerve, you can drill away the shell of the vein to the thinnest and leave it so that it doesn't recur. So this is how you can handle this tumor. This is not a difficult pathology, but this is interesting pathology, and anybody can do it. For that matter, any endoscopic surgeon doing any sinus surgery can simply do it. You don't need to terrify wherever it is extending. We have on MRI, it has a good shell all around, and this being a benign tumor, though it bleeds a lot. This tumor, when we scoop out, it bleeds a lot, and it acquires its blood supply from the anterior and posterior thymoidal arteries.
Okay.
So when we open up and the bleeding starts, you can use various maneuvers. You can use gel foam paste. You can use intermittent packing with the gauze and adrenaline. You can use the Surgicel in the walls. The meantime, the bleeding control, you can keep chipping out the periphery so to enlarge the opening, and that's how you can keep doing it from one to another area. But it bleeds. That's what I want to mention here. Any question?
No, sir.
Do you recommend MRI in all the cases? Because I think because how can you differentiate between suppose fibrous dysplasia or osseous fibroma?
Okay, I mentioned earlier the fibrous dysplasia is a genetically predisposed condition where the normal bone is replaced by that fibrous bone. But the difference is fibrous dysplasia is never so capsulated, number one. And fibrous dysplasia, you will never find this heterogeneous architecture inside. These are the two differentiating points. Fibrous dysplasia is diffuse. Sometimes these are two types of fibrous dysplasia, monoosteotic or polyosteotic.
Yes.
And it is so diffuse in the craniofacial bones. I can show you some pictures. So fibrous dysplasia is different. It is diffuse, it is never capsulated like this. And number two, the internal architecture is typically ground glass appearance. In fibrous dysplasia, that is classical of it, rather than this heterogeneous architecture of this varying amount of the fibrous and the bone in the ossifying fibroma.
Okay.
The question here again from Dr. Pankaj in the theater is about the CSF leak. Yes, when your tumor is in a close proximity to the thin, the skull base, and when you remove the shell, outer shell, you have to be very, very careful. I mentioned it. In case it is tightly adherent and you are likely to have a CSF leak and you don't want, what you can simply do it, thin out with your diamond burr that bone. Thin out that bone and leave it in place rather than giving a leak. And even if it happens to occur, you seal it like any other CSF leak intraoperatively. That is how you can manage. Any other question?
What about the visual acuity of this patient?
Good. Very good. I got a field test also done. A little bit issue on the medial fields, a little bit, and we asked for the diplopia and all. He was not having. But yes, after removal of this tumor and as the eyeball is mobilized and the medial wall is gone, may have diplopia a transient diplopia in the post-op period that you must tell these patients that they may develop transient diplopia, or I would say likely to have for some period, and that goes off on its own
Okay.
in the post-op period.
Okay.
Any other?
Okay. No, sir.
So you meantime you can discuss for a minute or two, and I'll be ready with the case as is already everything ready. And at the same time we are inducing the carotid body on the other table. So immediately after this we'll take the carotid body tumor. And for those who are logged in, on Sunday we have a huge course dedicated to facial nerve. The full day, the initial half is a cadaveric dissection showing all sorts of nerve anastomosis and reanimation about the facial nerve, reanimation of the eye, angle, almost will demonstrate almost 30 to 40 procedures on facial nerve. And more than that, the entire demonstration of the facial nerve right from the origin, from the brainstem to its destination in the salivary gland. Each and every step at every point will discuss the landmark and the pathology which can affect the facial nerve and how to manage at that particular level right from brainstem to the destination. That will be covered in the first half, and that will include two skull base approaches. We did a basic temporal bone dissection earlier, and now we'll enlarge to that. We will cover two skull base approaches. One is translabyrinthine approach, we'll show in detail in the facial nerve, along with on the other side the middle cranial fossa approach for the labyrinthine segment. So that will be covered in the first half, and second half will be followed by few live surgical cases like facial-mesenteric anastomosis, preservation of the facial nerve in a live case in parotid tumor, and so more. So that will be on Sunday, and next Thursday will be back with live surgery. So that will be for Sunday. Somebody asked to mention that, and we'll be back in a.
Satish mentioned that TISA is going to be the.
Yes, Ashish. So for this Sunday, we have two superstars joining. One is Professor Tessa Headlock. She is the professor in a dedicated heading the facial nerve department in the Harvard University in Boston. And you can imagine from the Harvard, she's so academically oriented, has almost 150 publications on facial nerve. You go and check Tessa Headlock, how amazing she is. We met her a few years back in Spain in a workshop, and she mesmerized with her work. So she's going to
free gracilis.
Yes, and she's going to show the free gracilis through her video as well. And then the another guy is Ralph Merkritz from Berlin. He is heading the department of the University Hospital in Berlin, and he was with us in Pune in a facial nerve workshop last year when Dr. Gori Belsere organized. That was a 2-day dedicated facial workshop, facial nerve, and he's going to be with us. So these two people will enlighten us this Sunday, dedicated purely to facial nerve. Thank you, Ashish, for that brilliant idea.
Yeah, okay, Satish.
So we'll be back in 2 minutes. You can carry on with the questions or anything.
So what is the external appearance of this patient? Like, is there a bulge or what is it exactly externally?
Okay, I will show.
Dr. Sethi sir, we get many cases of fibrous dysplasia. Suppose this was a case of fibrous dysplasia, then what would be your approach? Because I suppose we usually say we should wait for some time. But what is your practical approach, surgical approach in those cases, fibrous dysplasia?
Well, I haven't seen a lot of these cases actually, to tell you the truth. Maybe just 2 or 3 cases in my entire career. And most of the times I think they were very small, and we just observed them. We didn't do any surgery for them. But if there is, let's say, if it is compressing onto the nerve, for example, if it's the sphenoid sinus and then it's compressing onto the nerve, then of course you have to do something, then you have to decompress it. So in those situations, we will operate and decompress the nerve.
Okay. Sir, I have one more question. Dr. Vinay Kurle wants to know from Bombay that what will be the differential diagnosis of such a lesion in pediatric age group located if you're seeing such a lesion on CT scan? What can be the differential diagnosis in the pediatric age group?
Is the question directed to me?
Yes, sir, you can answer. Yes, sir.
To you, sir.
Okay, I think the basically looking at this particular imaging studies, I think it's very clear that it is a case of ossifying fibroma, and like Satish pointed out, that it is not a ossifying fibroma, which would be more compact. So the differential diagnosis, I think here, because it is enhancing onto the on the MRI scan, would be that of a tumor. And I would think of maybe if I didn't know the history, and if I only had one image to go by, I would think of a schwannoma.
Okay.
Schwannomas was enhanced like that, and I've done a few cases of schwannomas in children, but they are much easier to do than here. But the approach was exactly the same. Approach was to go inside from the core and shell it out completely till the capsule collapses, and then remove the entire capsule. So that would be in the forefront of my mind.
Okay. And so what about the recurrence rate of this tumor, of such a tumor?
Ossifying fibroma?
Yes, sir.
Well, they grow very slowly actually. The rate of recurrence may be very, very slow. I'm not sure about the exact rate of recurrence, but most of the time, because of the drilling very close to the skull base, some residual is left behind. I recently had one case that was done in New York, and the surgeon actually left behind a small shell of the tumor so as not to remove the skull base. And but the recurrence rate, I'm not sure about that.
Just one more question. The challenges of putting in a 4mm telescope with instruments in a 7-year-old child. What do you think?
Satish doing it, and I think doing surgery with the 2.7mm, you'll find the visualization is not all that great. And you should manage to do it. I've done used a 4mm endoscope in a 3-year-old child. So you can use it. But
Yes, sir.
Hello.
Hanji, sir, we are with you.
Are you getting the endoscopic picture?
No.
okay, Satish, before you start, thank you everyone. Even I have to take leave because I'm starting. I have early morning surgery. I'll be up at 5:30, and I have surgery at 7. So I'll watch this on YouTube tomorrow morning. And thank you so much. Amazing.
Thank you so much, sir.
Look
for
at the
being there with
endoscopic
us.
picture. Look at the endoscopic picture. It looks like any other tumor. Just nice. Had a bleed. Look at that picture.
Yeah.
It looks like any other tumor.
Yes.
So if it's just a schwannoma, you just remove, make an incision there, and remove the bulk of the tumor. The capsule will collapse, and then you remove the capsule. Okay, thank you very much.
Thank you,
It was
sir.
a pleasure, and I'll be joining most of your workshops, and amazing learning opportunity, really. And
Thank you.
Thank you, sir.
Thank you
for
so
we are
much.
living in a
sharing.
different era altogether, where you can just see the masters operate sitting here in Singapore, Richard watching from Sydney, and you have about how many views right now? About 7,000-8,000 people watching from all over the world. Right?
Yes, sir.
Amazing, amazing. Thank you very much. Bye.
Thank you, sir.
Thank you, sir. Thank you once again. So, are you getting the endoscopic picture?
Yes, sir.
See this? And this is as I told you, is a bony shell. See this? And I just placed the saline adrenaline pack. And this is not compressible. This is bony shell. So first of all, what I am doing, decongestion. See, a lot of vessels on the mucosal surface, And coagulator is the tool for all this, See the thin shell. You can see.
Yes, sir.
Yeah, very clear. Is it 2.7 millimeter?
What? No. It is 4 mm. 4 mm.
Sir, there is a message from Nairobi. Doctor is writing for you that excellent surgery and cadaveric dissection demonstration, selfless teaching and global spread of knowledge in all the webinars, extremely beneficial to people from all the developing countries.
Thank you. Where is this message from?
Nairobi.
Nairobi. Oh, thank you. Thank you guys for being with us. See this, as I open this shell, see this tumor. See this fibrous tumor inside. Can you see this?
Yes, sir.
And I told you, I told you, this is going to bleed. forceps. Motor.
Again, only option is low blood pressure,
What's there?
hypertension.
Pardon? Bada de.
Only option is hypertension.
I didn't get what you're saying.
Only option is
Hypertensive
hypertension.
anesthesia.
Oh, again.
Hypotension.
Hypotension.
Only option is hypotension.
Yeah. See this? I'm taking this biopsy. See this? This is the fibrous component and see the bleeding which I told you. This is going to be part of it. क्या है क्या?
Will you try
Debraj.
sending for a frozen section biopsy to rule out malignancy?
No, it's not malignancy. No question about it.
Okay.
See, here we have to apply our clinical sense always. This is not malignancy for sure. Pani dal. See what I am doing? I am scooping out with a micro debrider to expedite. See this? So this bleeding is expected. और पानी डालना है यार सब बोले मत See, this is what I am doing. I told you, you can place the gel foam paste, Surgicel, or anything for intratumoral, debulking. We have to scoop it out. There is no other way. Pani.
Sir, is there any role of biophosphonate in preventing recurrence
Pardon?
in these cases? Is there any role of biophosphonate in preventing recurrence?
Bio?
Phosphonate.
Biphosphonates? कुछ नहीं कर रहा था. Biphosphonates?
Yes, sir.
Biphosphonates are used for maturation of the bone.
Okay.
मेरे को गॉच पीस दे दे तेरे. Biphosphonates are for the maturation of the bone, This is a tumor that works in fibrous dysplasia,
Yes, sir.
Just a minute. See this? This bleeding is expected, Debrider.
Yes.
So you have to keep scooping it out. Do it fast. See, we discussed about the angiofibroma as vascular tumor.
Yes.
How much was the bleeding in angiofibroma?
Yes.
And see this. But this is in a shell,
The most commonest age you find clinically means your
See, I have been helped by my assistant with the irrigation all the time. Now give me a gauge pack. Now what I will do now, I will do a little bit of internal packing. Bada de. Section. See this? This is simple saline adrenaline pack. I will use the paste also later. I will use the Surgicel also. Wash all the time. Don't stop the wash any moment without saying. Even if I ask or not.
smallest age you have operated this case versus fibroma.
धीरे वो.
Hello.
Yes?
What is the smallest age you have operated this case?
Smallest age?
Yeah.
5 years. 5 years. See, in these patients, the indications of surgery is either the pressure symptoms or the cosmetic issues, These are benign, slow growing. Every case need not to be operated. See, the things will improve with time. See this?
Yes.
Debrider.
Sir, in this case, was there any external deformity?
Pardon?
In this case, was there any external deformity? External bulge or something?
External deformity this patient had.
No, I'm asking, sir, was there any bulge externally?
This patient had a proptosis, I told you.
Oh.
I didn't get your question for that matter.
So, was there any bulge externally?
Yes, the proptosis I told you again and again.
Okay, only proptosis. Okay.
Kumar, you did one case. You did one case in Agra with the frontal proptosis over there. Frontal bulging was there. Young boy, 7, 8 years old.
Yeah. So there are only two indications for this. Either the compression, see the vessel,
Yeah.
that is a branch of, anterethmoidal or postethmoidal. See, that is a ethmoidal vessel.
Yes.
Yeah, there are readers. Back. Surgical, little bit of surgical here. See, once you find the vessel somewhere now, एक और दे ये वापस दे. This is tumor. You cannot control these vessels. Ultimately, what you need to do is you pack with a surgical on surface and the gauze pack. अच्छा करता है दूसरा दे सर्जिकल सो थोड़ा लंबा पीस दे कुछ नहीं हो सकता see this in no time it will come under control, don't worry.
What is the best way we can avoid the recurrence in these cases?
Yeah, to stay inside the shell and keep removing the shell completely. You will see at the end of the surgery the shell completely removed. Okay,
Yes.
see this was the area. Yeah, now keep it like that. I will keep removing the shell. Yeah, keep it like this. Yeah, debrider. बस एक मिनट.
We have to drill around the skull base, so chances of CSF leak are there.
Yeah, at the skull base surface, once we completely, scoop it out, and you will see the shell around. We'll remove this shell under vision. Wash the. See this? The interior. With lot of irrigation all the time.
Or there's any warm line, or it's a.
Sir, in your experiences, any of your patients underwent staged resection?
Not really.
Okay.
No need of stage. Once you are doing it, remove completely.
Okay.
You'll see now, very soon it will see the condition is much better.
Yes.
Can you see?
Yes.
Can you see it improving?
Yes. Yes.
So you have to have patience, इधर ध्यान दे. See the superior limit of the shell.
Yes.
इधर ध्यान दे. Give me the debrider now.
So what are the chances of CSF leaks in such patients while operating intraoperatively?
Yeah, if you're not careful at the skull base, what is there? If you're not careful at the skull base surface, I will show you the skull base surface. You will come to know.
Okay, sir.
So you can, if you are careful, you can avoid it easily. See how you can improve the visualization. All the time you have to do this. See, intertumoral debulking. All intratumoral debulking.
Sir, even in the previous case, even in this case, many ENTs are asking the ratio of adrenaline with saline. I missed a few of their requests. They
Ratio.
were also asking few, yeah,
Yeah, in
adrenaline
this
with.
in this I am using 1:1.
Okay.
In children, you can use pure even topical.
Okay.
As long as you are using topical, see the entire fibrous osseous component inside in being taken away. I am not crossing my limit of the shell, totally inside the shell. I hope you are oriented.
Yes.
I am well within the shell.
Yes. Yes.
This floor is the safest region. This floor is the safest region. See now the conditions have improved.
Yes. Sir, any role of pre-op histopathology? Dr. Gaurav Garg from Bareilly is asking.
I tell you, the radiology dictates. With this classical picture of the radiology of the ossifying fibroma, juvenile ossifying fibroma, with no invasion surroundings, nothing, there is no need of histopathology. See, we have to use our, our brain and our common sense also. Once you know that tumor is classically benign, you don't need to do that. In suspicion, in malignancy, yes, always. Malignancy in the paranasal sinuses, the treatment is always histopathology driven.
Okay.
See the shell. See the coina.
Yes, sir.
Can you?
Yes. Yes.
See now the picture is much better.
Yes. Yes. Much better.
So what I was trying to say, the initial bleeding you should be ready to handle. Have patience. Keep your material ready. Keep yourself ready to handle that.
So can you repeat once again? I think you've mentioned this before, but there is one more question from Bangladesh that how will you differentiate fibrous dysplasia from the ossifying fibroma? Can you just say once
Okay.
again, sir?
Okay. Number one, fibrous dysplasia is a tumor. And it is lined all around by intact bony shell,
Yes.
circumscribed all around wherever it is going. While the fibrous dysplasia, see, we sucked out the secretion from the maxillary here.
Yes. Yes.
See this? This was the maxillary.
Yes.
This was from inside.
Ostium. Yes.
So the fibrous dysplasia is not circumscribed, it is diffuse. Number two, the inside architecture. This tumor, because of the varied, the fibrous and osseous component, it is heterogeneous from inside. You saw.
Yes.
The fibrous dysplasia is different. That is a woven bone, so it gives you a ground glass appearance.
Yes. Yes.
and diffuse. Sometimes it can involve all cranial bones, fibrous dysplasia.
Okay.
See the surrounding shell. See how expanded it was. How expanded it was all around.
Yes.
Yes, sir. A role of biphosphonates, she has already asked. Biphosphonates are the drugs used for maturation of the bone. Like fibrous dysplasia, yes, it has a role. In autosclerosis, yes, is a role, but not in ossifying fibroma. And ossifying fibroma is a tumor. See the limit all around. I am reaching to the, the shell. दबाओ.
So what about the anterior ethmoidal arteries?
See the lateral aspect of the shell.
Yes.
Yes.
And what is that? The orbital surface.
Yes.
That is the orbital periosteum. Can you see that?
Yes.
Yeah, you were asking something.
So what about the anterior ethmoidal artery in this case? How will you?
Anterior and posterior. See, everything is displaced. And anterior and posterior ethmoidal artery were the source of bleeding. You saw that gush.
Yes.
That is purely because of the ethmoidal vessels, which are the principal vessels supplying this tumor. See, I could reach the lateral edge. You can see. You could see this. That is the lamina papracia thinned out, and see the eyeball being pressed to see the ballotment. Now, see the superior lateral edge.
Yes.
See, this is the outer shell. See, same thing at the level of the skull base. If this outer shell is, breached, and you go beyond that, then you will get CSF leak. So always use a blunt dissection. Always use a traction sort of a thing. See, you have to gently hit all walls. Can you see the shell of the tumor?
Yes.
That is the shell of the tumor. See that? Complete removal along with the shell is the answer to prevent so-called recurrence.
Okay.
See the shell, outer shell.
Okay.
See how slowly you have to bring it away. Wash the neck. नहीं तू ये कर सकता है स्ट्रेट ले मेरे को दे. I'll just give it a wash to improve the conditions for you. कर section कर. See the situation?
Which cases? Yes, sir.
Give right.
So in which cases have you done a combined approach or external approach?
Not
Combined
really. You see, You don't need to go by open approach. Now for such lesions, in children, why to give unnecessarily facial scar, incision and so many developmental issues. For such benign lesions, which you can now address endoscopically. Yeah, Dena. See how big the tumor component was.
Yes.
So I am more and more doing internal debulking, reaching to the outer shell and peeling out that outer cell. By and large, a nutshell, this is what about this tumor is.
Okay.
And this bleeding you have to be prepared with, you know. See this micro debrider, how it's being used
Yes.
without any pressure, and I am going right to the level of the shell.
Yes.
See this internal component out?
Yes. You've kept
Hydrodissection will
the
also here.
shell intact there.
See, this is how you can remove it more and more.
Even the hydrodissection will help a lot over here.
Since the shell is bony,
Yeah, it's difficult to get into.
yeah, internal component you can use hydrodissection. But debrider is a good tool. You can, without using any pressure, you can do internal debulking. But be careful not to damage to the wall. See the medial side. Can you see the medial wall?
Yes.
See this shell.
Yes.
Give me the lux. See the medial shell. This one.
Yes.
Since it is a lower part, I can pull it as well.
Yes. So do you even reserve blood for these cases?
Pardon?
Will you reserve any pint of blood for these cases?
Blood, just we kept 1 unit because this bleeding was expected.
Yes.
I told you before I started that this is vascular internally and we are prepared for that. But you know, the initial bleeding is now not there. That bleeding coming from the anterethmoidal artery,
Yes.
that went into spasm. It goes in spasm after some time. So initially it bleeds like anything.
Okay.
Have patience. See now, there is no, like you can say a torrential bleeding or anything.
Yes.
Now that is your sphenoid sinus.
Yes.
Full of
Yeah.
radiation,
See
suppose
that?
there is a recognition,
See the sphenoid sinus. Now, this is the upper component. So far I have done with 0 degree.
Yes.
I will take 70 as I go anterior-superiorly.
any role of radiation in post-op, suppose there is a residue or recurrence afterward with a
No,
non-approachable area.
no, boss. This benign tumor, more focus on complete removal, nothing else.
Questions were there, that's why.
Ah, come on. If we start radiating such lesions, you have to stop practicing. No way.
And
See, in the paranasal sinus, skull base, all past literature is now not, corroborating with the present techniques of endoscopy. There are so many things, so many lesions in the past which would otherwise considered to be inoperable. Now with the endoscopy, they have become operable, So here the literature is now different,
So which debrider blade are you using in this case?
40. Sometime earlier was straight, now 40.
Okay.
And as I go up, I will use different.
Satish, would you like to keep the shell in the superior part, or try and take that out as well?
My goal is to remove completely, boss. Why to
All right.
leave?
Okay.
ये shell है. This is shell. See this tumor cell?
Yeah.
Dr. Kusum Patidar is asking, is there any chance of retraction of anterior ethmoidal artery into orbit?
Retraction? Not really. We are not transecting anything. Not really. But the question is valid because we are dealing with something at the lateral, the medial wall of the orbit. That too with a bleeding from the ethmoidal artery. So, point is valid. You should be careful.
Faida Wadia is she was with us till now because she has to go for some work. That's why she will join after some time again.
Okay, great. You would like to have, madam?
Yeah, she'll try to come before during this carotid body tumor.
See, this is maxillary sinus. Can you see all the way?
Yes. Yes.
There is some part of the orbital fat. It is just projecting. Here.
Yes.
Because here the wall, because of the tumor compression, the lamina is gone. Cobblator. Now, for anything, anytime in, endonasal surgery, if your fat is, trying to prolapse, use cobblator. Cobblator to stiffen. See that? Stiffen that. So it will not bother you. Now give me 70. Now I will use 70 degree here to see the angles. The only area left is antero-superior and towards the skull base, a little bit towards the superior part of the orbit. एक जना सिर पकड़ना, संदीप.
Prasad Kelkar is asking, in spite of doing wonderful dissection, suppose any microscopic remnant is left inside and chances of recurrence, what are the chances
Yeah,
of
it's
recurrence?
a slow growing tumor. Yes, recurrence can happen, but once you have done endoscopically, you can always monitor. See the superior part.
We can
See the beauty of the angle scope. It gives you opportunity to visualize all around, under vision, to the shell of the tumor. Yes. See the surrounding shell. No, coblation doesn't work on the bony surface, Section.
Satish, you can label this as the unshelling of the egg from the skull base.
Yes, this is literally. See the wall. See the wall I have brought out. Can you see this?
Yes.
This is the wall.
Yes.
This is the wall. This is the wall everywhere. You have to be very, very, keep your eyes right on the target. Something like that.
And as delicate as you're dealing with the foot plate.
Yeah, you have to be, but we cannot be so delicate here. Delicate here like foot plate.
Dr. Ashim Bhumkar sees footplate everywhere, I think.
Yeah. And delicate.
See the
Sir,
superior part. This is to uncover the frontal now. This is to uncover the frontal. This is a very, very important area. See this shell. अरे
yes.
बीच में से हटा ना.
Yeah. Beautiful. You found the plane there.
Yes. The bread. Now I'm using red 60.
Okay.
Manage these children in OPD because this is difficult to do endoscopy regularly, and so
क्या कर रहा है? सेक्शन पतला रख. She is so tightly adherent to the lamina. पतला रखे यार. See the shell.
yeah.
So Dr. M.V. Appara was asking, is image guided system extremely useful in this situation?
What?
Image guidance, is it useful in this situation?
Image guidance. Again the same answer. Always good to have. Why against? But the issue is.
It is just good for the image of the surgeon.
See this important area I am reaching. I am with a 70 degree. And very soon I will be, see this component. This is the beak that I will have to drill ultimately. That is the orbit. See, this is separated from the orbit now. Can you see?
Yes.
Very, very nicely seen here.
Almost completely
Posteriorly,
separated.
yeah.
Now I will show with a 0 degree. You the entire orbit. I will show you.
People have to watch how temperamentally he changed his gear.
0.
Yes. The aggressive thing that he was doing on the tumor initially, how his strokes became so very monitored and delicate and measured.
Ashish.
How he temperamentally managed the bleeding earlier on. I think these are the lessons that we have to learn. Did not get one bit bogged by the bleeding initially, and
Ashish.
Yeah, Satish.
Earlier, when the bleeding comes,
Yeah.
you had to expedite your procedure fast,
Yes. No, correct. So that was a big learning lesson.
Now
Not
see the huge shell. See this shell around the orbit.
Beautiful. Yeah.
This is the huge one to expose the entire orbital surface now. See that?
Yes.
Yes, the question from Dr. Minesh Jovekar. He's okay. Suppose right now, suppose your lamina is breached and middle rectus is damaged or pulled out. What you will do
Yeah,
right
the
now?
lamina is already gone by the tumor, you
There
know.
was
Middle rectus is
The
degenerative.
damaged.
lamina and the tumor shell was a party wall, you know. And what you see is the periorbita, and wherever the periorbita thinned out, a little bit of the fat projecting. I don't mind that.
His
Right.
question
Hata,
is
hata,
actually
hata.
about the medial rectus injury.
Yeah, medial rectus is, you know, see what is God has given us between the surgeon and the medial rectus, this fat. See that? The fat, this amount of fat, you don't see any muscle anywhere. Do you see any muscle? This fat is there in between.
That is why I don't lose so much fat from my body. Because God has given it for protection.
Protection everywhere.
You should leave it like this because no need to cover this part because as usual we doing.
See now what I am doing? Stiffening.
Yes.
Stiffening. No need. You just stiffen, the fibrosis takes place. See this now, everything going back in the place.
Yes.
You can use cobblator at the orbital interface, no issues.
Yes.
I told you, you have used several times in the brain.
So there's a request from Riyadh. Dr. Naushad is requesting you to explain the landmarks, if possible, the turbinates and
From
everything.
Pakistan?
Riyadh, yeah.
Riyadh.
Riyadh. So the landmarks so far, let me show you at here. See, this is the nasal cavity, this is inferior turbinate.
Yes.
Behind is the coina. Hata it. Let me remove this. See, all these surgeries require patience, you know.
Yes.
Preeti is seeing this since afternoon and he is very much in contact. He is putting some questions which we are giving answer on my level. He is right now, last comment is that Sir Satish always do something heroic, proud of you.
So this is nothing heroic here. You have to struggle to remove this shell.
Since 4 p.m. he is with us.
No. So you have to all the time struggle. See now the field is good.
Yeah.
The landmarks are in picture. So the one who was asking for the landmarks at this point of time, this is my coina. This is inferior turbinate, middle meatal antrostomy. The entire shell is removed from the lateral wall here. This is the orbit where the entire shell has been removed. And this is the dura. Now see the pulsations of the dura. Can you?
Yes.
Now your question about the CSF leak. Yeah, straight there.
Yes.
Can you give CSF leak here? One can easily.
Middle shell is left, right.
Yes.
See this? This is anterethmoidal artery here. See this?
Yes.
Cobblator.
It's
Yes.
bleeding actually.
Beautiful.
That is the.
People should take a screenshot of this.
Yeah. So this is the.
That was the
answer to all
feeding.
the questions.
That was the feeding
They were
vessel.
asking about anterior.
See, that was the feeding vessel which I have coagulated. Now, with the
Kusum, dekh lena. That
Right
there's
hander.
your anti-ethmoidal.
we'll coagulate it further. Don't worry. See now the dura. See how the anterethmoidal is passing from the orbit. See this? All open. All open
Yes.
to enter inside the dura, and this is dura. See, this is dura. This one. Hey, what you say?
Yes. Yes.
This is all dura. You have to be very, very gentle here. And see this tumor at the dural interface. Can you see this? Shell. I am bringing it out with a movement which is directing out away from the skull base. You know, I am at 0 degree and now will soon change to 70 to the most important area now, that is frontal.
So Satish, we are shell shocked to see your incredible skill.
Pardon, pack both. This is
So Doctor,
pulsation.
so
Pulsation.
Dr. Arshad from Bihar and few more ENTs are of the same opinion that like in angiofibroma, you would first take care of the feeding vessel. Then why not in this case?
In this case, the feeding vessels, the anterior and posterior model,
Inside.
they belong to the internal carotid system, first of all. And secondly, they enter the tumor from the deeper aspect. Being belonging to the
Yes.
internal carotid system, you cannot embolize. You know, these are
Yes.
branches of ophthalmic artery. If you do anything, try to do anything, the patient can be blind. So don't even try to think of that. See now everything below down, the pulsation of the dura. See how this tumor was. See this was skull base and this was orbit. Everything decent all around. Can you see?
Yes.
And now lastly the upper part towards the frontal. This is the last shell here. See that?
So much part is exposed. Will you cover this dura or because of so much so much area is exposed?
No, no, nothing will happen. It will the fibrosis will take place. You don't need to do anything.
So all the boundaries that they teach you to respect in a routine phase is what he is blasting. Rather, the
Yes.
tumor has blasted, so he's removing. Incredible visual.
So now the picture is, you see the picture is so good here. Like Ashish said, all the boundaries of the face. The orbit, skull base, anterior ethmoidal artery, all three in one view. All decent. For that matter, everything decent. See that?
Yes.
See this decent pulsation of the brain.
Yes.
Now give me 70 degree. Now I'm on to the last part.
Sir, if
And
this lesion is involving maxillary sinus, then what will be your approach? Yash Lavana from
pardon?
Surat. If this lesion involves maxillary sinus, then what will be your approach?
The same one. I would, if I have to go lateral in the maxillary, you can extend accordingly. See, you have to go as the shell dictates, you know.
Folks, watch this step.
Dhira, dhira.
This is incredible. What he's just doing now.
See, this is the shell here.
He's going to the frontal.
Yeah, see, this is pushed inside the frontal.
Yeah,
It's something like
incredible.
pushed inside, packed inside.
It's the coon seeker or ballpoint.
Yeah, yeah, coon seeker.
Ah, lovely. It's coming en bloc. Oh, lovely.
See,
Fantastic.
that is the surface, the growing
Yes.
edge. It was pushed inside, you know.
Yes.
So probably I have to drill out.
Nothing. No drill out. I think it's come out clean with the mucosa.
I was,
intact.
yeah. Otherwise, I had planned a drill out in case, you know, the opening is narrow.
Yeah. If it was.
Yeah. Many times you have to.
Yeah, really.
So we can take question regarding JNA if anybody has.
So no, I think we've answered all the questions.
और फॉक्स को बुलाओ, उसको बोलना, फोन करना. Yeah, Paramita, any question?
No, sir.
रुक जा. See the
Is it
pulsation of the dura. See this pulsation. And that is the frontal above. So this is simple pulsation. There is no leak there. For that matter. See this?
Yes.
And that is the frontal up there. Any doubts, any question regarding this? Now to me it is complete removal.
It's a great demonstration.
Can you see?
Wonderful, Satish.
Yes.
Excellent demonstration. Excellent.
Thank you, boss. Just pack for 5 minutes. So we'll just pack for 5 minutes.
Yes, sir.
Loose pack.
Sir, Umesh Torne from Nasik is asking what are the chances of
Hata.
empty nose syndrome?
Pardon? Empty
What are
nose.
the, yes, sir.
Nothing, boss. As long as mucosa is intact, patient is not immunocompromised, nothing will happen, and you have to obviously follow with the douching, post-op douching. And it does.
What was the question? We didn't understand.
Empty nose syndrome.
Empty nose. Oh.
Chances of empty nose.
Lot of people ask about atrophic
First
rhino.
of all, I think one-sided you don't really get that. Empty nose is when you do bilateral.
Yes.
Is that not right, Satish?
Yeah, it can happen one side also. Empty nose is, it's not a syndrome. Don't call it syndrome. Syndrome is like so many things included. A patient may have, I would call it most appropriately as a little excessive crusting, you can say. So if you thoroughly irrigate, either low audio, if you thoroughly irrigate, this excessive crusting can be taken care of. Simple.
No, they are talking about a year down the line. Whether taking away so much of the normal structures, whether it can cause a physiological problem.
No,
That's probably what
not really. I have seen
don't
those
think so.
patients.
I think, yeah.
I have followed them for years. After dankers and so many things, nothing happens ultimately, I tell you. They do so well. The initial, the douching has a big role. Initial douching has a big role. So now, guys, it is 8:45, and the most important case now is a carotid body tumor.
Many people are waiting for this thing.
And you are going to repair the carotid with a saphenous vein.
Most likely will reconstruct either with a saphenous vein or polytetrafluoroethylene tube.
What do you want to eat for breakfast?
Huh?
What do you want to eat for breakfast?
Sir, will you consider a blanket graft over the dural defect? The dural.
No. The mucosa will come over.
Okay, nothing to do with it.
You don't need. Now, you connect karo the laptop. So now this patient.
Sir, for JNA, 1 minute. So one last question.
Yes,
for
please.
JNA, any hormonal treatment will you believe on any?
I've already mentioned flutamide is one drug, anti-androgen. You can use it in certain situations. Pre-operatively, obviously in the receptors are in post-pubertal patients. So you can use pre-op to reduce the tumor bulk. It can reduce up to 15% in certain series, it has been mentioned. And to buy some time as well. Like you have a tumor and you are, because of some reason, you are the patient, whatever you have planned to operate in December. And the tumor is close to the critical structures. A tumor has already given pressure on it, you can reduce by means of flutamide. So just to buy time. And post-op also, when you have an unresectable recurrence, then you have to use all this. Along with the radiation, you can use flutamide, you may use anti-estrogen, tamoxifen, glucocorticoid, VEGF receptor blocker, bevacizumab, vincristine has a role. So many, all these are having an adjuvant role in those situations when nothing can be done. So these are not first line treatment for that matter.
Okay.
What was the setting you have operated while doing this in orbit?
Mila pani. Huh? Pardon?
Operator setting in orbit. You were
same boss. No issues because it is constantly irrigated with a copious saline. You don't need to bother about. So this next patient is a male above 50, had a unilateral cervical swelling in the upper part of the neck. On palpation, there was some, pulsation over it. So he got some scan done. Fox kya bola? So he got some scan done, a plain CT scan, and there was something in the region of the carotid bifurcation. But since it was a plain CT, you cannot make out much. So we got the CT angiogram done, our investigation of choice. Are you getting the CT angiogram picture there?
We're getting CT picture. Yeah, we're getting.
Yes, yes.
Are you
Yeah, we're getting it.
Yes, yes. We are getting it.
getting it?
Yeah, yeah.
Yes, yes. We are getting
Okay.
it.
So this is the CT angiogram picture. Let me tell you. This is the jugular vein on both sides, and this is the common carotid in the lower part of the neck. This is airway. And this was thyroid. This is the cartilage, thyroid cartilage coming up, you see. And keep an eye on the carotid now. Okay? Can you see the carotid here?
Yeah, yeah.
Where my cursor is? Where my cursor is? Hello?
We can see very clearly.
Yes, yes. We
This is
can
carotid. Can you see this carotid or not?
Yeah, yeah, we
Yes,
can
yes.
see it.
Now I am moving up. Moving up. Moving up. Now see, it is dividing into two. Can you see this?
Yeah, yeah.
Yes,
This is internal, this is external. Can you?
yes,
And see this tumor mass. Can you see this tumor mass?
Yes.
Between both the carotids, most
Yes.
laterally is the external and most medially is the internal push medially, external push laterally, and the jugular vein posterolaterally. Okay?
yes,
And this tumor is almost circumferentially encasing the carotid. Can you see?
yes, yes,
Internal.
yes,
And see, this is the tumor. I am going up. And now the next thing I want to know, to show you. Let me show in all planes first. Then we'll come to vascularity.
yes,
See in all planes. I am coming in the coronal first. You see in the coronal. See this? Can you see this lesion in the coronal?
yes,
Now see, this is common carotid here below.
yes,
Going up, this is giving the internal one, and see the proximity of the tumor to the internal carotid pressing on it. Can you see very clear?
yes,
And as you go up, see this, that is the internal carotid going in the carotid canal up, skull base. Now the second thing to be seen on coronal scan is the distance from the skull base. That is most important. It is one of the decisive point for choosing the approach. You know, this distance from the skull base, let me measure it. Let me measure it. 4.3 centimeter. Can you see?
yes,
What does it mean? You can remove by the transcervical approach and you can get the upper stump of the carotid for reconstruction in case required.
okay,
Got my point?
yes,
If this
yes,
is within 2 centimeter, if this tumor is rising up within 2 centimeter of the skull base, you cannot get the upper stump for reconstruction. And that can be a disaster. In case you injure the carotid, how would you reconstruct? So this parameter is very important in, in assessment of these tumors and planning the surgical approach, the upper extent and the distance from the skull base. You know, the Chamberlain earlier classified the tumor into 3 categories.
reclassification.
Type 1 with a contact, with a tumor, minimal contact with the vessel, with good plane. Type 2 with the involvement of the adventitia. Type 3, further involvement. Some people classified like type 1, up to 180 degree involvement between the vessels. Type 2, 180 to 270 degree, and type 3, beyond 270 degree. But
So
none
this
of these criteria explain the upper limit of the tumor, which is decisive. So this classification system lacks all this. So a lot of people mention it as a Samlin type 4 if this is within 2 centimeter of the skull base, because then the approach totally changes. Or for that matter, if it invades the skull base, the jugular foramen, carotid foramen, whatever above, it invades the petrous bone, then you have to extend this transcervical approach with the infratemporal fossa A, like we did in the glomus.
Okay,
Okay, so that the surgical approach changes according to the extent of the tumor. So that is the value of the coronal.
Okay, but if we go according to Shamlin's classification, this is type 3.
Yeah, this is, let us see in the sagittal plane first. Okay?
Okay,
Then we'll see.
okay.
Now, coming to the sagittal part, see this. Now see the tumor contained within, this is internal carotid here,
Yes,
this is common carotid, and this is external carotid. Can you see here? This tumor,
yes, yes,
what will you call it? This is completely, between the, this thing and the circumference of the carotid, is quite significantly involved. See that?
Yes.
And that is the upper extent
yes.
of the tumor. That is the upper extent. Now, the next thing to be seen is the vascularity to the tumor. Again, why it is frightening us? Vascularity, obviously. Are local laga diya. Why it is frightening us? Microscope le le. Bada. The vascularity, because the tumor is adherent to the common carotid, internal carotid, and you cannot afford to, lacerate the vessel. It can have implications on the cerebral blood flow. Patient can get a stroke. So many things. And this tumor has a tendency to invade the adventitia. Yes. So, the next thing we need to know about the vascularity. Now see, on the axial section back, like we saw the CT angiogram in the previous case, angiofibroma. Now look at the CT angiogram. This is external carotid. First of all, this is internal carotid. Generally, it doesn't give any branch. It may be minimal capillaries, maybe arising from the internal common, otherwise it doesn't give. So let us see, first focus on the internal, if it is giving any branch. You don't see any visible vessel from the internal. Can you see? All the way. Doesn't.
Yes.
Now coming to the external carotid. See this. This is external carotid now separating. Keep an eye.
Yes.
Keep an eye. What it is giving. Keep an eye. See this branch arising from it. Now go up, go up, go up, and now see the number of branches. See this is arising from it. Now see another branch arising from it. Can you see here?
Yes.
Here, and see here again. So many branches arising from it. See again, so many branches. Could you see?
Yes.
See 4 or 5 big vessels arising from the external carotid.
Yes.
Now I will keep an eye on the external carotid which is going behind the mandible to divide into internal maxillary and see this is internal maxillary and this is superficial temporal. So the main vascularity to this tumor is coming from the external carotid branches. Anybody for the theoretical interest wanting to know which branch is this, you can track each and every branch. Like for example, we must know all the branches of external carotid for that matter. Let me show you. Yeah. Now see, the first branch which is arising here, see now where it is going. Track each and every branch. Track each and every branch, and this is going to the thyroid. See this is the thyroid gland. This is superior thyroid. Now if I go up again, that is the lower branch. That I go again, this branch emerging. Now see where it is going in the lingual. Can you see this?
Yes.
In the tongue. This branch, it is going lateral to the mandible. This is facial. So we need to know which branches are involved and how they are emerging from the external carotid, and which of them and how many branches are supplying to the tumor. So this tumor is supplied by multiple branches of external carotid. See here again. See the multiple branches emerging from the external carotid supplying the tumor. Agreed? So our goal of surgery now, lot of people again like angiofibroma, same concept, they will embolize. Again the same implication. If you embolize, again there is a risk of going this embolized material to the cerebral circulation to give complications in the intracranial complications, cost, so many things. The beauty is once you know which vessels are supplying, you are doing an open surgery. We'll take those vessels in control, and for that matter, I will take this external carotid in control and rotate my specimen and separate from the internal and get away. Now, in order to do that, because this tumor is in, see the wall of the internal carotid is in entirely in proximity or in contact with the tumor. This must be involving the adventitia of the internal carotid. So now the plan number one, in case this tumor is significantly invading the carotid artery, I should have a plan to reconstruct the carotid. And the best we have done several times is to use saphenous vein, number one. Number two, we should have a complete information of the cross flow at the level of circle of Willis. In case this artery is accidentally blocked, to prevent stroke, the circle of Willis should be intact. So let me show you. I saw this patient circle of Willis. See, this is vertebral artery. This is internal carotid. Can you see this?
Yes.
I am going up. This is jugular. This is internal carotid. Now entering into the temporal bone. See this. This is vertical petrous. Now becoming horizontal petrous. See this. Now
Yes.
going up, becoming the foramen lacerum. Now
Yes.
becoming the cavernous. See this.
Yes. Yes.
Cavernous. This is clinoidal segment, and now this is intracranial. And see, this is the middle cerebral branch
Yes.
on this side as well and on this side as well. And
Yes.
both sides, this is anterior cerebral. See this?
Yes.
Anterior cerebral of this side, anterior cerebral of this side, joining and forming the A2. At the same time, we'll go back. This is the basilar from behind. Basilar dividing into posterior cerebral, two posterior cerebral, and both are giving this posterior communicating. See this posterior communicating on both sides.
Yes.
So that's a good cross circulation, and what I can show you here at this point of time, I will show you the MIP image to show the vessels clear, MIP sequence. Now this is the MIP sequence to show the vessels prominent.
So then, did you do any balloon occlusion test, sir?
Yes. So in case you have a doubt about the cross circulation, I told you when the vessel resection is planned, and particularly in carotid body, you never know. See this, by means of all this radiology or clinical, whatever means, the real picture of carotid wall involvement will be seen intraoperatively. And that will be an intraoperative decision. Nothing can tell you before how much the wall is invaded. So you have to be prepared with all these cross flow studies. I told that day that DSA is the gold standard, and with DSA we need to see three parameters. Number one, balloon occlusion test in the hypotensive condition to see the cross flow.
Okay.
You can wait, that can be done under local anesthesia, and patient can be, you can wait for 30 to 40 minutes in case any neurological changes come.
Okay.
You know, the Mario Sanar's classical protocol to see both the anterior and posterior circulation is to do Alcock and Mata's test. In one he blocks the carotid to see the opposite flow, and in the other he blocks the vertebral to see the posterior circulation. The second parameter is to see the venous phase difference. If the cortical filling of the veins, distal veins, on blocking one carotid, if the difference on both sides is more than 2 seconds, can be significant, and you have to be cautious. The patient may have a stroke if you block the vessel. And third is the stump pressure on the opposite side after the blockage, the flow coming from the opposite side, and you block with a balloon on one side, and beyond the balloon if you see the pressure of the blood which is coming from the opposite side, if it is more than 2/3 of the systolic pressure, that means it is a good cross flow from the opposite side.
Okay.
So these are three parameters we should take into consideration all the time to see the flow studies and see how the good anterior and posterior communicating vessels on both sides to give him a good
Okay.
circle of release.
Okay. So what about the malignant potentials of these tumors?
Up to 5%.
Okay.
And you can gauge, you can have a good idea pre-op with narrowing of the vessel on the radiology, with significant superior extension, but malignancy cannot be confirmed histologically. The
Yes.
confirmed criteria to declare malignancy is metastasis, either to the lymph nodes, or distant metastasis. So in all these cases, when you, like I will show you once you work on the tumor, if there are lymph nodes in the vicinity, you must send them for frozen section.
Okay.
If they turn out to carry the carotid body tumor, paraganglioma, then you have to do a formal neck dissection and if required radiation.
Okay. And
But
so
no
what about the
histological
cranial
criteria of
nerve?
malignancy. What?
What about the cranial nerve involvement, sir?
Yes. The second important thing in these tumors is the cranial nerve. And many a time they present with cranial nerve palsy. You know,
Yes.
because of the
Yes, sir.
expansion of the tumor in that
Yes.
region in the carotid sheath, many a time this tumor present with palsy of the 10th nerve, 12th nerve, whatever. So the cranial
Yes.
nerve palsy many a times is the presentation of these tumors.
Yes,
So
sir.
the vascularity and
even
what?
yes. And so even post-op complications we can have of hypoglossal and vagus. So we
Yes,
will take consent accordingly. We will take-
yes, I will show you once we begin the exposure. We will first expose the hypoglossal nerve
Okay.
and we'll separate it. In large tumors, it is difficult to save the hypoglossal. That is
Okay.
first cranial nerve which goes. Secondly, the vagus below,
Yes.
the spinal accessory behind, and above we have to expose the upper stump. That we have to secure in the initial period. So in case in unfortunate situation we need to do any reconstruction, we should be fully prepared to do that. Sometimes in the more superior extension, you are not able to catch the upper end. What you can do is sort of what we call it vertical, mandibular osteotomy. That is vertical segment osteotomy of the mandible, wherein a small segment of the mandible, from the mandibular notch to the angle of mandible, if you draw a line, that part of vertebral ramus osteotomy, VRO, we call this procedure VRO, you do a small segment vertical osteotomy, you can mobilize that segment behind and you can have a whole huge access right up to the carotid foramen. So there are many maneuvers. I will show in this tumor also to get superior access, like you can divide the digastric to go up. Then as you go up, still you don't find the upper segment. You can divide the styloid process and all the muscles of the styloid to go further up to get the upper stump of the internal carotid.
Okay.
So those are the maneuvers to enhance the superior exposure.
Okay.
We should be able to do that.
So, sir, this patient, does this patient have any cranial nerve involvement right
Not
now?
really, not really,
Preoperatively?
not really,
Okay. Okay.
not really.
Okay.
Satish, just one question from one of the persons asked me was that is there a wait and rescan policy in carotid body tumors also?
What, Vegas?
Wait and rescan. See how if they are growing and observe them over a period of time.
Yes, that is a strategy because they are slow growing, particularly in elderly patient. In
Right.
elderly patient, giving a cranial nerve palsy is something you have to avoid.
Okay.
And handling this tumor can lead to cranial nerve palsies. Even if you don't damage them directly, though you have to be very cautious. So in young patient, obviously straight away, whether it is giving symptoms or not, you have to operate because they have a huge it depends on the life expectancy. So in
Okay.
those having life expectancy of more than 25 years should be operated. Rather than
So there have been
waiting and allow the tumor to large become large and involve more segment of the carotid, making your life more difficult and all that, you should operate in as soon as this tumor is diagnosed in the young patients. In elderly, you can watch. About 65, 70, you can wait and watch. In case it gives symptoms, then you have to take a call of something like radiation, which can contain the growth of the tumor further. So those who have a less life expectancy, you can take that call of radiation. Otherwise, surgery is the only answer.
Okay.
Okay. And so,
And
what about in many studies I've gone through that there have been cerebrovascular accidents intraoperatively,
Yes,
cerebrovascular complications. So,
yes,
what is your experience
yes,
about this?
that can happen with the manipulation of the internal carotid, common carotid. In spite of the vessel completely preserved, that can happen. And the vessel may go in a spasm, may lead to a thrombus, thromboembolism. So many things can happen with the handling. So you have to be cautious. We keep on spraying xylocan, we keep on spraying piperine to prevent vessel going into spasm. And that is the only thing you can do. But the gentle handling of the carotid at its wall is the required thing to prevent all these complications.
and what your protocol for bilateral carotid tumor? Any different? Like
Yes, out of all head neck paraganglioma, this is the most common complication to have a bilateral carotid body tumor. Many a times you have come across.
yeah.
So then you have to take a call according to the age of the patient, size of the tumor. So first you have to remove the site wherein you can safely remove without, endangering the carotid, this lower cranial nerves.
Yeah.
The side where you are more confident without damaging the cranial nerves, you can remove, you have to take first. Like we have done several times, that side we have removed first, and a week after we did the opposite side, like that.
Okay. You will do it in stage.
Yes, but bilateral in tumors, if you do the second side can be dangerous sometimes because you take away the baroreceptor, and the baroreceptor deprivation syndrome can lead the patient, can make the patient hypertensive.
Yeah.
So the opposite side you have to be careful.
So, Dr. Dheeraj from Mohali is asking what is the role of heparin preoperatively or intraoperatively?
Yes. Ideally, when you are dealing with a carotid, particularly you are reconstructing, obviously you have to give a bolus of heparin. Some people even, they give, when they ligate the external carotid, they give a bolus of heparin to prevent thromboembolism. So always to give a low dose heparin to prevent thromboembolism, and that doesn't hamper or give any conditions like uncontrolled hemorrhage or anything. That is very safe.
Okay, so and so to prevent carotid artery spasm, any prevention for carotid
Piperine,
artery spasm? Tushar?
xylocan, piperine, proper handling.
Oh, okay, okay, sir. So I think you can move with the start
Yeah,
with the
with
surgery.
surgical part.
We can take up questions.
Okay. So we'll discuss the genetic aspects also later.
Yes, sir.
So, and we can carry on, take on question during surgery as well. So
Yes.
we'll be doing, since it has a distance of over 4 centimeters from the skull base,
Yes.
so this is a tumor for the transcervical approach, and we'll take additional superior exposure as needed to expose the upper stump of the carotid. Okay? And
Okay.
with having done such cases, my gut feeling is we'll be able to preserve the carotid without needing any reconstruction. But we are all set to reconstruct the carotid in any given, untoward situation today. Okay?
Satish, do you have a vascular surgeon with you along when you're
We
doing
always
this?
have a vascular surgeon with us, and I will introduce him.
Okay.
So he's amazing guy, and in case the saphenous reconstruction is needed, he will reconstruct in less than 10 minutes.
Okay.
And I learned a lot of things from him, particularly, in thyroid surgeries, we get a lot of retrosternal tumor. So I learned the sternotomy from him. And now we are doing sternotomy on our own. We are opening the thorax on our own. And he is always as a backup, you call me if you find any problem. So he has taught us so many things, handling the vessels, suturing the vessels. Having learned from him, we have, many a time dealt with suturing the carotid and all this. simply from him. So I will introduce my dear friend Dr. Sanjeev during surgery. And in case the reconstruction is required, will it will be a treat to watch him how he reconstructs. Any
We wish
questions?
that it should not happen, but theoretically we will like to how he does it. We want to see it after
Yeah,
the
yeah.
case.
We'll explain. So he uses saphenous vein. So in case it deemed necessary during surgery, you find that you need a reconstruction. Meantime, I am operating above. He would go down and take the saphenous as a graft.
Okay, okay, okay.
Then we put a bulldog clamp on both sides. Put bulldog on both sides and put a carotid shunt. I will show you the carotid shunt we have. Carotid
Okay,
shunt means it is a shunt. One end we insert in the common carotid, one end in the internal carotid, and we ligate from outside with a umbilical tape. So the blood flow remains, uh, you know, continuing to the brain without any interruption, and you have ample of time to reconstruct. Whatever time you want to take, it's all yours. Because blood flow is going to the brain, there is no question of ischemia. So the carotid stent, I will show you in case needed. Otherwise also I will open and show that. That is sterilized. So the carotid stent, umbilical tape, saphenous vein, and the fourth thing is a PTFE. I told you the polyfluorotetraethylene is a material by means of which you can quickly make the shunt from the common to the internal carotid. So once you plan an excision, what all you can do is put one bulldog above, put one bulldog below, take a scissors, cut the common carotid below and cut the internal carotid below and remove the tumor en bloc. In no time, in 2 minutes time. Once you are resecting, there is no wastage of time. And then put a carotid shunt and reconstruct and take your time. But that can be done like the way he does. He'll finish in less than 10 minutes. Okay, do we go ahead?
yes,
Yes,
sure.
sir.
So in next few minutes, we'll be back with the intraoperative picture that I'll be showing to the microscope we always use, and that's a good tool to demonstrate as well. Okay?
Yes, sir.
Yeah.
Folks.
What are the basic means hematological investigation you ask for this disease? Hello.
I think he's gone to get washed. Do we have Dr. Ashish Bhumkar here? No.
So next this Sunday we are going for 6 hours, 6 to 7 hour dissection on the facial nerve. Again, this is again one more announcement. So first 3 hours on cadaver, and then next 3 to 4 hours on surgery. So it will be a good treat for all of you. And next would be the on head and neck, benign lesion of head and neck. Then next Sunday would be the stapes, and hope so. I think all the things goes on like this. It's a for all the viewers who are here. It's a team actually, and we all are doing the discussion. And Satish is operating. We are taking all the questions from all around, and sometimes because I think till now in last 7 series we have taken almost to 4,000 questions being received from all of us, and we have discussed all the questions. And one Dr. Ipsit from Sambalpur, I think he has written something. It doesn't look nice on this platform regarding the moderators, because nobody laughed on anybody's questions, and we were just some half an hour something must have happened. Nobody laughed on any other question, and we all the question we taken very well by all of us.
Yeah?
And it is given to Dr. Satish, and from all the worldwide we have a list over there. So suppose anything goes, then don't write on this regarding the team. It's a teamwork. So Mr. Ipsit for Sambalpur, please take all of you, all the viewers. It's a teamwork, and we try to take all the questions and we discuss with all of you all like that. So don't feel bad suppose something goes, nobody takes the question or
इसको नीचे कर सकते
somebody laugh on this thing, then nothing to worry. So you are other part of team. You put the questions and in a healthy way. Anybody, any questions, Pamita? Dr. Rajan Bhagat, how many questions, how many this carotid tumor you have done till now? Because you do lots of this head and neck and
in 25 years, 2.
अरे वो एक्सटर्नल कैमरा लाना
2.
Sir,
can
okay,
you
okay.
hear us? Satish sir,
yes
can you hear us?
yes now
Yes. Sir, any particular reason for using saphenous vein? Dr. Sanjeev Kumar from Delhi is asking.
any particular region
Yeah, reason. Why saphenous vein?
saphenous vein first of all the donor side morbidity is less and it can sustain the flow of the high flow vessel very well as a lot of it's been a I would say the commonest vein to be used for this. Particularly earlier people used to use the femoral vein as well, but the saphenous is with hardly any morbidity at the donor site. You know, everything is important.
Okay.
Now, can you bring
Dr.
that?
Kusum Patidar is asking an important question. When will you operate these cases?
When will you?
Operate these cases.
When means?
Symptoms, yeah. What
With symptoms, when will you take these patients for surgery?
See, carotid body tumor is a surgical entity by and large. We have already discussed, except the elderly patient, this is the surgical indication. You know, except the elderly patients.
We
Yeah,
should
can you bring the external camera meantime? Idhar lao. See this external part I will show with the external camera, then we will move into the microscope, okay? Just in a minute's time he is bringing, idhar lao, piche.
So what is the protocol? Means you give instructions to your protocols to anesthetic while handling these cases.
Yeah, anesthesia protocol is also very important.
Yeah.
Though these are non-functioning paragangliomas,
Yeah.
but yes, still the manipulation of the carotid may result in bradycardia and other issues. So they should be all the time alert, handling such issues in the change in the pulse and BP and all that. And they always keep a cover of the beta blockers, alpha blocker. I don't know what all they use, but yes, they are also alert with handling such cases. So this tumor, as I told you, is not going very high up.
Yeah.
We should not be hopefully needing any big maneuvers to go high up.
Zoom out if possible.
Yeah. This skin part I was showing and now I will show. Now it's good?
Focus.
Yeah, I will focus.
Yeah, now it's okay. Little bit focus is required.
अभी ये माइक्रोस्कोप से करा तो लगा भाई ऊपर तो लगा दो तीन लगा ऊपर So are you getting the microscopic picture now?
Yeah, we are getting.
Yes,
Better?
Yes.
So this is the minimal magnification I can give for that matter. See the surface of the sternomastoid?
Yes. On the greater auricular is seen.
Yeah, very clear.
Greater auricular is very clearly seen.
Yes. चला जा हाँ और कर ऊपर This is how I am entering into this triangle at the anterior border of Sternomastoid.
Hmm.
And see, I took this incision little intentionally down so that we can expose the length of the common carotid as well. You know,
Observe.
in head neck surgeries, I don't believe in compromising the exposure.
Yeah, yeah.
That is the commonest cause of complication.
Sir, Satish sir,
Yes, please.
can you explain us the incision once again? The landmark and the incision
Yeah, this
again.
is a regular, upper cervical incision, mid cervical in the crease, in the neck crease, horizontal incision. Nothing great. Yeah, and see this muscle above? Can you see the
Yeah.
digastric?
Diagnostic, very good.
Yes.
Yeah. In case I need a superior exposure, the first thing I'll cut to expose above is going to be the digastric. Okay? Then above the styloid process and the complex muscles. I am a cautery person, do everything with the cautery. We have a habit of doing neck dissection faster with the cautery. I remember at Pachori Boss place last time we did a commando in 1.5 hours, skin to skin.
Yes, yes. 40 minutes, in fact. 40 minutes plus 40 minutes.
Now see this nerve, number 1. Can you see this horizontal nerve?
Yes.
Yes.
This is hypoglossal.
Yes.
And the tumor is underneath this. This is the tumor underneath. Okay?
Yes.
I hope the picture is good.
Wonderful, wonderful.
So that's the beauty of microscope. So the first thing to secure is to identify this hypoglossal, and we'll secure it as well. Hey, final. See, this is the ANSA. Can you see?
Yeah, yeah, very clear.
This has an immense value in the facial nerve reconstruction also. Many a times we use in, the reconstruction of the marginal mandibular branch for non-selective reinnervation of the recurrent laryngeal nerve. This is ANSA. Now behind,
Yes.
see this vein?
Yeah.
This vein behind should be, this is internal jugular vein.
That is very
Yeah,
nice.
bit thicker one.
See that? And this vein joining the internal jugular here is the common facial. See this?
Yes. Yes.
Which I will divide. Quick. See, on the non-critical areas, you can go fast saving time, so you can concentrate more on the critical areas.
Yes.
One, सोए मत. Funny. So this is something like इसको नीचे लगाना पड़ेगा स्विच रुक 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 lower part little bit more.
Yeah.
Yeah, that is at the interior border of the the lower limit ideally when you really want to expose the common carotid should be the omohyoid. See the omohyoid? See the omohyoid coming from here?
Yeah. Middle.
That should be the lower limit. And that is how the supraomoid dissection is named. The commonest neck dissection in our practice is SOSD.
In fact, I think most of the people, in fact, I would say this is the commonest one all around.
Pardon?
Still, it is the commonest neck dissection, I think, present.
Yeah. See this little bit of the lymphatic tissue you see here?
Yeah, biopsy.
I told you, yes. Rukna. Yes. Just for sampling, This, छोड़ दे. Yes, भेज दे.
So many doctors are requesting for orientation once again.
Okay, orientation for everyone.
Maybe externally you can
Okay,
just zoom out for some.
Yes, I am working on the left side. This is superior where the digastric is. This is inferior. This is anterior. And this is behind, posterior. Okay? This is, I am operating on the left side. This is lower, inferior area. This is inferior. This is superior where the digastric is. Okay? I hope you are oriented now.
Yes, sir.
Now, this is internal jugular. And now, see this ansa is going up on the carotid sheath, on the lateral wall of the carotid sheath. Can you see this?
Yes.
Yes.
And once I open up the sheath, you will find the common carotid. Can you see? That is common carotid. Very clear?
Yes.
Yeah, very good looking.
Retractor. Okay. No. Wait no. Okay. So we have a good length of the common carotid below. Now we have exposed. Can you see?
Yes.
See the length of the common carotid. And see, this is the tumor. Can you see here?
Yeah, we can see.
Now, posteriorly, one by one, we'll separate all this. Again, to orient you, this is, yes. I hope the picture is good.
Ultimate, very
This
good.
is anterior, this is posterior, this is superior, this is inferior. And in the inferior part, you can see the common carotid. Okay? See, this is common carotid.
Yeah.
Now, first of all, one by one, this is the internal jugular, which I will separate. This gives me a good, access from behind. See, that is my internal carotid going.
Yeah, deep.
Can you see there?
Yeah.
Scissors. Right. See, this is the tumor, this is internal carotid.
Yeah, big tumor.
Very
Very
clear?
expensive. Yeah, yeah.
Yes.
नाउ अब भाई साहब ऊपर चलो इधर यूं हाँ एक और लाओ रिट्रैक्टर यहाँ थोड़ा बड़ा now this is the upper part. I am retracting the digastric first, okay?
Yes.
If it warrants me to go further up, I will not mind it resecting. I will not think twice before that. Let me see the upper condition, if it warrants or not. See my hypoglossal coming from here. See this?
Yes.
And see the ansa hypoglossi emerging from
Yeah,
there.
very, yeah, very clear.
हटा हटा Nope. So I am opening this space above the tumor.
Yeah, yeah.
You know, this is blunt dissection to see if I can get above the tumor with this exposure or not. Okay. Anybody has any doubts, any reason or any, anything about orientation and exposure, let me know. See, my internal carotid is going down. See now? Deeper.
Yes.
See the hypoglossal?
Yes.
See, this is jugular, carotid, jugular, internal jugular here, carotid here, hypoglossal here.
Centralize this, centralize process.
It's a centralizer.
See now.
Now it's okay.
See again, the jugular here, the internal carotid there, vagus. See the vagus, the internal carotid there, and the hypoglossal there. Okay?
Yes.
Very clear or not?
Yeah, yeah, very clear.
Now,
Very clear.
now for a question for the audience, what is this vessel closest to the hypoglossal? चल ले. हाँ. You know, the answer has come from neurosurgeon here. This is occipital. So the vessel running behind, closest to the hypoglossal, is always. अरे काट इसको ढंग से. काट. Is hypoglossal. See that? Sorry, occipital I have divided. Can you see?
Yeah, yeah.
All these are maneuvers to go up, to get superior extent more and more. It looks like my gut feeling will be able to remove it with preserving the carotid. So far. See,
Yeah,
we have not embolized yet. We have not taken any vessel in control yet. I will tell you what we'll do to tackle that bleeding to the tumor. This is tumor surface bleeding. And see the hypoglossal.
Yeah, we can separate it easily, I think.
See the hypoglossal.
Yeah, yeah.
And that is the internal carotid going. See this? Eh? Yes. Yeah, so you have to use cautery close to the nerve very cautiously. If at all, bipolar with irrigation.
Irrigation in the around the cautery, irrigation in the sinus, irrigation in the ear surgery. All these concepts being taught by you. I think most of the people are using it nowadays.
Yes, boss. See all these vessels here. Some of the tributaries of the, internal jugular.
Yeah.
You saw the same dissection in the, most of the part of it in the glomus case also.
Yeah, almost.
इतना मत खींच इसको जुगलर को यार इतना see this is the internal jugular going up.
Wait, that was from up actually, from the mastoids part.
See now for your reference here, this is internal carotid,
Yes.
this is internal jugular here, and this is hypoglossal.
Okay.
Yes.
Kar. That is the vagus. See, that is the vagus.
Yes.
Can you see?
Yeah, we can see.
If I turn this tumor around, see deep to this is vagus.
Yeah, we can see.
So everything is important. We have to preserve all these cranial nerves. ये कहाँ से आ रहा है? Now see the tumor. So now again, this is the upper limit of the tumor going to be here, and I can see my carotid above that. See that?
Yeah.
You can very well control this. See this carotid above.
Yes.
So in case needed, we have an ample of space there. See the carotid above?
Yes.
Yeah, we can see.
See the upper stump? So good.
So it's little dark.
Yes, center. छोड़ना,
Extra
हटा.
sides.
I will show you again. This is tumor bleeding. रुक जा. छोड़, ढील छोड़. Whoop. See what a tool bipolar is.
Yes. Good bipolar.
Now what I was showing you, the upper stump of the carotid, See this upper stump. This is the carotid going.
Yeah.
And that is the upper stump of the carotid. See this. So clear.
Yeah.
That is the upper stump of the carotid. Can you see the entire?
Yeah, very clear.
So in case we need, we have. This is to ensure that we have a control above for anastomosis. Okay? Agreed?
Yes.
Now, this is the tumor and the relationship with the carotid,
Dr. Satish, Dr. Faida Wadia has joined us now.
Good evening, madam.
Madam, please unmute yourself.
Good evening, Satish, and it's a pleasure to watch you operate as always.
Madam, pleasure to have you. I am one of your dedicated student.
Oh my
Believe me.
God.
Good evening, madam.
Good evening, Parim.
See this internal carotid? This is the tumor.
Yes, very well seen.
अरे वो लगा ले जरा जाल को छिड़क दे अनुपम को बोला इतना मत खींच उसको इतना मत खींच ये हाँ See now, this is common carotid, this is internal carotid.
Yeah, yeah, yeah.
And I am trying to go subadventitial here. See this? See, this is very important region.
Yeah, yeah, yeah. Most difficult step and most important reason.
See, uncovering the carotid. Mop, mop.
Yes.
ज़्यादा मत खींच. And that is the fork. Pepperoni भी डाल देना एक बार. Yes. This was a xylocan spray, you know.
The 10% or 4%?
10%, 10%.
Yeah.
See, this is external carotid there.
Yes.
Yeah, yeah. Very well.
Many a times we divide the external carotid and rotate the specimen completely. And that is the easiest way to, you know, deal with this tumor. Now I am uncovering the external. Yes, can you see?
Yes.
Yes.
Yes, very clearly.
Both the internal and external carotid in view. Now I will first separate the internal completely to ensure that we are safe. Folks.
Still, for this case, more than 5,000 people are here right now online.
Pardon? I am going fast. You see this?
No, still for this case, more than 5,000 people are logged in right now.
Really? So crazy?
27, 24, yeah.
Oh my God. But grateful to you all. रुक जा गुरु. See now my internal is almost free from the tumor.
Yeah, yeah.
Can you see?
Yes.
All the way. This much of bleeding you don't mind. We don't call it bleeding.
You're playing with carotid like we play with the cholesteatoma.
I told you we'll finish fast. See how that was, the tumor is within the carotid. Idhar kar. Now from the external, you know.
Yeah, yeah.
External, if you find any difficulty in, you know, separating from internal,
Like it.
many a time we just ligate and rotate. Give me. I tell you everyone about the Farida madam. Farida madam is a dedicated head neck surgeon, you know, and she has an amazing experience of the head neck oncology. Besides that, she has a keen interest in other specialties in ENT, particularly endoscopic and all. And she has a huge list of students, including me.
Oh, Satish, you praise me to the sky. I feel embarrassed.
Not really, madam. You have been so modest.
It is a pleasure to watch you operate always.
Thank you, madam.
Madam, put on your video actually. People want to see you also. If possible.
I've been running around the whole day.
Okay.
I'm just.
See?
Yes.
Gently teasing out into the plane.
Yeah, yeah.
So you don't have to frighten all the time with the, you know,
Very true.
name and bleeding and all that. We'll take care of that. Let the bleeder come. We're all set to control that.
Since both the ends are under your vision, it is very, you can say, safe and...
See now, our hypoglossal, my most important was hypoglossal.
Yes, yes.
And the vagus, which we have separated already. See all these tumor branches from the external carotid which I am coagulating.
Yeah, yeah.
ऊपर. Now, इधर से इसको ला, इसको उठा. Now coming craniocaudal. See, my bipolar made my life, you know.
You're handling it very well.
It's going to come out in next now 5-10 minutes. You know.
Yeah, beautiful.
Professor Nishi Sonakya from Jaipur is giving you. She's watching your surgery.
Nishi madam, my
Yes, we can
favorite
join us.
teacher. You know, she has been my favorite teacher in medical college, SMS when I was. Thank you, madam. See now, staying in the plane.
Dr. Manprakash Sharma is also on YouTube.
Oh, sir, pranam.
He's on YouTube actually. So
Sir has been the big inspiration for many, including me.
yeah. Which RT you just cut me? It was just a.
These are all feeders from the external carotid, which one by one I am coagulating, you know. Every time I am working along the, see this, working, see these, all these are feeders.
Yeah.
Which I am coagulating all the time. See the internal is separate now.
Yeah, beautifully done.
And external with these feeders, you know. My both nerves, the ansa and the hypoglossal is separate. And tumor is now dying to be out, you know. Anybody, this is a question. We'll give a prize. Which nerve is this? Horizontal. Fast, quick. No. Now you have given a wrong answer. You will give prize.
Okay, I'm ready.
Negative marking.
Yes.
Anybody? This could be the superior laryngeal.
So thick and so high.
Which runs from deep to carotid. You know. See now the final separation. See everything with done by one instrument. Cut.
Bipolar.
That's it.
Excellent.
My God. First test.
Satish, excellent surgery. Excellent is the word.
Thank you, boss. See both the vessels and the fork. Now see in the end the anatomy.
Very clean dissection, Satish.
Yeah, ultimate.
See, this is digastric above. The vessel, the digastric.
Yeah.
Now, in case you need a superior exposure, I would first divide the digastric. You need further exposure, go above. See, I can feel the styloid process with the muscles arising from it. Divide the styloid muscles all lateral to the great vessels. And by means of dividing this, you can get additional 2 centimeter gain to go above.
Yes,
In case further you need to go up, what I told you, VRO, this is the angle of the mandible.
yes.
And see one thing, this is an important landmark for the Sunday facial nerve course. Can you see something here?
Marginal mandibular actually.
Yes.
Yeah.
See, this point is called as gonian,
Gonian.
the posterior inferior angle of the mandible. And right at the gonian, this branch is crossing, this is marginal mandibular. And this is the landmark we use in our practice. Gonian, you feel the gonian, your marginal mandibular is there. More than 98% of the time. Yes. Okay?
Sir, amazing.
So the carotid body didn't take time. And see, no bleeding, no embolization, no transfusion.
All are
Unbelievable.
And we went
mesmerized.
fast. This is, see this. This is superior laryngeal. This goes there to the thyroid membrane to divide into external and internal. This is the vagus. See this? This superior laryngeal goes up and it is given up from the vagus. See this is from here, deep to carotid. See this?
Yes.
Can you see this? This
I think most
this
of us
now
we
deep
must
to
have seen this first time.
see this now deep to carotid, and see this. It is arising from the inferior vagal ganglion, just below the jugular foramen, and comes down and forward, and to pierce the thyroid membrane, wherein it divides further at the level of the membrane. One goes out as the external laryngeal with the superior thyroid vessels, and one goes inside to supply the mucosa, the supraglottis, internal laryngeal. And the other now, another question for the audience.
Dr. Satish first. Dr. Ali Sheikh give the right answer. Give the right answer. Superior laryngeal. Ali Sheikh. From I think Dr. Ali Sheikh give the right answer. You give the right answer. Superior laryngeal.
Okay, so boss,
Gift from my side.
you have
Gift
to
from
give
my
him a
side.
prize.
Yeah.
Now, boss,
Yes, sir.
Anish boss who won, you saw this now? Now tell me
Yeah.
another answer. What is the nerve just above, deep, just above and parallel to this? Going like this, just above, like this now going just above and parallel to it. If you give right answer, you'll get 3 times prize. If wrong,
Ali Sheikh,
it is cancelled.
Ali Sheikh, you're waiting for your answer.
If wrong, cancelled.
Anybody else?
That is glossopharyngeal. Yes, right, boss. See now, so digastric, below the digastric is the hypoglossal. That you have to remember this anatomy for the facial now, Sunday. I will show the variety of facio-hypoglossal anastomosis. Then the anastomosis with the, this ansa hypoglossi.
Yeah.
Then the carotid and its branches. And see all these medial end, so many branches supplying the tumor. See this? I have simply bipolarized. Okay?
Okay.
And see both the vessels, the internal jugular is here. See, that is internal jugular. We have seen in the glomus case last time.
Yes.
So internal jugular, internal carotid, this is vagus. Okay, the accessories above crossing here. I didn't go above here. Then it is the hypoglossal, the ansa, external, and this is the anterior branch from the, see this carotid, this is most likely superior thyroid. Can you see here? Superior thyroid, can you see?
Yes.
This is superior thyroid artery, see, arising from the external carotid.
Yes.
Then above the next anterior branch is going to be here, just in the vicinity of, this hypoglossal. Below is the lingual artery, and above is the occipital, which we have cauterized behind. And just above is the facial artery, going to be the facial. That is the facial artery you can see anteriorly. Can you see?
Yes, sir.
Yes.
So the lingual at the level of the hypoglossal, facial above, and just behind here we have already ligated this occipital here.
Right.
At the level of the hypoglossal behind. And above, behind another second branch above is going to be the posterior auricular. That's how the anatomy of the neck is so interesting. And one should know is, being ENT surgeon, we do a lot of head and neck work. You must be well versed with. In one of the course, we have planned the anatomy of the neck in the cadaver as well as neck dissections in future. So this is all about, we didn't require any,
Sir, it's amazing.
Thank
You
you.
removed it just as if you would remove a schwannoma, Satish. Beautifully
Yeah,
done.
it's like, for us, it's like you've done some lymph node biopsy, sir. Dr. Amit Rana is also saying the same thing. It's
The
like
same thing happened in Agra. He just removed
And
within 20 minutes.
we had Dr. Sanjeev with us, the vascular surgeon. We didn't, require his help. But to tell you, the kind of vascular reconstructions he does for us is mind-blowing. He can reconstruct many a time in the retrosternal tumors. He has reconstructed brachiocephalic vein, brachiocephalic artery, so many things, the tumor invading the arch of aorta, so many
his
things.
presence is like your moral support.
Yes,
right?
amazing,
Yes,
amazing.
yes.
Thank you.
John,
Any more
John
Sir,
Shadow.
questions?
Wonderful.
glossopharyngeal.
Thank you. Thank you.
Just to acknowledge, glossopharyngeal answer many have given right. Bashir from Dhaka,
John Shadow from Australia.
Vijay, yes,
Answered
Kanwar
correctly?
Singh,
Correct answer?
Dikshit. Yes, yes, many have answered, sir. Dr. Sanjeev Kumar Verma from New Delhi. Many have answered, so.
And you know, our neurosurgeon had answered here in theater. And Farida madam?
Ali Sheikh will get two prizes almost.
Yes.
He's from Andhra Pradesh, Amalapuram. John
Great.
Shadow from Australia. You will get all the things. And who else is
Yes.
there?
Sir,
So
but
much
on a serious note, sir, we are today mesmerized seeing all these three surgeries, bloodless surgeries, all the three cases, and the names sounded so tricky to us, but you made it so simple. We are
And
all really mesmerized, sir.
I'll be happy when everybody watching this webinar will start doing this. That will give me real
that
happiness.
is the.
Believe me, don't get frightened. Few words about Farida madam. Again, her presence always encourages. She has always, treated us like, her
Thank you,
family
Satish.
member,
That's enough.
always encouraging, supporting, whatnot. Thank you, madam. Thank you for being
Oh,
with us.
Satish, it was beautiful. Very well done. Whatever I saw, I really enjoyed. And God bless.
Thank you. Thank you, Rajan boss, for being
Satish,
all the
just a
way.
last word. Just a last word. I think one of the take-home messages for everybody is the pre-operative planning and the detailing that you do prior to surgery. As a surgeon, everybody is very willing to pick up a knife and start operating. But
Very
the
true.
amount of time that you put in pre-operative planning and detailing is commendable and something that I have learned hugely.
Thank you, boss. And it is 10 o'clock, exactly 6 hours now.
Exactly 6 hours.
So, if any questions remaining, otherwise we call it a day.
Yes.
Yeah,
Now
we
I
can call
think
it.
you need rest.
Yeah,
Yes, sir.
I think you need a rest. You
Thank
really
you.
need a
I am
rest.
fine. I am fine for everyone. Tomorrow morning, I am doing a webinar for the Kerala ENT surgeons, 8 o'clock. That is live on Facebook. Something on tips to avoid the surgical tips for sinus surgery and avoiding complications. Thank you. Anybody interested can join us.
Thank you,
Yeah.
sir.
Okay.
Thank you so much, sir.
Thank
Hats
you.
off to you, sir, your efforts. And we will also like to thank Sun Pharma, especially for supporting us.
Obviously. Big thanks
Being
to Sun Pharma.
Yeah.
yes,
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 Verma,
for
good
And you
morning.
all are invited for the Sunday event. You'll get information soon on that dedicated day to facial nerve.
Absolutely.
yes,
Look
Yeah,
forward to it.
6, 7 hours again, Professor Love. I think that would be
Maybe longer.
maybe
yes,
longer.
sir.
It's a
It
huge
will be, you
subject.
can say,
Yes, sir.
strength for everyone. I think we should call for the day. And thank you, Faida Madam, Rajan Sir, as
Yeah.
well. You are the,
Thank you, Rajiv,
Thank
for
you.
inviting me over.
and
Thank you.
Satish, thank you.
Thank you. Thank you,
Thank
Raj.
you,
And
Farida
It was a
ma'am.
pleasure to be with you all.
thank you, ma'am.
Okay.
Thank you, ma'am.
Cheers.
Thank you, sir.
Cheers.
Thank you,
Rajiv.
Dr. Paramita.
Thank you, Parmita.
And
Thank you, Paramita,
Thank you.
for,
Thank you.
she has been the
Thank you,
pillar
sir.
behind the success of all these webinars. The person who has worked behind the
Thank you, sir.
curtain for day and night to make this event successful. And big thanks to Pachori boss. His,
Yeah, Rajiv is
his
really
involvement, his commitment, I've never seen
Yes,
before anywhere.
yes, yes,
absolutely.
really. It
Absolutely.
is.
Thank
Okay.
you,
thank you very
boss.
much.
Bye.
Thank you,
Thank you,
sir.
thank you.
Thank you
Good
so much,
night.
sir.
Good night.
Right.
See you soon again.
Right, boss.
Bye
Good
bye.
night. Thank you.
Bye bye.
Thank you, sir. Bye.